Good morning, everyone. My name is Malti Sachdev, and I represent the variant business for Siemens Healthineers. A warm welcome to all our distinguished panelists, and thank you for everyone who made it here today to discuss this very important topic. Cancer today is world's second most common cause of death, responsible for more than 10 million fatalities every year. And two-thirds of these happen in what we call LMIC today, right? And where there's already issues of limited access, and also there's issue related to diagnosis. WHO actually puts the economic impact of cancer at US dollars 1.16 trillion a year, and this trend is rising. The good news, however, is that innovative medical technology can significantly improve cancer care in these countries. Every dollar invested in improving cancer care in these countries actually pays off many, many times over and above what is invested. Where you live should not determine how you live and whether you live is a very profound and a hard-hitting statement, right? And today what motivates us, drives us, is the inequities which happen worldwide and how we can really address those. So I'm really very happy to have our panelists over here to discuss this very important topic. And I'm sure our deliberations today are going to be extremely critical and would also give us direction in terms of how do we address these inequities in our country. I would like to introduce our panelist here today, Dr. Kanika Sood Sharma. She's the Director of Radiation Oncology at Dharamshila Narayana Hospital, New Delhi, with over 20 years of experience. She specializes in electron therapy, various forms of brachytherapy, and cancer care for the brain, lungs, head and neck, pediatrics, and genitourinary systems. So she brings an extensive experience from treating patients for many, many years. I would like to introduce Raj Gore is the Chief Executive Officer of HCG, India's leading oncology-focused healthcare provider. Raj is a seasoned global professional with over 25 years of cross-functional experience across North America, Asia, and Africa. He's spearheading transformative journey at HCG today to redefine cancer care in India. I would like to introduce Sachin Salim. He's a seasoned health system strategist with over 13 years of experience in global health policy, and public health initiatives across Asia, Africa, and Eastern Europe. I would like to introduce Vineet. Vineet Gupta leads the government affairs functions at Siemens Healthineers India, driving strategic engagement with central and state governments. His work focuses on positioning the organization as a medical technology leader aligned with government's Make in India initiative and expanding access to healthcare infrastructure in the country. So thank you to our panelists for being here today. Before we get into the discussion, I would like to very briefly walk you through some of the aspects around our country, cancer care infrastructure. So if you look at India's cancer care burden today, what is reported is 1.8 million incidents of cancer, but we also believe that the actual incidence numbers are a lot higher. This is projected to reach 2 million new cases by the year 2040, with estimated 1 million deaths. What is challenging here is that in terms of overall infrastructure, we perhaps have only 50% of the infrastructure that's required today. If I look at it from a radiotherapy standpoint, out of 718 districts, only 200 districts have a radiotherapy LINAC today. Taking it forward, if you look at the state-wise penetration of comprehensive cancer care centers, 73% districts in India do not have a cancer care center. I mean, that really shows the gap that we have in terms of access today. If we look at the western states, with 20% of patients, today has 25% of comprehensive cancer centers. However, if you go to the northeastern part of the country and rest of the northern and eastern part of the country, access to care is very, very limited. Moving ahead to cancer screening, while India has a program for breast, cervix, as well as oral cancer, but the utilization of the same is extremely poor. We have less than 5% of patients who avail any form of screening facilities, even though today many primary healthcare centers are equipped to provide this screening. Now, if you look at the map over there, the heat map over there, all the reds show that the screening is very, very poorly utilized. So that is one of the reasons why majority of the cancer cases especially if you look at breast cancer, majority of the cases are diagnosed in stage 3 and stage 4, which is more than 60% of the cases. Likewise, lung cancer, majority of the cancers are diagnosed in stage 3 and stage 4, which is again greater than 75%. So that is the fundamental issue that we are facing today. On one hand, we have issue to diagnostic and treatment facility. On the other hand, people are not availing of the screening facility that's available in the country. Coming to key challenges overall in access to care, less than 30% districts have access to comprehensive cancer centers, so there's a huge gap there. 60% of the radiotherapy equipment is located in urban areas with only 0.4 per million penetration. WHO today requires us to have 1 LINAC per million population. However, in the current scheme of things in India, we have only 0.4 LINAC per million population. Penetration again of PET-CT and other diagnostic equipment is low. And again, from a capacity standpoint, number of medical oncologists, radiation oncologists, and surgical oncologists that are required in the country need to be significantly higher than what we have today. So all this adds on to the challenges in terms of access to care. Now coming to affordability, while the entire Ayushman Bharat scheme has significantly improved access to cancer care treatment for many, many patients compared to what it was before, we still realize that perhaps cancer today needs a dedicated reimbursement program because the scheme today is not able to provide coverage for advanced therapies such as PET-CT, genomics, targeted therapies, etc. And therefore, perhaps what is required is not just the number of people who get access to treatment today, but the qualitative aspects of the treatment also need to be looked at. And even today, 25 to 30% of expenses are made out of pocket by the insured patients. And therefore, perhaps what we need today is a dedicated cancer reimbursement program. Now, if you look at the voice of patients, today, the entire journey of the patient is very disjointed and complicated. There is lack of information. Many patients need to travel long distances. Their waiting times are really long. There's a whole lot of information, but perhaps available in silos. While the patient undergoes treatment with a surgical oncologist in one center, as and when the patient goes for treatment of radiotherapy or chemotherapy, the same set of information is not passed on to the clinician over there. So the entire journey is very disjointed. And as you look at this entire chart, it can be very frustrating for the patient as well as their families. Now, what do we need to address today? If we have to address the cancer burden in India, what we need really is a comprehensive cancer care approach. All the way through the continuum, whether it's screening and early detection, diagnosis and therapy decision, and then all the way through the treatment, whatever treatment the patient requires, and continuing to follow up and survivorship. Survivorship is another area today which is significantly lacking. Many of the patients do not come back to the centers unless they get into a complication again. What we really need is how do we keep connected with those patients and ensure the survivorship aspect, the quality of life aspect, all of these are maintained. And I think what this will require is a shared responsibility between the government, clinicians, thought leaders, the technology partners, as well as the private hospitals, which are treating a whole lot of patients today. So now over to our next part of the discussion with our panelists. So thank you everyone for being here today with us to discuss this very important topic. Dr. Kanika, my first question for you is, in your experience, how critical is early detection in improving patient outcomes, and what barriers do you see today?
So first of all, I think you've made my task very easy because you have presented beautifully the scenario in our country. I think your heat map was showing the story of our country very, very clearly. Early detection is the key. There is nothing new to that. Why is it important to detect early? Because cancer's outcomes are defined by the stage at which you start treatment. Outcomes, by outcomes I mean the survival outcomes. If you just generally see the figures, if you treat patients in stage 1, almost 80 to 90% patients we can cure. But as the stage proceeds and we reach stage 4, less than 5% patients have the likelihood of cure. So stage determines the cure status. At the same time, the amount of treatment which you require also changes stage by stage. Early stages may be treated by a single modality of treatment, so the amount of morbidity or the side effects which the patient might encounter will be lesser. And as you go for the higher stages, we would need to employ almost all modality of treatment: surgery, radiation, chemotherapy, hormone therapy, and that not only increases the morbidity in terms of physical morbidity, but it also has financial toxicity. So definitely early detection is something which we all push, and we really want that should be driving the our programs nowadays. But we face a lot of hurdles, and there are few hurdles where I feel it is not about the lack of facility, it is the mindset as well.
Right.
So firstly, I think what we need to do is we need to normalize this word cancer. When you talk of cancer, as if we are talking of death, people, equate cancer with pain and death, and that is why people avoid talking about cancer. Even if you give good articles in newspapers, people flip those pages, they don't read that. If there is something going on the TV, they will change the channel, because we have put that scare in people's mind. If you remember one movie, we all used to see that Rajesh Khanna's movie, the lymphosarcoma of the intestine, such pain was reflected that it penetrated into the community. So normalize this word. Cancer is also a disease. It is a disease like diabetes. It is a disease like hypertension. You take treatment for diabetes lifelong. It has also its share of problems, end-stage problems. But then people are happy treating diabetes but scared talking of cancer. So we need to normalize, we need to change the mindset. Because people with most educated inclination also feel that it will not happen to me. Right. So they resist screenings. People feel that cancer is something which is genetic. The lack of awareness gives that notion to them, and we know the genetic component is just 2% when you look at the entire basket of cancers. 98% cancers are non-genetic, 40 to 50% are lifestyle induced. So that mindset has to be changed there, that it can happen to anyone. Right. So everyone has to go for screening. So screening, why it hasn't been very effective, why we see that fragmented screening programs, because it is not a mandate, it's a choice. When a person is already a believer that it will not happen to me, they will not go for screening. So two things need to be done about screening. Firstly, we need to, incentivize it somehow. That, if it is in your office, you have to go for screening. It is related to something which gives you a motive to go for it. Of course, it is important. It tells you are healthy. And second thing which needs to be told is that you're not investigating you. It is not that we want to find diseases in your body. We are just worried you might be having something which later on might turn out very harmful. So that again has to be done. So that reinforcement there, and awareness. I think awareness is again something which is lacking. Another thing which came to my mind when I was seeing your slides is also the access. You see, I sometimes go for outreach OPDs to some places which don't have cancer treatments. If I prescribe a PET CT scan, they don't have a PET CT scan in 100 miles. Right. If they want to come to treatment to my city, they have 4.5 hours of travel. That is what an average cancer patient takes to reach to treatment. So the access to diagnostics is also very poor. And this is about the periphery. If you talk of Delhi, if somebody is in the public sector getting investigated, the waiting time for PET CTs is enormous. So that also contributes to delay in diagnosis, delay in referral to the right person. And unfortunately, you had very well reflected, we see almost 60% of women coming to us in stage 3 and beyond of cancer. Lung cancer, which otherwise is the poster boy for oncology, survivals have improved tremendously. Again, we are seeing almost 70 to 80% patients coming to us in stage 3 and 4. Right. So I think a lot needs to be done for screening, and mainly I feel that we have to change the community mindset. There are programs. Our hospital has had a preventive oncology department, which is doing free of cost screening, but people fear to come.
Yeah.
So money is not a concern in some areas. It is the mindset I think we need to work on.
Absolutely. I think very well said. We have to remove this fear from the minds of people that if I go for screening, then something will get diagnosed. I think that taboo has to be removed from the minds of people. And as you very rightly mentioned, I think we have to put it in the minds of people that cancer is also another manageable disease, just like diabetes is today.
Success stories, there are lots of survivors. If they take a lead and they come out with their stories, because mostly people feel motivated by people who have come out of the disease. A lot of celebrities, when they speak about cancers, fortunately Manisha Koirala and even Sonali have come on board. They do come to our survivorship programs, they come to these. So that is also motivating, because they want to see success stories, they want to see people happy. You have to show that there is a cure rate, and of course reinforce the fact that cures happen if you come early.
Absolutely, very well said. Raj, my question to you is from a healthcare provider standpoint, what are the most pressing gaps that you see? And what do you really think we need to do in terms of closing those gaps from a provider standpoint?
So first of all, thank you for having me here, and thank you for being here. As a cancer care provider, as HCG, what is our ultimate objective? Our ultimate objective is to reduce the preventable mortality as much as possible, extend the lifespan of our patients, and add life to those years by improving quality of life. Now, if you look at, we have two challenges. On one end of the spectrum, the cancer incidence is rising at an alarming rate. And on the other hand, as a provider, we don't have enough resources to take care of those patients. So if we have to achieve our objective, we'll have to attack on multiple fronts. And some of the parts were covered in your presentation and were very well articulated by Dr. Kanika. So if I have to put major gaps, first is awareness and prevention. While there is still significant awareness among Indian population about tobacco-related cancers, the other major cancer, whether it's breast, cervical, there is still not enough awareness among Indian population. So if there is no awareness of risk factors, tobacco risk as a risk factor, there is quite awareness, but alcohol, obesity, not enough awareness. So if people are not aware, you're not able to slow down the incidence. So that's number one, with prevention measures. Second is what Dr. Kanika talked about, is screening and diagnosis gap. If you showed the heat map at an India level, less than 1% of India's population is covered under screening programs for most common cancers, which is oral cancer, breast cancer, and cervical cancer. Dr. Kanika spoke about it. 2/3 of cancer patients are diagnosed, in late stages, and that just becomes odds are just against you. Third is access to infra. Your map showed that less than 30% of India's districts have a comprehensive cancer care center. Because most cancer patients are diagnosed at late stage, they need multimodal treatment. And radiation is part of that. And if 30% of India's district have a radiation machine, 70% don't have, then it just, again, makes it difficult for save those lives. Fourth is affordability gap, right? One, unlike all other non-communicable diseases, the interventions are episodal. Here, the treatment goes on. One is multimodal treatment. The treatment goes on for 5 to 6 weeks minimum. And if you need multimodal, then it can go up to a year. The cost, for one episode, cost is 2 to 3 times. And if you have to add immunotherapy, etc., cost can go to 6 to 10 times. But there is another gap, which I call understanding of cancer gap, which creates even more affordability challenges, right? First, I think, if you look at all are public or private insurance. Let's take public insurance. I mean, 20 years ago when I entered this field, only 15% of India's population was covered under any form of insurance. Today, majority, like 52, 53%, is covered under public and private insurance. Public insurance plays a huge role, 32%. Thankfully, now that huge chunk of population can get some treatment through Ayushman Bharat and other state government schemes. But the way schemes or insurance players have, designed these plans are attack the most common procedures from their disbursement ratios, package it, and only target that. In cancer, first you have to diagnose it accurately. It's the advancement in diagnostic that is leading to precise and precise cancer care. You're now categorizing cancers based on underlying genetic mutation. Forget the genomic testing, but most schemes, public schemes, don't cover PET-CT, don't cover biopsies, right? So how does it affect? First, it's out-of-pocket expense. And if you're not diagnosing, using PET scan or using biopsies, and if there is a financial, hurdle in that, if you don't do it, the treatment that you give is pointless, right? Second is either you treat cancer completely and comprehensively, or you might not as well treat it because you can't leave cancer behind, right? So if the insurance, our insurance framework doesn't look at cancer differently than cardiac and neuro, what we're going to do is, this is what is covered and this is what is not covered. So this approach of do whatever you can, whatever you can afford, whatever is the most common, treatment procedure doesn't work for cancer. You must cover it. Otherwise, you're not giving the best chance. And it's unfair to treating doctors to be put in a position to take calls on what can be done and what cannot be done based on what is covered, right? All that adds to the out-of-pocket expense. If 70% of India's districts don't have a cancer care, that means you have to travel to another city. But again, if the treatment is 6 weeks, 8 weeks, 2 months, 3 months, you have to temporarily relocate. So accommodation, food, logistics, loss of income. If the patient is a primary earner or a caregiver is a primary earner, you have to take unpaid leave. All that adds to the cost burden. Combination of all these gaps, what is happening is, if you look at breast and cervical cancer, our mortality to incidence is 20 to 30% higher than US or UK. Large part of it is late detection, okay? But all these create an outcomes gap. We have the best clinicians in the world. They're everywhere in the world, leading, medical advancement. We have comparable infrastructure today. The kind of technology that, Varian has, it doesn't take more than few months anywhere in the world when it's launched to come to India, okay? But in the end, this is about outcomes. And all this creates, gap in what outcomes we are delivering because of things that are not under the control of a doctor. So I think those are the gaps that I think it's a big challenge, but okay, that's why it's such a fascinating and interesting field to be in.
Thank you, Raj. Sachin, moving over to you. Use a different lens of a non-government organization and experience from several other countries. How do you look at applying some of those experiences from other countries to address the gaps that we have in India today?
Yes, first of all, thank you for having me, and thank you for having this session, which is very much needed. And I really appreciate going all the way till survivorship, because most of the time it starts with diagnosis and finishes with the hospital. But there's a part before where they reach the hospital, and there's a part after they go out from the hospital. So it's good to see that Siemens taking that effort to bring out. It becomes easier because Dr. Kanika and Raj has set the forum very rightly, but for me, for cancer is rising, and that's a known fact. But if you look at it, how do we reimagine things which we were already doing? For example, uh, if I look at it, awareness, or probably access in that sense. So there should be something which he says creating the need should probably precede or also get that importance of infrastructure, which is what Dr. Kanika was talking about in terms of patient care-seeking behavior. It should be as important and considered that somebody should be aware and open to seeking care as much as how you put up an infrastructure. You could bring it all the way closer to home, but it still has a step to take towards. So one is creating the need is as important as infrastructure. The second part is the capacity in terms of accessibility. You probably think of it saying, can we collaborate rather than compete? It's probably not about government becoming as good as private or private becoming as good as global. It's about how do we work together and use the excess capacity that is available to add it into these packages. How do we solve this problem in terms of efficiency? You have numbers on one side, you have capacity on the other side. It's skewed, the numbers are skewed, but can we work together? And that's a part of the community part of coming in. Affordability. There was a study in World Economic Forum. It says it could take even 7 generations for a family to come from below poverty line to above poverty line. And it just takes one diagnosis, one catastrophic expenditure, push them all the way back. Right? And that's a scale. It says, imagine 7 generations worked hard to move the family up with education, studies, hardships, and just one diagnosis. And that's where could we look at creating funding stacks? Could there be copay model? Could there be above poverty line cancer insurance where you could actually have subscribed to this? Because even insurance policies, Raj was speaking about, it's still not comprehensive for cancer. It's designed for something else. It's designed for the masses. Can we have something which is designed for cancer, which is outcome driven, which is focused for such interventions, which is advanced for what is coming out, for the technology that comes? What's the point when you have a 20 lakh insurance and a sublimit of 2.5? It's useless for you, because at 2.5 you will not get anything else above that. And for the kind of complication that exists in the system, it just doesn't reach all the way through. So it's an insurance, more like a safety net, that you could fall. It doesn't prevent anything else. So it's about looking at reimagining things. How do you look at it saying, can we also work on creating the need? Can we work with the community? Workforce, for that matter. We don't have enough workforce. Everything that an initiative comes up, it falls on an ASHA worker. Pandemic, ASHA worker. Any other government programs, ASHA system, seeing how they get involved in the systems. Those are all certain areas which we could tap into to solve this problem together. I was reading, it says, if not us, then who? If not now, then when? That's a thought that we always have to. Yeah, that's it.
Just one point. Sachin, do you mind if you could explain a little bit more about the point which you made? A 20 lakh insurance with a 2.5. So can you be a little more elaborate
Sure.
on that? What exactly does it mean?
So if you look at many of the policies, generally people tend to look at a policy bazaar or any of this and compare, I'm getting it cheaper. What you don't read really is the fine print. The fine print says your innovative therapies listed has a sublimit which is either 25% of your total cover or a 2.5 or 3 lakhs. The moment you hit the thing, even if you are ready to purchase the medicine outside, do the care, your cover is rejected because you started on an innovative therapy. So even if you have to pay, if your insurance is 20 lakhs, you have to pay for a 40 rupee medicine because the therapy says it's innovative, you have exhausted it, then you cannot. So that's restrictive. That doesn't really help out. There needs to be corporate awareness that every corporate which is giving those corporate insurance should also ensure that is these questions being asked to the brokers, that do you have, when you say 5 lakh,
Right.
does my employees get all 5 lakh? Do they get restricted at 1 lakh? So these are certain things I would call out to. Yeah.
Thanks, Sachin. Great points and great insights. Vineet, moving over to you as someone who's been actively engaging with the government, how do you think the government is looking at balancing between really providing wider coverage through Ayushman Bharat versus providing a high quality treatment, which covers all the latest innovations?
Thanks, Malti. I think if we talk about the government scheme of health insurance, Ayushman Bharat, which was launched in 2018, I believe that it has actually redefined the healthcare access in India. It was basically designed to provide free healthcare services for a population of around 500 million people, in the category of below poverty line. And now government is further expanding the base of the people getting covered under Ayushman Bharat with anybody and everybody 70 plus, is eligible to be covered under this scheme. Now, if you see, this scheme probably is the only scheme in the country which is actually providing patients, the procedure-based reimbursement. If you see the current package, I have got some numbers here with me. In the medical oncology space, almost 264 procedures are covered under this scheme. Similarly, in radiation, 46 kind of procedures are covered, and surgical oncology covers about 125 procedures. So it has come a long way. I mean, if you see when the 1.0 package was launched, the numbers were around, in med-onc it was about 52, radiation around 14, and surgical around 48 procedures. So over a period of 3 to 4 years, government has actually gone 5 times in the space of med-onc, 3 times in the space of radiation, and almost 2.5 times in the space of surgical. So oncology, if you see, as part of the scheme, it is one of the most utilized tertiary care facility or services, as part of the Ayushman Bharat scheme. Almost 4.7 lakh people have benefited, have been treated under the Ayushman Bharat scheme, which is almost about 9% of all the claims which Ayushman Bharat is reimbursing, and almost about 34% of the tertiary cases. So from that point of view, it has surely, been a fairly impactful disease reimbursement plan from the government point of view, and it has given an access to a large segment of population, financial access basically, financial power it has given. But the question is whether that financial power or financial access is good enough for the people, because they still do not have that access to get the treatment. The healthcare services are still not available the way they should be available to this complex country, in terms of population, in terms of demographics, in terms of socioeconomic factors. So access is still a question mark. And yes, government is definitely thinking, but still we have a long way to go. I mean, numbers were shared initially at the beginning by Malti, which shows that less than 30% of the districts have facilities like radiation therapy. As Raj told rightly, people have to move from their houses from one place to another, for months together. And because of these factors, people are not able to complete their treatment. I mean, most of the time, people are not able to complete their treatment. Globally, if you see, around 50% of the cases are, are getting the radiation therapy treatment. In India, the numbers is as low as just about 18 to 20%. So there is a huge gap which government needs to fill in. But we also believe that government, there are certain examples of best practices which have been taken as an initiative by the government. One of the best example which I can highlight is in the state of Assam. So there was a Tata Trust and Assam government which formed an organization by the name Assam Cancer Care Foundation. And today they have a very, very, I would say, developed network of cancer care infrastructure in their state. There are a few states like Tamil Nadu also, where you will find the radiation oncology facilities in their district hospitals across the state. But these examples are still very far and few. I mean, we can only count them on fingers. India is a much bigger and a larger state, and the government and the state especially, because state being a health subject, I think they need to take that initiative where they can, bring in some kind of a funding and also the intent to develop these kind of infrastructure. Central government, yes, is looking. I mean, we have been working with the central government because we feel that cancer as part of NPCDCS, which is non-communicable disease group, somehow the focus gets diluted, because the burden of cancer is much higher, both in terms of mortality as well as the new cases which we see every year in the country. So we are pushing for a separate comprehensive cancer care policy with Government of India. And the good news is that yes, government has taken some initiatives to carve out, a separate comprehensive cancer care policy. So those are the things I think government, if moves in these directions, will surely help to develop and bring up a new infrastructure for cancer care patients, and the cancer care facilities can further be developed, I would say. Thank you.
Thanks, Vineet. I think one of the other gaps, because cancer is part of the NCD program, is that cancer is still not a notifiable disease, right? And once we have a separate dedicated national cancer care program, it can also become a notifiable disease, and therefore better actions can come out of it as well. But clearly, government has come a long way, but I still think there's further long way for us to go if we really have to provide high quality treatment to the patient.
I just share an example. We started our journey of reaching out to states, to set up to seed the concept of setting up radiotherapy centers almost 8 years back. I mean, of course, at that time it was absolutely, something which was new to most of the people we interacted with. But today, that engagement definitely is showing results. And states are taking initiatives, to set up cancer care infrastructure overall in the state with a focus on radiotherapy also. And yes, there is definitely a positive movement I can see over a period of last 2-3 years. And hopefully it will take further momentum and we will see more and more such cases happening across the country.
Thanks, Vineet. Moving over to you, Dr.
I had a comment. So I think even in our radiation oncology communities, we are, giving recommendations towards the government bodies that we need to disintegrate the cancer care. We need to decentralize it in a way that we can have some, low energy LINACs at the second tier city level, so that patients don't have to travel for most of the cases, because 80 to 90% of treatments would be managed by the low energy, single energy LINACs. And then specialized treatments like high-end SRS, SRT are the ones which they can refer in a hub and spoke model sort of a thing, because that might be more cost effective. Because building in full dedicated tertiary care centers is not, it's an unimaginable dream. Because right now, I think what they're looking at is just a daycare at every district level. LINACs are not being still spoken of. And without a LINAC, a cancer center is not comprehensive.
And to your point that a low energy LINAC can also function and let's say attend at least about 80 to 85% of the cases, you are absolutely right. And here as an industry, maybe as the medical community, what we need is educating the policymakers in the country. Because when it comes to procurement, there are many, many reasons which force them to buy the best in the technology. I mean, there is one thing which is best available in the world, and there is one thing which is best required for your, the conditions in the place where you need to install that equipment. So that difference, that comparison needs to be established, that whether you need the best available in the world or whether what is best for you as per your requirements. So that, is something which probably we have been working on. But yes, it will still take some time, I believe, and hopefully it will happen soon.
I think concerted efforts from both the industry as well as clinician groups can actually help make the government understand the value of making good enough treatment available. And if we look at the country today, there's so many empty cobalt bunkers available where low energy LINACs can fit in, right? And there you don't even need to make the bunkers again. Just with slight modification, you can put equipments today. Moving back to you, Dr. Kanika again. How do you see the role of artificial intelligence in terms of improving overall treatment precision as well as overall patient outcomes? Like, what's your experience like?
So I think AI is the new buzzword
Yes.
around. And a lot of debates happening, AI is going to replace clinicians and all that. But I think as a radiation oncologist, we are very happy with AI coming in as a co-pilot to us, because it has really made our workflow simpler. And our, the efficiencies have also improved with the integration of AI. And I think AI has stepped in radiation much early on, even before diagnostics, in the sense that, as doctors, we spend a lot of time on contouring. So these automated contouring, automated segmentations, they reduce, our labor-intensive procedures and simplify our workflow in that context. Additionally, what I see is that the newer solutions and the new platforms which are coming in, they have a lot of good algorithms where the planning has also been speeded up by the usage of AI, especially the personalized adaptive planning. I think that is one thing in the last 4 or 5 years which we feel which is transforming. So for the understanding of the people who don't know radiation, because I know it's something which is very high end. So normally when we treat a cancer patient, we're treating a particular tumor, which may be around 4 centimeter, 5 centimeter. But as the treatment proceeds, the tumor shrinks. The tumor changes shape. So where there was tumor, now there may be some body organ which has come in. It has expanded. It has taken back its place. So if I use the same plan throughout the course of treatment, I end up burning the adjacent organ. So that is the type of treatment which used to happen 2-3 decades earlier, where we were not seeing on conformal images that what we are treating. So adaptive is doing a real-time correction. So they are integrating the CBCT, the scan which has been taken on the machine. They are integrating the imaging which we have used for planning. And by integrating all this, they are identifying that there has been a significant change in your volume, and these real-time corrections are being done. So how it impacts the patient? So you don't see long-term side effects, because everybody thinks of the side effects which patients is encompassing during the course of treatment. But what 5 years down the line, 10 years down the line? So when you're respecting the normal structures or the normal organs in the body and are devotedly treating the tumor to a higher dose by use of these, then the outcomes are much better. So AI definitely has made that. And now we have many platforms which have integrated AI into these planning tools. Third thing, which I feel it is still work in progress, a lot of predictive tools are coming with AI. So somebody from Australia took a lead. They have been collecting all the images and treatment plans and outcomes. So what they're trying to find out is that based on the baseline imaging, you would be able to predict the response or the result which the radiation is likely to deliver in that patient. And herein they will give you an input that this sort of a radiological picture reflects a radioresistant tumor. Here you need to intensify your treatment in some form, either in form of dose intensification of radiation or using any partner in form of a chemotherapy or a immunotherapy to better your results. So these predictive machine learning work is actually been there for the last 5 years, and I believe they are coming up with some results soon in the coming 2 years. Apart from radiation, as oncologists, we have been using predictive AI. A lot of normograms and algorithms are there which we use in our clinic. When patients come to us seeking consultation regarding whether they need additional treatment after surgeries. So by putting their parameters, their surgery parameters and other things, these tools, they give us objective values where we can tell the patient how much benefit a particular treatment is going to give. So that helps them choose whether they would be willing to go through that treatment, because now it is a shared decision-making era. It is not that as a doctor I endorse a treatment and the patient just walks out with that consult and starts off the treatment. So in the shared treatment decisions, I think this AI again is definitely which is helping us out. But majorly I think our workflow, our labor-intensive steps of contouring have come down by AI, and the adaptive, I think, and adaptive is going to change the scenario of the patient outcomes.
Especially in a country like ours where you treat large volume of patients. AI will also make our clinicians a lot more efficient.
Definitely in high volume centers where you have 12 to 15 patients to be implemented on a very single day, and every patient is wanting to start the treatment right away, because once they know it has to be treated, they don't want to wait a single day. Yeah. So there definitely our workflow has become very efficient.
Great. Raj, coming over to you, how critical is digitalization in terms of ensuring post-treatment follow-up? Because we think that's a big gap in our country today. Clearly, there are large volume of patients getting treated in every single center. I mean, I see our machines doing 100 plus patients every day, which is very unlike several of the countries in the West. How do we really take this forward and utilize digitalization to ensure we have a better post-treatment follow-up of patients?
So first of all, it's important to understand why follow-up, not just post-treatment, but during the treatment, or let's put it as hand-holding the patient is important for cancer. One, the treatment is multi-episode. It needs to be done timely. You need to ensure there is no drop-off, right? So that hand-holding reminder. Second, just the information sharing with patients, whether it's educational information, etc. Before every chemo, you may have to do, some tests before you come for a chemo sessions. There is a lot of educational information sharing and hand-holding that patient needs while going through the treatment. Then, unlike all other acute interventions, whether it's cardiac and neuro, where you're following up to make sure patient is okay, in addition to that, there is an inherent risk of cancer coming back in many cancer patients, so most cancer patients, right? So the stakes are much higher for a follow-up, and you need to monitor 3 months, 6 months, yearly, whatever the routine is, not only to make sure that, cancer hasn't come back, but also to make sure if it comes back, you diagnose early, because we all talked about how late diagnosis means odds are so much against you. Third is, if you look at, we did a survey, almost 50% of cancer patients do not have information or awareness or access to rehab services. Almost 60% of cancer patients have severe emotional distress that may require professional intervention. The suicide risk among cancer patients is 4 times more than general population. Right? Aim of treating a cancer patient is not to treat cancer, but treat a patient so that you physically and emotionally or psychologically, patient goes back to the original stage, because the psychological damage is huge. You need to bring back. For a woman, breast is not just an organ, it's source of identity, sexual health, so much more, right? So if you want to heal the patient, not just treat the patient, you need to handhold them in a multiple aspect. I'm sure you have experienced this, that your car manufacturer or service station does a way better job in giving you reminders, calls through messages to get your car back to the preventive or maintenance servicing after 6 months or 5,000 kilometers. Compared to that, as hospitals, we do a pathetic job in reminding patients, to come back when the stakes are so much higher. Now, before 2020, neither patients wanted to use online consultation, nor doctors wanted to. Doctor Saab, samne baithe, when you touch, you feel you've been treated, right? Silver lining of COVID has been today most patients and most doctors are okay doing a follow-up consultation, through online. Prior to COVID, the general understanding was that a typical online consumer or an online user of services is a millennial metropolitan male. 2 years post-COVID, when we did a survey, we found out that women are equal, 50-50, in terms of being an online consumer. Urban is actually less than rural consumers. Number of rural consumers have way grown because just we have a higher rural population. Age group 55 and above is as big as 25 and 35. They just use it differently. They may not use app, but if they see something online, they'll take a screenshot, send it through WhatsApp to the local guy, and who'll home deliver. But they still digitally influence consumers. That's such a huge opportunity now, because now, and cancer patients, if you look at incidence, 20 lakh patients in a 140 crore population means a very thinly dense, widely spread, fragmented consumer base. The only way or best way to reach out to them is through this, right? So we are in a best position now to use this technology, not just to share information, but give them reminders, nudges, digital nudges, notifications, and make sure that you bring them back. Ease of, I'm sure you've experienced, if you get up at 2 at night and you remember that tomorrow someone is coming for breakfast and you don't have eggs, you can order it at 2 o'clock at night. But if your child is sick or you're sick, try taking an appointment. Okay, you have to go to ER, or tomorrow you have to go and stand in the line and wait for 2 hours and not have any visibility when the doctor will see. But today with digital, you can take an appointment if the hospitals invest in it. So I think combination of the mindset change, the prevalence of smartphones, mobile connectivity, the data consumption, if you talk to the telecoms and Googles and all, the data consumption in rural is way higher. It's all in form of video, and now you can reach them through vernacular, because video is an excellent medium. So I think as a combination, I think we have an amazing opportunity to fill this gap and make sure that you handhold the cancer patient throughout the journey and make sure that they get the timely treatment so that the outcomes are the best.
I just want to add to your point that cancer, if you see in absolute numbers, the new cases, the kind of deaths we are having every year, I mean, the fear is there about the disease in the minds of people. But somehow that urgency for awareness is missing in the system. And we have seen during COVID time that government stepped up and created tools where each and every one in the country was aware about the disease. They knew that there is something like COVID. They knew what are the preventive methods which can possibly be utilized to, kind of save themselves from the disease and everything. Everybody on the road, even a rickshaw puller, a vegetable seller, they had that basic knowledge about the disease. And not to undermine the loss we've had during the COVID, I mean, we are losing 850,000 plus people every year. So I think this reason is good enough to create that infrastructure where the level of awareness has to be raised, maybe through apps. Telephone is one smartphone is one technology which almost 90% of the people in the country has today. So why can't we use the technology? And government did step up during the times of COVID. So at least I sincerely believe if we can create that kind of an urgency around the disease, create that kind of an awareness, I think it will definitely take us a long way in terms of prevention, I would say.
I just want to highlight for everyone to understand how big is this problem. Since the beginning of COVID, we must have lost about 500 to 600,000 Indian lives to COVID in last 4 or 5 years. Every year, we lose about 800 to 900,000 lives to cancer. That's 1.5 to 1.6 every year. And these are just reported deaths, right? We don't even know. So I think I'm glad that house is full today, because I think we need to do so much more to create awareness, and a lot of it is preventable, because obesity, alcohol, lifestyle, food that you eat, there are so many preventable risk factors that people are not even aware about, and they don't know that obesity is a major factor contributing to cancer. So I think there is enough we can do to actually slow down the incidence, while most of our discussion is on taking care of people who diagnose with cancer, I think the only way to reduce the burden is actually slow down the incidence. Because we'll never be able to deploy enough resources to take care of the rising incidence with the rate at which it is going.
Yeah.
It's, you know, at the end of the day, it's about the prevention, which is critical, you know. And to reach the last mile, government has to step up. You know, we cannot expect the private sector to reach the last mile and cater to the requirements of the people there. So it is the government only which needs to step up. And today we see such huge gaps. I mean, there is, as part of NPCDCS, there is a prevention screening program, you know, which covers just 3 types of cancers: breast cancer, cervical cancer, and oral cancer. Whereas you also have, from a treatment perspective, there are state cancer institutes and there are tertiary cancer care centers. But are they talking to each other? Are they being referred, you know, the patients who are diagnosed or potentially diagnosed, you know, for cancer, are they being referred to the way they should be? I think there is a huge gap in these 2 pillars, I would say. And that is why things fall between the cracks. And then, of course, access, again, you know, we have already discussed about it. That's such a big challenge, you know. So somewhere I believe government needs to step on. The good part is that there is a thought process in the government which is happening now. We have been talking to policymakers on these subjects. So I'm hoping, you know, it's not a job for me. It's more like a personal mission that, yes, if something like these things can happen, can we have some changes in the, you know, the medical colleges, you know, today radiation oncology is just an optional course as part of any medical college which is offering oncology as a course. So all these things, if can be addressed, I think we can definitely, you know, see a lot of disease burden coming down in the country, I would say.
So I had something to add here. So, you know, it is not just the government or the healthcare providers. We really need to collaborate well with the civil society advocates also coming into the picture. Because we do a lot of awareness. Awareness is something very close to my heart. So what we feel is that you need to create cancer awareness ambassadors, which are from the community. So we started these, especially on the breast cancer awareness, the Cancer Rajdoot, the breast cancer awareness ambassadors. So coalitions need to be built. And we need to take these advocates also on board because they are very enthusiastic. We, as clinicians, are more engrossed into care delivery. But these people, they have more reach into the community. Let not everything come to the ASHA worker. Let there be more KOLs in the community who can pick this up. And I think our Indian Cancer Society is very, very serious. They have created beautiful apps. They have gone digital. It is in 5 languages. So I think they're breaking the language barriers. They're trying to improve the health literacy. And not just medical colleges. I've been an advocate of bringing in, you know, understanding of NCDs in the schools. If you look at the children's curriculum, they talk of nutritional disorders, they talk of what vitamins deficiencies can lead to what diseases. That is the time a person builds his lifestyle. So it should be at the school levels where the children should be briefly exposed to what NCDs are and how they have to work lifelong to make it sure that they are not getting those 40 to 50% cancers which are in their own hand. We earn those diseases, 40 to 50% cancers we earn by our lifestyle. So I think we need to work on at the school level as well. And I'm definitely on board with you that oncology is not taught to the extent it should be at the MBBS level because everything should not be left to the super specialist. At least the diagnostics and the initial workups should be known to each and every medical person who has come out of a medical training.
Great discussion, really, and you know, great points coming out, which we should be able to, you know, collectively take it forward to the right stakeholders in the government. But I think if we really are able to get that policy created for cancer from awareness all the way to treatment and follow-up, I think that will solve a lot of problems, including ensuring there is extensive use of digitalization to create awareness, follow-through, as well as, you know, survivorship as well. So that program, eventually, if it comes through, I think it'll help address a lot of these points. Sachin, coming to you, given your experience in policy and advocacy, how can multi-stakeholder partnership strengthen cancer care in India, and what are some of the key challenges that you see today?
Sure. Great discussions, and again, thanks to the panelists. I've got a good platform to start from with civil societies. Dr. Kanika was mentioning. Uh, see, citizen-powered movements has that power to have scale and impact. You need to have something that works at grassroots level to scale up. It cannot be top down. It has to be meeting. There should be top down, which is the government policies. There should be bottoms up, which is this community practices, which community stakeholders. Uh, this is a problem which we all acknowledge for the last 40 minutes, 50 minutes of discussion. But the starting point of solving a problem is defining the problem. And you cannot define that problem when you put it between NPCDCS or NCD. It has to be a cancer mission. It has to be a cancer program. That's where it starts. That's where you define. That's where the data comes from. That's where the resources gets come in. And then you look at it. What can the government meet with all its priority? We are struggling in all the areas. So what can government meet with its own resources or whatever limited resources? What would the community add to it? Which is the part that we could take care of, including as a citizen, what we could take care of. And I can tell this from my personal experience. We built a community of 35 odd plus partners in Kerala as part of a City Cancer Challenge initiative. And what is advocacy? Advocacy is someone who is affected by cancer, working in cancer. Talking about cancer is part of what we do. But when a relator, when a hospitality, when a banking sector, when an NBFC talks about cancer advocacy, that's where the advocacy comes in. That's where somebody who doesn't have anything to do with health, anything to do with cancer, comes in and says, okay, I'm also going to join in. And then they come and tell you, how do I partner? Can I make a microfinancing model for you? Can I work with you against a corpus fund to subsidize these treatments for you? So once you have these solutions or identify these gaps, that's when we kind of complete the puzzle. So sometimes it's also about connecting the dots backwards. You kind of say, this is my problem, and then you start putting in the dots and put it around the jigsaw puzzles around it. So that's one part of it in terms of civil society. Second, if you look at the problem from a patient journey perspective, great slide which you have put in, saying the patient journey aspect of it, you solve it for a patient, you solve for the system, right? You have 3 or 4 types of patients coming from different situation. You solve it for the patient. You say that, okay, fine, there are civil society which fund certain treatments. There are civil society which drive awareness. There are civil societies which provide accommodation to cover the out-of-pocket costs. There are civil societies who actually work with families affected with cancer, providing educational fellowship. This goes back to my point of someone who has spent all their resources in probably treating cancer. How can we hold their hand back to help them coming back? You have a program where all children under 18 is given free of cost treatment. Who takes care of the education, that aspect that was lost during the way? Who looks at the outcomes of this? Right? So there is a part where we could contribute into the society, but it all starts with defining the problem. And then we say, where do we fit in this puzzle? Once we identify that, that becomes our purpose, and aligning that into the common 35 or 40 or 100 plus partners, that becomes a shared vision and goal, that we solve this problem together as part of the program. So that's my take on it.
Thanks, Ajay. Very well said. Vineet, while you've already spoken very passionately about some of the initiatives, is there something specific that you would highlight by way of the efforts that we are doing from a government advocacy standpoint in the area of cancer?
I think it's been more than 8 years since my journey started in this space. And maybe it started as part of my job, part of my work, but now it is much more beyond that. It's more like a personal mission, that yes, we need to bring in some genuine changes which can actually, bring a better focus to overall cancer care for the patients and overall infrastructure, for the patients to access. as I mentioned earlier also, that we had started this journey by engaging with the states, where we wanted to seed the concept of setting up radiotherapy centers, on PPP basis, interestingly, because we had seen this model very successfully implemented across the diagnostic space in radiology, for CT scanners and for MRIs, and we had also seen in the space of pathology labs also, they were being successfully run on this model base. And then in the space of treatment nephrology, the dialysis treatment was being successfully given to a lot of patients across the country. So we felt that yes, we could possibly, see something. Of course, we had, I would say, limited success at that time. But then today, the good part is that a lot of states are now focusing on increasing their overall cancer care infrastructure. So there's a lot of procurement happening at the state level, and even from the central government point of view. Now the government's vision is to have one AIMS across every state in the country. So each AIMS which they are establishing will have a cancer care center, a comprehensive cancer care center where they will be able to provide services. So these are the positive developments which are happening. We also felt that a policy change is also important, because today, as we have discussed earlier, the focus on the disease probably was not getting as much as it needs to have, considering the burden we have as far as the disease is concerned. So, the good part is, recently we have had a meeting with the policymakers this week itself, and we heard this positive news that government is now looking at formation of a new comprehensive cancer care policy. We have also been proposing, that we need one specific organization at the government level, on the lines of, let's say, a NACO. NACO came up in early 90s to, address the menace of HIV in the country at that time. And it has been fairly successful. We have seen very positive results the way NACO has functioned, So this is also one thing which we have been working and proposing to the government, that if government can come up on similar lines, where every aspect of cancer disease, whether from screening, diagnosis, treatment, palliative care, post-treatment care, everything gets covered under those things, and the decisions related to these services are also happening, under the same roof, then definitely things become much easier, much faster. And there are, the delays in getting things implemented on the ground level, probably can be reduced to a greater degree, I would say. So these are few of the initiatives, I think, which we have taken in the past, and we are continuing to work, and hopefully we will definitely see something positive happening. A lot of things are positive, no doubt about it. And I am a great believer that, yes, government has to be there. Without that, it is impossible to reach the last mile in the country, because the kind of, variation we have in the country in terms of population, in terms of, the socioeconomic differences, in terms of geography, and so on and so forth. So, yes, we need to bring in the government, and the good part is government responding positively, and one can always hope that things will definitely go better from here only. Yeah.
I would like to add something. Vineet and I are co-leads for National Task Force, Cancer Task Force, under aegis of FICCI. We started our journey 4 years ago, and our first goal was to actually map the landscape, cancer landscape in India, and actually quantify the problem and come up with solution. So we worked with EY and created a very comprehensive cancer research report, which was published by Vice President of India in October 22. It's available online. It's probably the most comprehensive document on this topic that is available online for free. After that, what we've done is, once we were armed with this wealth of knowledge and information on cancer, we went around across the country in last 2-3 years and have held 5 regional roundtables. Our approach was that I think any challenge like this, the first step is create awareness and bring people together, different stakeholders. So what we did is we started in Bangalore, the first regional roundtable. We called different stakeholders from Karnataka and neighboring states, Kerala, Tamil Nadu, Andhra Pradesh. Health secretaries, health ministries, medical education, government officials, finance ministries of those states, stakeholders, politicians, bureaucrats, public hospitals, teaching hospitals, private hospitals, diagnostic companies, medical equipment companies, patient advocacy groups. In each of these regional roundtables, we brought the people together, presented the specific data on those states, the quantum and the nature of the problem, had a brainstorming, created the recommendations. So we did it in Bangalore, Ahmedabad, Bhubaneswar, Shillong, and Jaipur. We've done 5 roundtables. Just bring different people together and at least start the conversation, because any of the stakeholders alone will not be able to make much of a difference in this unless we all come together. We'll continue to do that, whatever recommendations that have come up. Last year, we publish it, we've given a representation to the health ministry, different ministries.
All the kind of recommendations, we compiled a compendium of the recommendations, and we have submitted it to the Ministry of Health. And based on those recommendations, things are being now worked out accordingly.
Very engaging conversation, and I don't even realize how those 90 minutes have almost gone by. Our vision really remains to create a world without fear of cancer, and with thought leadership present on this panel and beyond, and a strong execution, I'm sure we will get there one day. So thank you very much for being here today and contributing so meaningfully to the conversation. Yes.
My name is Parth. I'm a public health researcher. I have a few comments to make based on the discussion. Firstly, thanks, Raj, for bringing up primary prevention, because nobody was talking about why the cancer burden is going up. I think everybody mentioned cancer is rising at an alarming rate, but somehow we never asked that question. Why is lung cancer going up in women? Air pollution. Why is oral cancer going up? Smokeless tobacco. And till we become anti-tobacco advocates, all of us, that's not going to change. ITC is providing lunch here. How many of us are calling that out? The Indian Tobacco Company is providing lunch. So that's my first
So
comment.
as a company, we don't host any event at ITC.
Thank you. So I think all of us need to call that out. My second comment is on awareness again came up, access to care came up, and health-seeking behavior came up. I was also under the impression that patients are not seeking care. Till I studied the pathways of 150 oral cancer patients. The median time to reach a doctor as soon as I identified something's going on in my mouth is 2 weeks for those 150 people. Time taken to diagnose them is median of 3 months. To start treatment is median of 2 months. So again, we need to ask, where is the medical education going wrong? As a physician, when I was training, I wasn't taught oral cancer screening. I wasn't taught cervical cancer screening. So that's something we need to question. And my third sort of comment, and I would invite some thoughts from you, is that I am personally relieved that the screening rate is 1%. Because if it goes to 10%, 20%, do we have the capacity to treat those patients? Like I said, 6 months is taking from identification of symptom. All of them told, muh mein chala tha, painless oral ulcer I had. 6 months to start treatment. If I pick up all of them, where am I going to start treatment for those patients? So is it ethical to diagnose somebody with cancer and then not offer treatment, knowing that we don't have access to care in our country? Some thoughts on that. And just to give you an example, waiting time for MRI in Delhi is 3 years. So in the public health sector, so how do we diagnose those people once we screen them positive, and when we know there is a lead time bias in a lot of diseases, lung cancer specifically. So is it ethical again to screen all those? Some thoughts on this. Thank you.
Look, there are many. First, effectiveness of screening, the effort that you do versus the output. There are a lot of research paper questioning the effectiveness of screening. However, screening is important, and what Dr. Kanika was saying, that I think the starting point has to be including oncology at an MBBS level, so that, because first port of call for any patient is not, not a specialist, not an oncologist. For oral cancer, it will probably be dentist or an ENT specialist, right? So first, I think educating doctors across to identify symptoms and all is absolutely important, number one. Number two, I don't think there is anything morally, ethically wrong. I mean, it's like, you don't want to be ostrich who's buried his head in the sand just so that you don't want to quantify the problem. Let's identify the problem to actually create awareness that we need to scale up our infrastructure massively, invest massively to address it. So quantifying problem, just because we can't handle it, that's a starting point. Personally, I don't see anything wrong in that. See, today, I think the good thing is in union budgets and all, government is recognizing cancer as a challenge and an opportunity of improvement for us. But I think we should take it with a pinch of salt also. One of the announcement was we'll open 2,000 daycare centers and 200 dedicated cancer hospitals by 26. To start a hospital, it takes, if you're efficient private organization, it takes 24 to 36 months from acquiring land to at best. Okay, 200 dedicated cancer hospitals by 26. Okay, but even if you put infrastructure, today we are 3 to 4,000 oncologists short to treat current patients, medical oncologists. Okay, who's going to man it? You may start a daycare center 2,000, but who's going to run it? Current health and wellness centers are not staffed, right? So I think good thing is we've realized the problem and we are making ambitious announcement, I think, but we need to be realistic and have a little bit more detailed and realistic, pragmatic, practical plan to now address it. But I think we must screen it. I mean, is it just because we can't treat it, are we going to keep the patient blindsided? And the more you diagnose, the more awareness will be there. At least they will have a recourse to go and get treated, whether they afford or not, whether we have a capacity, or it's a different thing. But I think we must screen people and identify them.
So I think I'll echo what you've said. I think you should not undermine the advantage of screening. You're putting a health behavior in that person. A person who's going for screening will be vigilant. You're introducing a health behavior. Second thing is, that is the beauty of screening. It is picking up early diseases. So the quantum of treatment, the number of modalities required at a screen detected stage would be much lesser than when you find the disease when it is symptomatic. Screening also picks up pre-malignant conditions. They may not be cancers. So if you are treating at a pre-malignant state, you don't need a very high-end specialist to address that. So I think don't go home with that notion that screening is something, if it is done, because patients also have that mindset, nikal aaya to kya hoga? So don't carry that message. Screening is something which should come into our system. It should be like a ritual to us that every year I have to go for screening. Rather, what I tell most of the women, when I address them, that, you fast for your husbands on Karwa Chauth, you fast for your children on Holi Ashtami, I need one fast from you for yourself. Come to the hospital, 4 hours fasting, get your test done, and have a sumptuous meal after that. And that ensures that you are taking care of yourself. So do something for yourself. So don't stop these things.
I also think that each of us have to take responsibility of our own health also. It's not just the providers and the government and all, right? Now that we know obesity is a major risk factor, now that we know alcohol is a major risk factor, we just spoke about how diligently we service our cars, but do we go and do health checkup? I mean, how many of we do it? How many of you insist your family members go and do it? Right? So there's a lot of personal responsibility that we need to take. If each of us don't take that personal responsibility, we'll never be able to manage and address, this problem as a country.
The preventive checkup, just one point, ma'am. The preventive checkup is all about mindset. And it's not a rural issue. It's there at the urban cities. People who are moneyed, people who are influential. Unfortunately, as a society, we have a mindset. One, we are very wary of getting preventive checkup. And once the checkup is done and there is nothing diagnosed or nothing screened, we feel sad that we spent so much money and nothing came out. This is the unfortunate thought process we have. So next year the person will definitely not go for the preventive checkup. Okay, what's the point? Nothing will come out. So rather than feeling happy about it that nothing came out, they feel, okay, we have spent so much money and still nothing came out. So this is the ground reality which we are facing with. So, I think we need to basically change our mindsets on these aspects. Yeah.
Right, and I think we should not undermine the importance of preventive screening in any way. I tell this to a lot of my friends. Gift your spouse, friend, partners a mammography rather than gifting them anything else, right? So let them go for a preventive checkup. Let them go for a screening. You don't have to give them anything else.
Gift of life.
Yeah, don't give them any diamonds. Gift a mammography. Yeah, you're giving them a better quality of life. Yeah, you can get both if you have the ability to do that, but don't miss out on doing for a preventive screening checkup. Yeah.
Just kind of synthesizing some of the thoughts from the panel, there are lessons to be learned from the US. In 1971, Nixon declared war on cancer, that we're going to solve it in the next 8 to 10 years. We'll find a cure. Now, I'm saying the benefit of hindsight, we are nowhere finding cure seems an impossibility, but that declaring the war on cancer catalyzed the society. Philanthropists got involved, celebrities got involved. There was, if you read Siddhartha Mukherjee's book, there was a young boy dying of cancer. They started something called the Jimmy Fund. Like, people sent pennies, and I think the good thing we can learn from the US is that we as a society need to declare a metaphorical war on cancer, right? To catalyze politicians, celebrities, civil society, NGOs, everybody. Otherwise, and it is just not, we are not taking it as seriously. The number you mentioned, 850,000 lives lost every year. We have, compared to the US, we have more pressing primary health challenges also, but there has to be a concerted effort to kind of really declare war on cancer.
So just adding to that, we see that implication all the time. I lead a social enterprise and we do preventive screening, including for cancer. And when we approach CSR initiatives or funds and donors for this, उनके दिमाग में ये ट्रेड ऑफ होता है कि मैं डायग्नोस्ड पेशेंट को फंड कर देता हूँ ना, मैं स्क्रीनिंग क्यों करूँ, दैट इज़ नॉट माई रोल. एंड स्क्रीनिंग मैं 100 लोगों को करूँगा, 2 डायग्नोज होंगे, उसमें मेरा क्या मतलब, व्हाट इज़ द इम्पैक्ट आई एम क्रिएटिंग. दैट इज़ ऑल्सो समथिंग दैट नीड्स टू चेंज, एज ही सेड, दैट even focus on screening and funding these screening initiatives by civil society is also really important.
I think I want to address his comment. We sent a man to the moon in late 60s. And since then, every decade, many heads of the states have declared this moonshot. We're nowhere there, right? I think that's a very oversimplification. And we need to have a realistic expectation on what that winning a war means, right? Just... I know, but I'm...
Even if you don't win the war on cancer, it will catalyze action.
I know. What point I'm making is cancer is a disease of genetic mutation. What makes living mechanisms powerful is that genes are evolving. The cancer genes will also keep evolving, right? There are some cancers you can eliminate, HPV related, etc. The last few risk factors that we identified and isolated, which made a significant difference in reducing the disease burden, was radiation, tobacco, and probably HPV. Now it's combination of many, many risk factors which we don't know if we can eliminate, right? Cancer is here to stay. Some will eliminate, some are here to stay, right? Now, the most experts, the realistic winning the war means you reduce the mortality, you extend the life period, and you may give a better quality of life so that cancer becomes a disease like hypertension and diabetes. You can live and the fear of death goes away. That's winning the war. But to do that, there is no magic bullet. Whatever we talked about, awareness, prevention, screening, early diagnosis, taking responsibility of your own health, eliminating these small risk factors. This is collectively is going to, help us bring that. There is not going to be any magic wand or magic bullet.
We'll take one last question from ma'am. Question or comment? Yeah.
Hello, I'm Ananya Dasgupta. I just wanted to say my father had cancer in urinary bladder. He had primary detection, so went ahead with immunotherapy and cystoscopy. 3 months, 6 months, 1 year. Like this, he underwent the cystoscopy and the immunotherapy treatment, and he was cured. But he had a disordered lifestyle. And now he is having thickening in urinary bladder. He has been advised by his urologist to go to a nephrologist. So we are very much confused whom to consult, urologist, nephrologist, or an oncologist. This is my first question. And second question is for breast cancer. To prevent breast cancer, should we do mammography once a year or 6 monthly?
I would like Dr. Kanika answer this.
Yeah, so I think the first question is more of a consult. So I think the urologist should be the first person. The bladder thickening can be because of many reasons. They need to do a cystoscopy to rule out cancer. If it is not cancer, then thickening might be treatment related, which has treatments. So urologist should be the first point of contact. For mammography, there are very, very simple recommendations. After the age of 45 years, it has to be done every year till 54 years. If it has been normal for those 10 years, then you can make it once in 2 years till 70, 75 years of age. Beyond that, if you want to leave it, you need to discuss with your doctor. In case you have a family history, you might need to continue. However, this is for average risk. If there has been a family history, somebody's mother, maternal aunt, or grandmother has had cancer in the breast, ovary, colon, or an uncle in the maternal side has had prostate cancer, then you have to start your screening slightly early. But the earliest you can do a mammography is at 40 years of age. Prior to that, alternatively, ultrasounds can be done. And self-breast examination, every woman should know how it is conducted. That is one big thing because it does not require any cost. No shame, you can do it on yourself. I think that also should be a health behavior we have to introduce, should be taught right at the teenager stage. Right. Because the youngest cancer patients I have seen for breast has been 18 years. So I think this is also something health literacy has to look at.
Right. Thank you so much, everyone. I'll request the panelists to be available outside for a few minutes so that if there are any other comments or questions, you can get them addressed.
Undernutrition is a leading social determinant of TB in the region, followed by smoking, alcohol, scourge of TB.
नॉर्थ साइड लाहौल से और मेरे काफ़ी बैचमेंट्स लाहौल में हैं, तो कुछ हेल्प चाहिए होगा तो obesity.
We are working with civil societies in 4 districts of Vidarbha region of Maharashtra. So maybe we need some awareness session, if possible, online or whenever time permits, physically. So there are more than 6,000 plus patients connected. So because this punched in my mind that 40% advance is really a lot.
I'll tell you what we have is normally what happens when people land up in India, they come to some select place on charging their relation to the services. So at Narayana, we are not having a middleman. Whosoever comes to the hospital is offered the same rate which our domestic patients are getting. We don't charge anything to anyone beyond. If the patient is not having going for high-end, we have customized some subsidies based also where we are having although our hospital is known for its cardiac, Dr. Devishek is known for its cardiac work, but since I'm an oncologist, the patient I see with my manager. Family.
I was part of radiation also because I was a part of NECTA, so what specifically why I came to you was you mentioned about the ICS app, so we were actually behind the development of the entire app with the
TB control effort. Frameworks based on the principles of equity
See how we can take it forward. Few more like-minded doctors, not in my organization, few more organizations.
majority of the adoption leaders once the hospital also
Yeah, we will push. Maybe somebody from the team, my last man, can give a demo here. We have a survivorship program running, Disha. Yes. So we have a social worker there. Maybe if you can line up with her, she can make it for each of our patients. Contact him, take my number. I will talk to Dr. Ramesh Davar. She is the Vice President Commissioner Foundation. I wrote the program, but she was the one who wanted us to have a survivorship program. Sure. She will definitely
No, and I think you made another great point where you talked about, I think, more inline people, more famous people advocate equity. So could we have a lineup for the application, maybe of people, their videos or their lineups going socially? But I mean, if they're patients to you, it would be good to actually have them contribute.
not just testimonials, it to be stories of happiness and success.
Yes, absolutely. That mindset
It's not should be just, I always say, don't talk about us, don't talk about highlighting. Talk about your journey, talk about how you came over.
I think, but in all this time, we realize it only comes from people of fame that the actual population wants to listen to.
So what I did, I started sending my survivors to beauty pageants. Two of my survivors, they went up to even glad rags and went up to,
Sudhir,
and modeling. So
खोलो BNC खोल के देखो.
that is where.
We'll connect with you on that. But pleasure.
Wonderful. Right person.
We have this AR-based app for screening all the cancer. We work with Dexter and other institutions with the
Sure.
can I write to you and
Maybe I will put you across my head and neck surgeon.
that would be amazing.
Thank you.
Sorry for that. So great to hear you, Dr. Kandika. Manoj, I was your former managing director for Technical. Now you're working on an oncology lab that brings in patient
One. Check 1 2. Hello. 1 2. Hello.
Access to TB services and achieve universal health coverage. Social protection measures such as cash transfers and nutritional support are essential for mitigating the social and economic impacts of TB. TB should be prioritized in national budgets, including through innovative financing mechanisms such as social impact bonds and public-private partnerships. Importantly, meaningful community engagement and empowerment should guide designing, implementation, and monitoring of TB programs. Countries in the region have been making efforts on these lines. Bangladesh hosted Global MAF-TB Forum in June 2024 to accelerate multi-sectoral action towards ending TB. India launched Adopt a Patient approach under the Pradhan Mantri TB Mukt Bharat Abhiyan for nutrition support. Indonesia's presidential decree on TB aims to implement a comprehensive strategy towards ending TB in the country. Maldives has rolled out TB-free atoll initiative. Myanmar was the only high TB burden country in the region to achieve 2020 milestones for decline in incidence before COVID-19 pandemic disrupted this progress. Nepal's TB-free initiative at Palika level aims at actively engaging subnational level systems in TB programs. Thailand has made significant efforts to improve coverage for TB services under its commitment to achieve universal health coverage. Timor-Leste initiated a partner's pledge to end TB led by the Prime Minister for a multi-sectoral approach. While a lot is being done, a lot more needs to be done, and with urgency. It is time to transform all our commitments and political declarations into actions. We need to accelerate efforts to achieve global TB goals. The time to act is now. Let's work together to end TB in the WHO Southeast Asia region. Tuberculosis or TB, a disease affecting humanity since time immemorial, continues to be a major killer despite being preventable and curable. A major public health challenge in WHO Southeast Asia region, TB has significant socio-economic consequences for individuals, families, communities, and beyond. With a huge disease burden, the region accounted for close to 5 million persons developing TB, which is 45% of global estimates for 2023. The region also accounted for nearly 600,000 deaths due to the disease, or more than half of all deaths due to TB globally in the same year. An estimated 30% to 80% of TB-affected families in the region face catastrophic costs due to the disease. Undernutrition is a leading social determinant of TB in the region, followed by smoking, alcohol use disorder, diabetes, and HIV infection. To address the scourge of TB, countries in the region have been rolling out numerous initiatives. As a result, between 2015 and 2023, the region witnessed a 6.7% reduction in TB incidence rate and an 11% reduction in the number of TB deaths. However, this decline has been slow and is not enough for us to reach the WHO End TB strategy milestones for 2025. Cognizant of the need for greater efforts against TB, in August 2023, countries of the region adopted Gandhinagar Declaration. A month later, the political declaration on TB at the United Nations high-level meeting in New York set global targets to reach at least 90% of people who develop TB, provide TB preventive treatment to at least 90% of the high-risk population, and ensure each and every person with TB has access to health and social benefits package. The declaration emphasized on people-centered approach and equitable access to quality health services. The political momentum against TB is unprecedented in the region and globally. We need to grasp the moment. We need to translate declarations and commitments into actions against TB for accelerated gains. For this, the highest levels of political leadership should prioritize and drive the national agenda on TB. A multi-sectoral coordination platform under the highest political levels should be established to ensure comprehensive and integrated TB control efforts. This is critical to address the multiple social determinants of TB and it.
Good morning, everyone. We thank you for joining this session on TB, which is to accelerating progress towards ending TB through research and innovative approaches. Before we start, we have an interesting lineup of senior eminent people here, and we are lucky to have them with us. May I request the chair, Dr. Soumya Swaminathan, and the panelists to kindly take their seats on the dais. Dr. Soumya Swaminathan, who's chairing this session, we know is currently the chairperson of MS Swaminathan Research Foundation, and she is also the principal advisor to the National TB Elimination Program. She also serves on the boards of Alliance Biodiversity, Population Foundation of India, Institute of Global Environment Strategies, and Women Lift Health, amongst others. So, you know, she has to her credit so many, her profile where, you know, we would aspire to reach even one of those stages. Dr. Soumya Swaminathan is having multiple, achievements to her credit. Dr. Soumya Swaminathan, as we all know, has also served as WHO's first chief scientist, and she played a pivotal role in coordinating global scientific efforts and was instrumental in setting up COVAX to ensure equitable vaccine distribution to low and middle income countries. Welcome, ma'am. We have amongst our panelists Dr. Ramya Ananthakrishnan. Dr. Ramya Ananthakrishnan is director of a non-profit organization, REACH. She's a medical doctor with a postgraduate master's degree, and she has been working for more than 2 decades in the field of tuberculosis. She currently had several initiatives of the REACH, and some of them being strengthening community system strengthening, private partnership models, case finding initiatives, empowerment of TB survivors, and their engagement to improve quality of TB care and quality of TB services. We also have the pleasure of having Dr. G. Narendran here, Dr. Gopalan Narendran. Dr. Narendran heads the Department of Clinical Research in ICMR's Institute, NIRT, located in Chennai. Dr. Narendran is pulmonologist, and he has been conferred FRCP London by the Royal College of Physicians, and he also won the prestigious Blackrock Thompson Gold Medal in surgery, and he has been engaged in clinical trials for over past 2 decades. And then we also have Dr. Sarabjit Chadha from the FIND, which is one of the leading agencies working in the discovery of newer diagnostics and ensuring their equitable access. Dr. Chadha is a clinician and a public health expert. with over 25 years of experience, and he is heading the country office of FIND and is also the regional director of Asia. And he leads the work in TB, COVID-19, hepatitis C, non-communicable diseases, antimicrobial resistance, lab strengthening, and amongst several other things. So welcome. And finally, we have with us Dr. Sameer. Dr. Sameer Kumta is from FIND, the Gates Foundation. Seeing this esteemed group of panelists, I'm getting a bit nervous, so please excuse me for that. And Dr. Sameer Kumta, Gates Foundation has been an important partner, and in fact, I would say driver of many of the TB works that's ongoing, not only just in India, but across the world. They have special supporting several works in research and innovation, which is also the topic of today, and they have been important partner for the WHO as well. And finally, we have one person, Dr. Tiara Pakasi. She is joining us online, and she is the National TB Program Manager for Indonesia. And Dr. Pakasi, since July 2021, has served as an epidemiologist specialist and head of the TB working group at the Directorate of Communicable Diseases Control and Prevention in the Ministry of Health. In her capacity, Dr. Pakasi plays a pivotal role in leading efforts to combat TB in Indonesia, which is a high TB burden country. And as the head of TB working group, she coordinates and oversees strategic interventions, research initiatives, and policy development aimed at reducing the burden of TB and improving patient outcomes nationwide. So, I'll just take 2 more minutes, and we know that the audience is eager to hear panelists more than me. The theme of this entire summit is scaling access to ensure health equity. And so why does TB and research in TB and innovation, or how does TB fit in there? Now, TB, we know, is a disease of the marginalized and vulnerable groups. So addressing TB helps us reach out to all those groups. TB has been included, the coverage on TB, as a proxy indicator for UHC. TB is also an entry point for integrated services. You can reach out to, you can implement multiple interventions when you approach TB patients, and which includes addressing some of the non-communicable diseases, such as diabetes, undernutrition, and other such comorbidities. And of course, TB is the greatest killer amongst the HIV infection. So there can be no better entry point. And we have seen that preparedness or investments in TB programs also helps us in pandemic preparedness. We saw during COVID-19 pandemic that the TB infrastructure, the equipment like the molecular tests were used for COVID-19 detection, the airborne infection control practices which were followed by TB, they became an example of how we could implement them for COVID-19. So with those words, I think I would now invite our chair of the session, Dr. Soumya Swaminathan. Madam, please, if you would deliver your remarks.
Yeah. Thank you. Good morning, everyone, and greetings to my co-panelists as well as to the audience. And I can see from people here that all of you are very, very committed and already very engaged in TB. So actually what we need is to reach out to people beyond the traditional TB community folks, because all of us are already 100% involved and committed. So I think each person here needs to think about how to enlarge the circle of people who understand what is happening with TB and what support patients need, as well as the program needs actually to make it a success. So whether you're from government or from a research organization or an NGO or a civil society organization, I think there are things which need to be done on the ground, which if we do more effectively and with renewed vigor, I think we can look forward to achieving the elimination goals at some point in the near future. So I just wanted to share some of my thoughts really on where we are and where we need to go. We know that TB is a disease that's been around for thousands of years with humankind. In a way, it's very different from COVID, but there are also a lot of similarities. COVID, of course, was viral. It was very new to human beings. It was a zoonotic infection. It was acute onset illness, and human beings had no immunity to it, and so it spread and became a pandemic. But the thing with, and then we were able to develop in record time vaccines, diagnostics, therapeutics, and we were able to actually make it from what it was, taking a lot of lives, to a more manageable and chronic viral illness, respiratory viral illness, like many other viral illnesses that we already have circulating in the human population. TB is also a pandemic, though we don't think of it as such, and nobody pays that kind of attention to TB as we did to COVID, for many reasons, because firstly, it's been around for a very long time, so no one really talks about it a lot. Secondly, it does affect the poorest and the most vulnerable in every country. So again, it's partly invisible and hidden because people who are well off, well educated, urban elite, it's not in the consciousness that TB is still such a problem. And whereas a disease like dengue, I often find it very amazing that when a dengue death happens let's say in Delhi or in any of the big cities, it gets picked up immediately by the media and is reported the next day. Of course, any death is a tragedy, and dengue is an infection that's really increasing in large parts of the world, especially in urban areas. But what I'm saying is that the media attention on something like that is so high, whereas for TB, you have still about 800 or 900 people dying every day of TB in the country. And I don't think that's in any newspaper at any time except on World TB Day or something like that. So it's invisible. That's also part of the issue. There are challenges, and let's talk about some of them. The first, let's start with mortality. So one of the targets for the TB, NTEP, as well as the global NTB target, of course, is reduction in mortality by a significant amount, 80%, 80 to 90%. So, and some countries have made huge progress. India has also made progress. We've gone from having a mortality of 35 per 100,000 to now, I think the latest is 22 per 100,000 population. But still, if you look at case fatality rates, they're in the range of 5, 8, 10%. They vary by state. Of course, it's higher for drug-resistant TB, but overall, having that kind of mortality for a disease that is actually treatable is of concern. And if you see, of course, TB affects people in the working age group. So majority of people who are affected by active TB are in that age group of 25 to 55. And so the deaths are also occurring in that economically productive age group. So if you calculate as an economic loss to the country because of having people in that age group out of work or very ill or then dying, then it is a huge economic burden as well. And if you add up all the secondary costs, then it will be much more. So I don't think there's been enough modeling analyses done on the economic impacts of TB on the country and how we could actually benefit from having less TB from that perspective. But more important than that is that these individuals who die are young, they have families, and so they are leaving behind, a spouse, young children, dependent family members, so what do we do about it? So the first thing is to understand the data. Are we doing a proper analysis of the deaths that are occurring? As you know, for maternal mortality, the government has, it was right from the MDGs, it's been a huge goal and a success actually. We have reduced maternal mortality significantly through certain, key interventions like institutional deliveries and better antenatal and postnatal care and so on, addressing the primary causes of maternal mortality, and the collectors of each district undertake a maternal death audit every month. And every maternal death which occurs, everybody has to sit together and understand and explain why that death was not preventable. So could we have a similar approach to TB death audits where the collector is involved, so the collector is also aware of how many TB deaths are occurring, monitoring it on a regular basis, having the death audit being presented by an independent. So I would suggest that a community medicine department or a public health department in a medical college in that state be assigned, or one or more could be assigned the task of doing the death audits. It should not be the TB program itself that does the death audits. And then it's presented and analyzed, and then the reasons for that death. So recently, a few months ago, I asked the LRS Institute, as you know, they run the difficult to treat TB clinic through the ECHO platform. So I said, difficult to treat TB is fine. Why don't you also start discussing TB deaths? So they picked the case of a young woman of 19 years old who had died in LRS and presented that case. And it turns out that it was a failure of the system. That girl was very poor, migrant family. Father had died of TB. Then she got TB. The sister got TB. They were going to private doctors because they were all working as housemaids, and they fell through the cracks. Probably they could not continue the treatment regularly. Nobody was tracking them or following up. And by the time she got admitted in LRS, she had very extensive bilateral disease and she ended up dying. They put her on the ventilator. They did everything. But a 19-year-old girl dies in Delhi of TB, drug-sensitive TB, not even drug-resistant or anything. So any number of such cases are occurring every day, but are we paying attention to that? Are we learning lessons? Are we trying to improve the system? Now, of course, we know we have the private sector also plays a very big role in TB. It's not only the public sector. How do we bridge that gap? What is the research that's going on, in this area? So one example of a research is the National Institute of Epidemiology, who worked with the Tamil Nadu government and established what's called the Tamil Nadu KET program, so to reduce deaths due to TB. Basically what it was is a better clinical management of the patient. Essentially, why does anyone die of any disease? You don't get the adequate care you need at the right time. So you may have TB, but you may have a number of other things. You may be severely malnourished, you may have high blood pressure, diabetes, any of the other comorbidities. You could come from a very poor background where you cannot get that care at home. Vulnerable, there may be stigma, there may be discrimination, the person could be an alcoholic. In fact, in the southern states, alcoholism is a huge comorbidity. We keep talking about other comorbidities. I've seen in the wards that I've visited that alcoholism is one of the biggest reasons for people becoming really sick, becoming non-compliant and being admitted. So if these things can be identified right at the beginning when somebody is diagnosed with TB, and it's not a rocket science. So whoever is in the primary health center who's starting the treatment, that doctor should be able to say this person has any one of the warning signs, is breathless, looking pale, has edema, not able to eat, can't walk without support. As a doctor, you know that this patient needs help. So then they should be admitted. Now the next problem comes, where do you admit? Very often hospitals refuse admission for TB patients for one reason or the other, infectious cases, both in the public and the private healthcare system. So then you need to have there has to be a sort of a order that a TB patient must not be refused admission, right? And it has to be brought under the PMJY scheme, so that hospitals are compensated for admitting a severely ill TB patient. Once you admit, then the medical team can take care of whatever the needs are, whether it is nutritional rehabilitation or any other comorbidity that requires management. In the southern states, a lot of people have diabetes, alcoholism, as I mentioned. They need insulin. They need the sugar to be stabilized. In the northern states, it's more likely to be severe malnutrition, severe anemia. Tribal areas, it's likely to be severe malnutrition, severe anemia. Many young tribal women who have died of TB, I've looked at death reports from the tribal districts. You'll have 21, 22, 23-year-old females in the list of people who've died of TB with no underlying comorbidities and with drug-sensitive TB. So I think the TB community here really needs to ask itself, what are we doing? Are we just going to accept this, and say this is all we can do? Or are we going to address the core issues over there? So for me, reducing prevalence and incidence will come later. It will come on its own. But let's reduce death. China has a death rate of 3 per 100,000. India has a death of 22 per 100,000. There is no reason why we should. So we need to find the gaps and address them and have a very ambitious plan. And this may be the same for other Southeast Asian countries as well. So I would put our short-term focus, I hope, in the next national strategic plan would be on reducing mortality, very ambitious target, which can be achieved. An incidence reduction is going to take time, whatever we do. We don't have a vaccine, right? So unless we start treating and finding everybody and treating them, you're not going to have very rapid incidence reduction. So that brings me to the second point, is that what we've learned from recent studies, including the TB prevalence survey, national prevalence survey, state-specific prevalence surveys. Earlier there was one in Gujarat, recently there's one in Tamil Nadu. Subclinical TB accounts for 40 to 45 or even up to 50% of cases, which means that you will not pick them up with symptom screening. And so far our program is based entirely on symptom screening. So straight away you're missing 50% of active TB in the population. So then what's the solution there? The solution there is more widespread use of X-ray, particularly when it is backed up by an AI algorithm, and many of them have been now green-lighted by the WHO, by the Stop TB Partnership, and by ICMR. So you have several good AI solutions now, and we also know that we now have handheld X-rays. So whether it's a handheld X-ray with which you can go into the village, whether it's an X-ray mounted on an MMU that's going from village to village, or whether it's an X-ray in a health facility, if you had the AI running at the back end, you would, and the experience from Bombay, where they did it in 6 hospitals, government hospitals, showed that their case notifications went up by something like 10 or 12% in a short period of time just by installing the AI for X-ray reading. So definitely I think there's no doubt about the efficiency and of such a solution, and the fact that it picks up your subclinical TB, which you're not going to pick up otherwise with symptom screening. So that's a big change. That's a very big change, because for all these years we have not been using X-ray as a primary tool, for diagnosis. So we need to make that big shift now and expand the use of X-rays. So that means more investment into X-ray, and we have to use it smartly. I think we have to make sure that we have the AI tagged onto it, so that we are not then wasting a lot of time waiting for radiologists to read it and so on. Radiologist comes in later. And then the next test needs to be a molecular test. So if you look at upfront molecular testing in India till last year, it was 30% of all people who got a TB test, got a molecular test as the first test. Now the CTD says that percentage has gone up Certainly during the 100-day mission, they tried to put a lot of molecular testing out in the community, but still the goal is 100%. So we are not near 100%. So if that can be our second target of trying to find as many people as possible in the community, clinical and subclinical, and making sure that X-rays are used widely for screening, and then we get an upfront molecular test, definitely our case notification will go up. And then the third thing, of course, is to make sure that everybody gets the appropriate treatment, the support, ensure compliance and completion of treatment, and that can also happen now through using, we have so much of technology that can be used, but human beings are not replaceable. I think in this particular instance, you do need the human beings, and perhaps we need a strengthening of the HR to be able to do this kind of intense follow-up. At least for first 2 months, people need to be followed up very closely, because that's when the majority of deaths occur. So this whole concept of a differentiated care, for which actually CTD also has guidelines now. We need a simple guideline in the front of every doctor's table, which talks about these high-risk, warning signs or something like that, so that every TB patient gets screened immediately. Very simple warning signs, and if it is, then admit, then what is the treatment, and then after discharge, the follow-up. Then, of course, there is the screening of the family, which is needed, the household contacts. That's where the X-rays come in. We have to make it convenient. People can't be expected to spend days just going and trying to get themselves screened. They're not going to do it. So we'll have to make it convenient for household contact screening. And then, of course, is the issue, is the preventive therapy to be given. And I think we need a little more data collection there as well, people who are taking preventive therapy, those who are not, what is the outcomes, how much of secondary infections are we preventing. And then let's remember the rations trial, which showed us that up to something like 48%, almost 50% of secondary cases, that is cases in the household, close contacts, could be prevented just by doing nutritional support. So I would say that at this point of time, nutrition seems to be a better vaccine than any other vaccine that we have. We don't yet have a vaccine with 50% efficacy. But if you give adequate calories and protein to people, particularly in a malnourished population, like where the rations trial was done was in Jharkhand, in a tribal area where the average BMI is probably around 16 or 17. So the average person walking around there has a very low BMI. And so when they're very prone, of course, then to get TB. I understand that the state government of Jharkhand is now, I was very happy to hear from Dr. Anurag Bhargava that the STO has now implemented the Nikshay Mitra program in a more systematic way, because the Nikshay Mitra program is an excellent program, but it basically depends on volunteers coming forward, and it's so everyone who needs is not getting, basically, because everywhere you may not have enough volunteers, and the ability to deliver it also may be limited, especially in the remote. So for the STO to take ownership, to get the donors, big donors, to make sure that the majority of patients will get access to nutrition, not just for themselves, and it's very good news that Government of India has enhanced the direct benefit transfer from 500 to 1,000 rupees, and that I think is being now quite widely implemented. So hopefully patients are getting 1,000 rupees a month that they can spend on food, on nutrition. That's not enough, we know that. So that's why the Nikshay Mitra program supporting families is very critical, but it needs to be organized in a way that it has a maximum impact and reaches a maximum number of deserving families. Not everybody needs, of course, we know, but a lot of the TB patients still need that. And then getting the right drug combination. So of course the upfront testing for rifampicin resistance also very important, following which we could, they would hopefully now increasingly have access to the BPAL-M regimen, which has started getting rolled out and hopefully can now accelerate and scale out so that everyone who has MDR-TB or pre-XDR will have access to the BPAL regimen. So I think on that side, the CTD made some very important changes last year. One was around the DBT, then around the BPAL-M rolling out and the training and building that. And the third is around the nutrition support for TB patients, which also was part of the policy that was rolled out. And extra nutrition support for all those TB patients, less than 18.5 BMI for the first 2 months. So I think that is, as far as the programmatic implementation is concerned, how the private sector is going to, hopefully Ramya and others will talk about what are the ways in which we can get communities more involved. They've worked a lot. Reach has worked with the TB champions. A network, I think that was a successful model. How do we build on that? How do we build on experiences with private hospitals to get them also to do the right thing? And because we know 50% will still go to the private sector. So it's not enough to just have the public sector, doing it. But even within the public sector, there's a lot that we need to really improve. And the voices of survivors from all walks of society are going to be very important. Somebody who's actually gone through the experience of having TB, being diagnosed or diagnosed late or diagnosed early, what support did they get, how quickly were they diagnosed and given the right treatment, were they followed up with the right kind of clinical care and so on. Those things are going to be important feedback for the system to improve. So yesterday we were talking in another session about learning health systems. Health systems need to keep evolving and learning. You cannot launch a program and then have it completely static, because any program when it is launched will do so with certain assumptions, but then you find actually in operationalizing, you'll find there are a lot of learnings on how you could do things better. So those learnings must come from people on the ground. The STS, the STLS, the TB HVs, the ASHAs, and of course the patients themselves. They are the ones who can actually tell you what works well and what doesn't. So we have to make it a point also to have a forum where their voices are heard, so that we can improve the way in which the program is designed. So I think research and innovation is going to be important. The TB Innovation Summit, which the ICMR hosted last month, was very impressive. I think there were more than 250 startups and entrepreneurs and who were, had all sorts of ideas that they were showcasing on better diagnosis, better treatment, monitoring, follow-up, and all of that. So it was very nice to see that. And so the challenge will be to really take the most promising of those innovations and quickly sort of study them, validate them. If ICMR or DHR could do that, do the health technology assessment, and then get it into the program so that these innovations become useful, not just for patients in India, but I think across Southeast Asia. So since we are sitting in a session which is really CRO, and TB is a high burden in many of the countries around us, India's innovation can actually help the region as well. And then there was a separate session yesterday on TB vaccines, so I won't speak a lot about vaccines, but certainly that's an area where more investment is needed, more regional investment, focus on R&D, doing clinical trials together, trying to advance the most promising candidates, using innovative trial designs, setting up platforms. We don't necessarily have to spend hundreds of millions of dollars on these clinical trials. We know that we can do them quite efficiently, but that requires good collaboration. So maybe having a Southeast Asia network for TB clinical trials and also adoption of innovations, promising innovations, could be something that the CRO could lead. And of course, to adopt innovations, you're going to need funding. And so countries must enhance their domestic funding, but we could also look for other sources of funding to support the, at least the testing and uptake of innovations that could come from philanthropy, it could come from other sources, and a Southeast Asia regional fund for TB might be a good idea, something also that could be floated, where we could focus on some of the gaps and challenges that we see. So finally, I just want to say that, the R&D and innovation is going to be extremely important, and all types of research, not just research on new innovations, but research from the ground, as I mentioned before, on all of these barriers that people face. So what you call implementation research must continue, must be strengthened. and really looking at how to improve the performance of the health system, and then have maybe regional goals around mortality in the first instance that we could achieve within the next 2 years, and that will give a big boost to the program. Because if you put an elimination goal or an incidence reduction goal and you see slow progress, that could be demotivating. But if you put a goal which you can all get behind, and who will not get behind a mortality reduction goal, and we can show significant progress there coming together, then it gives an additional boost actually, and say yes, this is a problem that is solvable. And there are countries in our Asia Pacific region that have done it, that have brought mortality down to very, very low levels. So I firmly believe that it's doable, and it's not going to be rocket science, but it's going to be attention to detail and good clinical care, and basically treating the person as a person who has a serious illness and a disease which needs clinical care, not just prescription of drugs. And sometimes that happens. That tends to happen also, that you just write the drugs and then you expect that everything else will be fine. So we know that TB as such, from ancient times, has been described not just as a biomedical but as a social disease, because of all the vulnerabilities that people have when they develop TB, in addition to the stigma and so on that they might experience. So I think that's really the way forward as far as I'm concerned. So I'm very happy to listen to the other panelists, and hopefully, as I said, we look forward to seeing the new national strategic plan in India, but also in other countries, and see what the CRO can do really to bring different stakeholders together to address this very big public health problem in our region. Thank you.
Thank you, ma'am. Your remarks were insightful and inspiring. I think you have provided a synopsis of what needs to be done to address this age-old problem. A few points that I got was, proper analysis of available data. I think that would be part of research and innovation that we do. We need to count on what are the losses, and specifically economic losses due to TB. There could be TB death audits, and that too by engagement of non-program partners, which could be medical colleges or someone. The emphasis to diagnose asymptomatic TB patients, people who do not present with any symptoms, increased use of AI, and above all, the engagement of communities. And those who are most affected by TB would actually lead us to the ways in which we can end TB. So thank you so much, ma'am. And we, of course, will take forward your ideas on a Southeast Asia regional collaboration mechanism on various aspects, and specifically research and innovation. We'll work around those things from the regional office. Thank you. So now that we have already heard that communities are kind of center for whatever we do, and of course, why not? Because they are the ones who suffer, and those are the ones who know what the needs are. So now I would invite Dr. Ramya Ananthakrishnan. She's from REACH. Dr. Ramya, you have worked closely with communities for their empowerment and engagement, and specifically, how they could work along with the programs for TB. So from your experience, what are the community expectations regarding research and innovation to make TB services more accessible and affordable and also acceptable? And of course, if you would like to add elements of private sector engagement, as Dr. Soumya has mentioned, maybe you could do that as well. Thank you.
Thank you. I'd like to thank Chair Dr. Soumya Swaminathan and moderator Dr. Vineet for giving us this opportunity to talk about the need and importance of community engagement, not just for the program, but also for research and innovation. So I think when we think about research, it's research translating to evidence, to translating to policy, to practice. those are the different steps. And communities play a very important role at every step, right from understanding the community needs to actually taking what is in the policy to practice. And that has been our experience in the last, now it's 10 years that we've been working with the communities. In fact, I was very pleasantly surprised that I was asked to go first in this panel, and usually I go last, but this time I'm going first. And I think that shows a true bottoms-up approach that we need to adopt when we talk about bringing research and innovation and marrying the concept of research with the community participation. So very briefly, just to set the context, REACH has been working very closely with the affected communities for the last 10 years, and what we have learned from that experience is that they are keen to play a very important role in providing back to the program in various capacities. The TB champions, they are called, they are basically survivors who've been identified, trained, and engaged to become TB champions, and they have played a very pivotal role, and they continue to play a pivotal role in providing psychosocial support to other people with TB, and also in actual service delivery, in addressing gaps, and also looking at what the community feels, the feedback from the community, and creating this awareness among the community on the TB program itself. So the TB champions basically are the pulse who help us understand what the community needs are. And I think what we have also learned is that we have innumerable examples of how we could structure community engagement in various aspects of research. While working very closely with the affected communities, especially the TB champions, we found that there was a need in the area of elderly, the elderly faced many challenges. People with disability faced many challenges in accessing TB services. So this led us to doing a kind of a rapid assessment on TB elderly, TB disability. Similarly, we also found the huge barriers with respect to gender, and that led to the whole gender assessment. So working with the communities basically helped generate ideas for research. So we were able to take what they found at the ground level, the things that they come across in their day-to-day work when they work with other other people with TB or with the health system. That raw information we were able to convert to these rapid assessments. Basically, we undertook these rapid assessments, which is like a quick and a easy way of assessing what the gaps are at a very macro level. It involves a combination of in-depth interviews and focus group discussions and literature search, and where the community feedback is very much ingrained in those. And we've come out with rapid assessment on TB elderly, migration, gender, TB and migration also. So I think what we also learned in that process is once we come out with these rapid recommendations, and there are recommendations in these assessments, we again need someone to help take these recommendations to the ground. And that is again where the communities play a very important role. So they are actually playing a very important role in this bidirectional of giving us the information as to where we need to look when we want to do research or when we want to innovate, to actually taking back what we feel is the best solutions. And I think that is in any true epidemiological sense, that is the entire cascade, right? We understand the community needs. We undertake a participatory learning approach to understand what the community wants and take that for a research. We also have, again, innumerable solutions as to how these information, when we look at community engagement and participation, it's not just generating scientific evidence. They also generate a lot of information as community feedback. And I think that is as valuable as all the scientific publications that come out, because community feedback helps us to get information immediately and also helps in action taking. And it's not the traditional scientific research process, but still it helps to generate instant local solutions at the ground level. Just to give you a few examples is that as part of community gathering, information gathering, when the TB champions found that weighing machines were not there in the health centers, and our entire TB treatment is weight-based. No, so how do you even treat? And especially when a patient has to move from IP to CP, no, the dosage itself is going to be different. Otherwise, we are just giving suboptimal doses. So, and they found that entire district is not having weighing machines, and that information was collected, collated, and presented to the district TB officer, and who immediately arranged for the weighing machines to be purchased in all the centers. So this is a very simple example of how data can lead to action. And this is, of course, very non-scientific, but again, this is very valuable information when we talk about community innovation. Similarly, when people got ostracized and they couldn't afford housing, and they were actually were not eligible to apply for a loan, we had the TB champions supporting the people with TB to help them facilitate access to loan and make sure they got housing. So we have innumerable examples of how the TB champions gathered the information as part of their whole community monitoring and community accountability, and help generate local solutions then and there. And also use that information, very evidence-based, to actually advocate with the program for policy changes. So I think when we talk about the engagement of communities, as I mentioned, our learning in the 10 years has been that they need to be engaged and involved at every step. And they're quite interested, and I think sometimes academia and research sees them only as end users, and I think we really need a paradigm mind shift. We need to engage them at every step of the way. We've had the chance of working with them even for developing questionnaires, methodologies, and they have really helped us in giving very valuable inputs as to how we should go about into the community. What kind of questions would be culturally appropriate, what language which we could ask the communities the questions about. So I think things become very easy when we engage the communities and involve them. And why do we do all this research? Why do we do all this innovation? It is basically so that we can take it back to the people, right? And that is again where another area where the communities play a very important role in taking whatever strategies, whatever solutions we have, we take it to the community and take it to people and make them accept the solutions. We had one example where people were, the TB champions were doing an active case finding effort along with the program. And in fact, it was very funny, it just happened 6 months back, and they met DDG. And they were saying, we take so much of effort, time, resources to go and do active case finding. And then the sputum samples are getting tested for microscopy. So shouldn't we be doing NAD? Right? So that was a kind of advocacy they were doing with the program, and stressing on, two things they highlighted. One, that was not happening when they were doing the active case finding. And second is how, empowered they've also become, understanding the challenges in the community and able to pick up. And I think for this, we need to engage with the communities, not just as a tokenism, but it should be a continuous process. We need to engage them, we need to train them, we need to talk to them about the various things. In fact, in the last 10 years, when we have been working with the TB champions, we've trained them innumerably on various aspects of how to read data. No, that was what, I mean, you cannot survive in TV program without understanding the incidence or the graphs and the mortality. So data for action, no? So training them on how to read data, how to interpret data, because that is how they can actually look at a graph and say, oh, the mortality is high, right? And it was, like 10 years back, this was this mortality. That district has a better rate than us. So I think that data for action. So we had the opportunity to train them. We also train them in communication. So how to take information, not just to the community, but to policymakers, to panchayat leaders. You do an elevator speech, or you have like a 20-minute community-based program. So I think this kind of continuous training is very important. Training them on basics of research methodology. In fact, the assessments that I talked about. So we have packaged like a community rights, gender, stigma assessment, which we train the networks to actually look at what could be the potential gaps at a state level. Is there a match between the needs where the vulnerable population are and where active community screening is taking place? Whether any particular gender are getting ignored in the active case finding effort. So this CRGS assessment, so we also train them on how to look at data, how to do these quick assessments so that they can generate data instantly and feed it to the a system for action taking. So I think in all, we feel when we want to engage with the communities, we need to constantly keep them knowledgeable. So constant training is very important. And in fact, Dr. Soumya was mentioning about the Tamil Nadu Kasano Irapilla Thittam. So there also, it's where people with very low BMI are asked to be admitted, and so that the mortality is reduced. So we were working, the TB champions were working there, and we found that we couldn't get them admitted because there was nobody, there's no attender. So, and every government hospital needs an attender to get admitted, and they cannot get admitted without that. So TB champions spoke with the health system, and they tried to arrange someone who could be with the patient, because the family member, there was no family member otherwise available, or because of stigma, they didn't want to stay. So I think these kinds of practical challenges, which we'll always find while doing research also, I think TB champions have a very important role to play, right, in understanding needs. They play an important role in generating ideas for research, to set research agenda, to find out local solutions for the gaps that they find by mobilizing local resources, by identifying the community influencers, and also for taking these solutions back to the community so that they accept it and they use it well. So I think this is, again, I just want to say that the very fact that we are starting with the community engagement and the need for that, I feel very encouraged, because this is very important. So they are the first step, they're the foundation, and very happy to know that the rest of the talks are going to be layered on community engagement. And I think we have to move away from the traditional research terminologies that we use, sensitivity, specificity, positive predictive value. I think the way forward, we should be sensitive to the needs of the community. We need to be specific to the vulnerable population. Positive PPV is not positive predictive value, but it should be public and participation value. ROC is not just receiver-operator characteristic, but it should be understanding the rights of the communities. And the CAPA agreement is not just for 2 tests, but it is to look at how the communities and the research community can agree and work together to produce and take the solutions of research and innovations. Thank you very much.
Thank you, Dr. Ramya. I think that was a very interesting and captivating speech. and probably that's why you were amongst the first amongst the panelists. You talked about the more than community engagement, what we say these days is a meaningful community engagement, which means we need to have them in designing, in implementing and monitoring at all stages of any TB activities. And as you said, community feedback by itself is important to get the local solutions rather than thinking something anything else. And finally, I would say the important part is also the solidarity and peer support that communities can offer to other TB patients, which is so important to make sure that the people are able to adhere to treatment and receive the proper treatment. And that would also support what Dr. Soumya said in her inaugural remarks, that it's important to reduce the adverse outcomes and specifically the mortality amongst the TB patients. So thank you so much. Before we move to the next panelist, ICT, is Dr. Tiara there on the line? Yes. So may I now request Dr. Tiara Pakasi for her intervention. Dr. Tiara is, as I introduced earlier, is the National TB Program Manager for Indonesia, which is another high burden country in the region. Dr. Tiara, Indonesia has done some remarkable work in ongoing research and innovation in the field of TB. So as a program manager, please share your views on what are the key policy decisions that create a research enabling environment. Over to you, Dr. Tiara.
Yeah, okay. Thank you, Dr. Finet. I would like to check, am I audible enough to you all?
Yes, you are. Thank you. Please go ahead.
Okay, thank you, and respected delegates and participants, and also panelists. I'm Tiara Pakasi from Indonesia. Thank you so much for having this opportunity to share with you my point of view with regard to the questions Dr. Finet has explained. So I will start responding from a policy perspective. I think it is also shown in the video animation that was shown by the meeting committee that Indonesia have demonstrated a strong commitment to a research and innovation through the presidential regulation 67 in the year of 2021 on tuberculosis control, in which one of the strategies in national TB control in Indonesia states the importance of enhancing research, development, and innovations in TB control that will later on shape our TB control policy. And besides that, Indonesia has the National Research and Innovation Agency as the central institutions, besides research centers in universities and also in some subnational governments. So secondly, also maybe shaping into TB, national TB program itself, to create a research enabling environment, we also clearly outlined this commitment in the national TB strategy, the multi-year national TB strategy, I should say, which includes some activities. First is the establishment of research and innovation network or working group. We call it the Jet Set TB Indonesia, where this Jet Set TB has just celebrated its 8th anniversary this month. So this independent network consists of mainly academicians, but also some researchers from the BRIN, the central institution, and also some TB clinicians, researchers from different universities, TB survivors, come academicians, and also researchers, and also some researchers from, I should say, like not a private university, yeah, something like that. And in NTP, together with this Jet Set TB, to guide researchers with national TB program needs, we've developed also together the TB research priority agenda. This is to ensure, but not limiting, yeah, that TB research in the country is aligned with our national TB program priorities. And as I said, it's not limited. It's not limiting the activities. We also keep everything. We try to keep it up to date and up to the current situation and need, where they are independently can do or propose some researchers and collaborate with if some development agencies or universities in overseas. Okay, and then of course we need also to monitor the result of the research, etc. So to keep the priorities in line and up to date with the current situation, each year we conduct discussion with researchers to jointly review the studies that have been conducted and also to formulate or reformulate follow-up plans based on those discussions. With these approaches, it has been helping us in ensuring that research research findings are translated into actionable steps, and also that future studies remain relevant to the national TB situation and also national TB program needs. So that is how we've been doing it, and I think I'm summarizing now my remarks that to create a research enabling environment in Indonesia, we have a bold high policy with regard to TB control that incorporates the TB research and innovation to be enhanced, and followed by collaborative action among key stakeholders with one objective, yeah, to strengthen an evidence-based TB control policy in Indonesia that is aligned also with the dynamic of TB situation, of course, in the world. And some research that we've been doing is currently, of course, Indonesia is participating in the novel TB vaccine multi-country studies. And also we have some new policy that is based on our recent operational studies, such as the innovative financing in primary healthcare. I think I will stop here and I offer to Dr. Finet. Thank you.
Thank you, Dr. Pakasi. You provided the great examples of how Indonesia has encouraged and embraced research. We heard that you talked about the Jet Set initiative, which is a kind of network of academicians, clinicians, researchers, when they all come together. I think these examples can be replicated by other countries in our region as well on how you are promoting research in Indonesia. And so with that, I thank you so much. I'm not sure how long can you stay, because there could be some questions later, but we'll come back to that after all panelists have spoken. Thank you so much.
Thank you.
Sorry. So after that, we move to Dr. Gopalan Narendran. Dr. Gopalan, you have been closely involved in TB research and also keeping a watch on global developments in the field of TB research. We would request you to share a landscape of what's happening in the field of TB with the audience.
First of all, I'd like to thank the organizers and as well as my guru, Dr. Soumya Swaminathan, because whatever I have learned, what we learned was primarily through her. So true leaders do not make followers, but make leaders. She's one good example of that. So I joined her team in 2002 when there was no ART available. So we joined the HIV-TB team. We got pricked thrice, 4 times, 5 times, no drugs to act, only psychological counseling. So every doctor is a psychologist. So there is no differentiation or segregation of community from medical treatment. So he's first a psychologist trying to have the patient as a human being rather than looking with sensitivities and specificities, what she said. So that's a very good point, what she added. The platform has been very nicely set for me because now I'm looking into the farthest of research. Then why do we require research? So if I ask you, give me a question which is important for reducing TB. Each one of you will give me a question, and none of you will say that my question is inferior to the other person's question. Is it, do we have the luxury of taking 40 research questions and trying to go about with all the 40 research proposals? Now that is where the data comes into play. How good are you? How strong are you with your evidence? It's really difficult to do research for one good reason. Understanding research itself is very, very difficult. I'll just cite a true story, probably of a little damaging language. Please bear with me. So this was a CMC mathematics professor who was in a school teaching children. So the mother came to the principal and said, you have to remove your maths teacher because my son is horribly reading maths. So what happened? So she said, my son has started reading 2 + 1 son of a bitch 3, 3 + 1 son of a bitch 4. Now, I'm not able to tolerate this language. Then the principal said, I cannot believe this because he's a very, very beautiful maths teacher. He's got a very good way of communication skills. So the maths teacher was called, then he was asked to explain. So the maths teacher said, I keep teaching my children 2 + 1, sum of which is 3. If you interpret in this way, I'm not responsible for it. So research interpretation is not very easy as people think. So I'll try to make things as easy as possible with my slides. So this was one of the integrations which was done by ICMR. I should be really grateful, and I'm proud and privileged to say I'm from ICMR because exactly what was told by the former 2 speakers, my guru as well as my colleague, we have made what is called an integration. Even yesterday when ICMR was doing a session, I was really surprised to see, I think one of my friends, Dr. Hansraj, is here. They started from the, what you call it as, from the program people, and then went up to the funders. This is the first time seeing a funder being asked, will you be happy to fund my project? So that is what is integration. Now, integration and collaboration is what is the need of the hour if at all we want to bring down a disease which has been living with us for ages. I was just telling one of my friends outside the podium saying that don't think that just research has evolved, scientists have evolved, medicine has evolved, even the bacilli has evolved. We are dealing with not with a virus, we are dealing not with a bacilli which has multiple forms. And we, from the Rig Vedas, from the pyramids to those photographs which were shown yesterday, up till now, things have changed. But we have not realized that TB also is evolving. So with that, I'll thanks to the organizers for putting this already. So for the want of time, I'll go to the newer approaches to drug trials. What has been done? The most important is what Dr. Ramya was telling. Now we have gone for what is called a pragmatic approach. Previously, NIRT was known for hardcore trials. In ideal situations, what is required. But now we have gone into a system where we are looking at the community. So if this is what I learned from ICMR as well as from WHO, saying that when you, what the meaning of pragmatic is, now we are not looking at a trial just for the sake of getting new drugs. Because it's a long story, actually. It's 20 to 30 years for any new medication to come into the market. My son often criticizes me saying that, what have you found out? Tell me one new drug you have found out. You have been telling that you have been in research for the last 2.5 decades. What have you found out? I said, it's not an easy question to answer. But sometimes, yes, we have found out certain things. And so one is pragmatic trials. Pragmatic trials means we want to know whether we can translate it into the pregnant people, vulnerable population, people who have compromised liver damage. And that is how trials have actually evolved. And now we are going into one more thing, what is called the integrated approach, where whenever, even yesterday we had a meeting. So the idea is to integrate community, integrate program, integrate the funders, integrate the pharmaceutical industry, and more importantly, come out with solutions which are economical. I'll come to that in a little later. But now we have a lot of designs available. So I'll try to simplify it for the sake of everybody. The MAMS design is called multi-arm, multi-stage design. It's typically, I'll give the analogies, it's like what people do in the 10th standard and, in the 9th and 11th standard in schools. They take and pick out those students or pupils who are doing well so that they get the best answers in 10th and 12th standard. This is simply the MAMS design. You go with multiple arms, but those have a fixed, but it's not like according to whims and fancies, you fix the thing. You say that a particular value of success rate should be there in these arms. And if it is there, I proceed to the next stage. And you raise the obstacles. In the second stage, I have 60% success rate. In the third stage, I have 80% success. And finally come out. In this way, we don't have to waste our resources. That is the MAMS design. The second one is the stratified medicine concept. Now, when I am going, how clinical trials are now evolving with respect to what is the need of the community. The second one is the stratified medicine concept. Suppose I have a pumpkin and give it to a rabbit. What we accept is toxicity. But I have a very small banana, I give it to an elephant. It will keep, like what yesterday it was happening, some people had to go without food. So it will be the same condition. So now that concept is also coming into a big, coming up in a big way. If you look at the regimens, why are we not able to shorten regimens, TB regimens? Because the fundamental point is that 85% of patients do not need more than 4 months. 10% may not be able to curtail their disease with 4 months. They require at least 6 months. And 5% may require longer than that. But the question for the researcher or for the clinician is, which fellow falls into which group? That's the most difficult question for us to answer. The last one is the seamless transition trials. It's a very good method for the investigator, but it's a very troublesome one for the institutional ethics committee, where what we are trying to do is we say that these are all the fruits which are going to eat, and then we go to the next thing where we say these are the fruits which are actually more tasty, and I will not come back to you for permission and go back with this. Here there is conservation of time, but on the other hand they will have ethical values. So I just made it as simple as that because my basic motto is keeping it simple and straightforward. So now what have we done? We have come to newer drugs with better efficacy, as Madam was telling that we had come to BPALM. But what after BPALM? We have to have some kind of a longer vision. So with the BPALM, whatever drugs you have found out for the last, let's say till the 3 years back has already stopped. Now what if the patient develops resistance? What drugs do you have to treat? And not all patients will be suitable for BPALM. So we need alternatives. We need not only alternatives, but effective alternatives. So we are going with lots of newer drugs which are coming to the market, and the most important point is 3S. We used to call Madam as SS, Soumya Swaminathan. So we want 3S. Simpler, shorter, and safer regimens, which is our motto. So with this, I'll go into artificial intelligence. There are two things which I always get fascinated when we talk of artificial intelligence. Every domain has artificial intelligence impregnated with it. So when I made this presentation, it has taken 2 hours for me. When I told my son, he did it in 15 minutes. I said, don't do this way because you will totally lose your originality. So that's why now we are very happy that some of the manuscripts are checking you with have you used artificial intelligence. One is that medicine is a science of uncertainty and art of probability. This is what William Osler said. The second is what Jeffrey Hilton, he's the father of artificial intelligence, this is what he said. First 4 times, why I'm worried is the first 4 times, it will listen to the human intelligence. The 5th time, artificial intelligence dictates artificial intelligence. So this is what people don't understand, that artificial intelligence has to be trained like a dog. If you have a good master, it will help saving and guarding the house. If you have a bad master, it will start biting everybody in this room. So that is what you need to be careful about. And most of the times it is being picturized as if artificial intelligence is going to replace the physicians or any field. Obviously it cannot. The idea of artificial intelligence is to play a major role in reducing the time which is required, especially if you want a specialist to see the chest X-ray, or in places where, like what she was telling, even a weighing machine is not available. The idea for us to develop this X-ray software is We had already started there are so many softwares available. So if you can ask me what is new about your software, this is one indigenously done by our group. What we are trying to now do is triaging, because we was told that we have to prioritize admission. You cannot put all the patients into admission because there are lots of socioeconomic factors involved. How many of you were very, very happy when you were told that you had COVID and you have to stay in some place for 14 days? So it's not practically possible to put incarcerate some guy in a ward and then say that you will be all right. Most important, what is required is affection. You cannot get the affection from your attender. You can only get the affection from your relative, especially those whom you trust. So the important thing is, if you look at the first X-ray, even I was not able to find out whether the cavities were there or not. So when we teach students, we say, probably you can see this cavity here, there, this thing. But you see the next X-ray, even a layman will say something is happening on the left side. So this is what we are planning to do, trying to have what is called a heat mapping. You can very nicely take the photographs because there's no copyright involved, it's all ours. So this is what we are trying to do. The second thing what we are trying to do is look at a chatbot. You take the X-ray, somebody goes from, let's say an attender, takes a click of this X-ray and then sends it to the center, then you will get the answer whether the patient has improved, patient is static, or patient requires attention or is doing well. So that kind of a confidence can be given, but we are in the second stage only. I cannot say that we are just differentiated between normal and abnormal, because the basic foundations here is we require two wheels for a cycle. One is from the physician side, other is from the computer fellow side. And both have to be at the same speed for us to get these answers. The second one is the coffee. Most of the times coffee has been used as a square peg in a round hole. The reason why I am saying is coffee is more attached to the physiology of the dynamics of respiratory system rather than due to the anatomy. So one of the times I had to tell that I can now mimic a cough of a COPD, of an asthma, of a TB. And now that virus infections are causing real havoc because more patients are taking X-ray, because most of the viral infections take 6 to 8 weeks for the cough to settle down. And the pharmacy people are very happy because I can see enough number of prescriptions of Monter and Monter LC and all those things given. But we still do not know which one is actually reducing the cough. The problem in TB was many people don't understand the two spectrums. If you are hypoimmune or hyperimmune, both can cause problems with your TB. So what we are trying to do is trying to anticipate complications because of cough. Again, I'll give you a very simple analogy how you can use coffee. Hold an empty bottle and start pouring water into the can. Even if your closed eyes, you will be able to feel that the sounds keep changing. You will know that the tumbler is full. That's the basically idea of how to use the coffee. Geospatial mapping, my friend Dr. Sriram is here. He has done wonderful work in national this TB prevalence survey. So this is his slide where he has shown that we want to actually tune our heat map, that is the hot areas with respect to diagnostic network optimization. I was actually fortunate in this meeting of climate and lung health. I was asking that what climate has to do with TB. Every year we are having enough cases, people are coughing, maybe a little less. We have seen that in summer that people are, the other answer could be that people go for vacations rather than coming to the hospital. That could also be there. So the important thing is that many lands are getting submerged. In the same way, you can use there are farmers who are using apps for forecasting weather. The same thing can be forecasted to the patient saying that you please come and take your drugs because tomorrow we are going to have a cyclone, you need not come. Then the last one is with respect to toxicity and drug adherence. This coordinate is not actually the coordination between patient and the physician. The coordinates is actually longitude and latitude. Again, I'll give you an analogy. How is your cab when you book a cab? I book a cab for my son or for my daughter from Delhi. It will immediately ask, it's not for you. How does it check? Just looking at the coordinates. So the easy way for us to monitor adherence, even without the patient asking, just have a casual chat with the telephone and then keep asking him if you have an app. Where are you? How are you doing? How are you taking the drugs? If suppose he is in Delhi and he says that I'm in Chennai, you can easily find out that. That is the way we are trying to do a surrogate monitoring of these patients. The third one, what we are doing is, we are doing it with the CDAC. Now, the BPALM, one of the basic problem with BPALM is the L, linezolid. I don't know how many people know that linezolid brings down your hemoglobin. So I was fascinated to sit in one of the AAs where they asked me to just sit in front of the AA, and it calculated within 30 seconds. You are not supposed to turn your head. It calculated my BP, it calculated my pulse, it calculated my saturation, it calculated my hemoglobin, and also roughly my sugar. You don't have to prick anything. It uses the facial artery pulsations as well as the pallor, which can be easily seen. So the patient can, what we are trying to do is take a selfie, send it to the physician. We know whether you are having a toxicity or not. But again, it's in the phase of phase 1, and we are not very nicely said. Which is the best vaccine available now? I'm the same boat as what you are. Which is the best TPT available now? It depends on the community's preference. But the best one is nutrition. I'll tell you a very good example. Please do not reveal it this alone, because this is still, we are yet to publish it. We had a diabetic study. I always keep telling my folks. We had a diabetic patients, almost 457 patients. The control was quite less. And we started following them for nearly 2 years, because as a teacher in pulmonology, I knew that diabetes, anywhere you put, is a common cause for any of the risk factors for any of the diseases. But then we did not have a single case of breakdown. Can you beat it? And the reason was that we found out that the only thing could be their BMI was nearly 23 to 26. Whereas for the TB patients, quite less. But that means even though they are diabetics, the body is able to adjust itself. The only problem is that nutrition plays a very vital role. And when the ration study was a very nice study, because we have very few clinical trials in nutrition where they found out that transmission comes down by 31% in the contacts when you give good nutrition. But then there is a catch, even in the same trial. You read between the lines. If you go and read the study carefully, what we found was those patients who were given nutrition, those patients who gained weight actually had a better outcome than those who did not. That's where cachexia comes into role. That means you are having a hypermetabolic state. The same findings we found in our HIV study with TB, which we published in probably 2018. Those patients who had a low CD4 at baseline did not have a problem, but those who remained low at 2 months had a problem. I go back to Abdul Kalam's saying that, I thought you were asking me to stop. So, failure is not when you fall down, but you fail to get up. So those patients who are not able to gain weight, now we have to go into inroads saying that, why is this fellow not gaining weight despite the same nutrition? So there are lots of other things behind it. I think DBT has taken this in a very, in a large scale, and they are trying to find out what exactly causes cachexia. And in layman's term, every TB patient, whomever you interview, they will say that I'm hungry. But when you bring the food to them, they'll take one tiny morsel and say, enough, I don't want to take. What is causing them to refuse the food? That is what needs to be the research goal. Biomarkers are coming up in a big way. See, precision medicine has been the days of the time. I have specifically confined myself to the Indian data. The reason is tomorrow, because we need in-country or in-house data for us to tell our regulators. One of them was, I was really fascinated, was the one by Nagasuma and group from IISc, Bangalore. What they tried to do was they found out some biomarkers. They were host-based. They were not pathogen-based. So you can use it for DRTB as well as DSTB, EPTB as well as pulmonary TB. So that was the advantage of these host biomarkers. And the most important advantage was they were able to predict something at 2 weeks of treatment when the patient could die at 2 months. So this kind of a prediction helps us to take better care of a small subset of patients and not bother everybody putting them in admission in a hospital. So this kind of segregation of stratified medicine is very, very important. What about NIRT? So what we tried to do was we looked at the biomarkers for progression from infection to disease. We had contacts, it was a huge group actually. We had almost 2,000 to 3,000 contacts we had. We just took the patients who broke down with disease, and then we had age, or because it's a propensity score, we had age matched or comorbidity matched non-progressors, and we found out that there were 5 biosignatures. We call it biosignatures because it's a collection of 5 cytokines. So they were either upregulated or downregulated, and these same 5 biosignatures was evaluated in a totally different group that was in Brazil, and we came to identical findings. Now we are interested because both the countries are now interested to see if we can go about, because ICMR is not bothered about looking at the publications. That's what our DG always say, we want some product. So can we have some product or something like that where we have these biosignatures? And this again, most important point is 6 months before the patient breaks down with disease. Prevention is always better than cure. So if we have these biomarkers which are concrete, then we have an idea what to do. The other thing is going one step ahead, looking at the host biomarkers. We have gone 3 steps ahead. We are also looking at proteomics. We know that malic acid and one more arachidonyl glycine are we can say that these levels are raised. Most importantly, in those who are responding to treatment, these levels go down. So looking at the slope of decline or the slope of progress, we'll be able to understand whether this guy will break down with the disease or will not break down. This will become very useful in vulnerable population, because you say diabetes is a vulnerable population, but you know that I don't have to tell anything about the population of diabetes in India. Such being the case, how many people are going to give TPT? How many people are going to do this? So when you look at a cost-effective approach, we need to have some kind of precision medicine built in. Finally, this has been discussed at large, so I don't want to. So the last column is the promising group of vaccines we have. But again, you need to understand that you need to first very enthusiastically as well as in a vigorous way see if the patient really has TB, because now the concepts of subclinical TB, asymptomatic clinical TB, clinically symptomatic but bacteriologically negative TB, now all these medical confusions are already there. It's not a new entity as such, because every disease starts as subclinical. You tell me one disease which immediately comes and then pounces on you. It's not a black panther sitting on the tree and just pouncing on you at the back. Only thing is we fail to recognize the symptoms, or we fail to understand that there's something which will happen, and then it comes out of the surface, and then it surfaces out. But the most important point for us to learn is, as far as vaccines are concerned, is looking at BCG. BCG, again, I want to stop with an oxymoron statement, is the most extensively studied vaccine in the worst of controversies. So problem is, we know that BCG is good, but how good it is simulating or trying to mimic the TB virus. The TB bacilli, the Mycobacterium tuberculosis. This is Mycobacterium bovis. So the recombinant, the problem for us is it's not exactly similar. And the other thing is, it actually helps in a particular section of population, the younger age group. So if you ask me what is as on date, what is your advantage of using BCG, I'll say if you are able to give it early to a patient or to a younger population, which is residing away from the equator, and without the problem of non-tuberculous mycobacteria, your efficacy will be greater. This is what we have found out. It's a systematic reviews of various countries which are done, including the Chengalpat BCG trial, the Malawi trial, as well as the Brazilian trial. Even in Brazil, the interesting thing was they had 2 or 3 centers which were closer to the equator and away from the equator. Away from the equator, they were able to have better efficacy. Closer to the equator, they were not able to. What is the exact reason? We do not know. Now, M72, MTBVAC, and VPM 1002 are promising, but we are yet to get the results, because some of them the problem is based on the adjuvant, some of them the problem is based on the evidence which is still not available, and some of them are very good with respect to particular age groups. So how to generalize it, how to bring it to a step, we do not know. There are also, yesterday there was talk on boosters. So BCG is, but the other interesting thing is BCG is helpful in lots of other ways. BCG helps against leprosy, BCG helps against respiratory illness, and recently BCG helps against long COVID syndromes. So it helps in lots of other ways. But with respect to TB, where we are intending that it should help, there's still a lot of controversies remaining. We hope that tomorrow something will turn out, because there are hundreds of these enthusiastic minds which are trying to look into this. So with this, I stop my thing, and thank you once again to organizers and Bhatia sir and to Madam for giving me this opportunity. Yeah.
Thank you, Dr. Narendran. That was very absorbing presentation, and something I really picked up from your talk was that research is not always about discovering something new. It's always also about optimum utilization of what we already have. So thank you. Quickly moving to now to Dr. Sarabjit Chadda from FIND. Dr. Sarabjit, I don't need to say that, but most of this audience would know that despite the availability of molecular diagnostics, the upfront testing of presumptive TB remains less than 50%. Additionally, there has been a rapid evolution of TB diagnosis in recent years. However, the accessibility remains an issue, and the countries have not been able to ensure access to the scale. So what are some of the innovative approaches which can be used, and what's your experience in improving access to the diagnostics?
Right. Thank you, Vinita. And just to break the monotony, I'll just quote an incident. And thank you, Narendran, for mixing humor with your presentation. So there is this doctor, whose wife birthday is coming up, and he asks his wife that, what would you like for your birthday? And so the wife, gives him a hint that I want something which goes from 0 to 100 in 5 seconds. I think what she had in mind was probably a Ferrari. And the doctor, gave her a weighing scale, right? So, besides, being on the lighter side, but I think the interpretation is very, very important on, how we kind of do research or innovation. And until and unless, it is interpreted well and then, gets implemented, I don't think we get the desired result. The poor doctor is in ICU, I believe. So I quickly introduce FIND. I think most of you would be aware. Foundation for Innovative New Diagnostics, that was our earlier name. Now we are known as FIND by the acronym. And we got established in 2003 as a product development and delivery partner. But slowly, over the last 22 years, we have diversified our work. And right now, we work not just in product development, but also in validation, access, market shaping, and also strengthening the regional manufacturing. So basically, we are a global alliance for diagnostics where we seek to ensure equitable access to reliable diagnosis around the world. We connect funders, developers, countries, communities to spur innovation in diagnosis. And ultimately, the objective is that these diagnostics should be available at the most resource-constrained settings for the benefit of the most vulnerable and marginalized populations. So coming to the question, which Dr. Vineet has posed, that the TB diagnostic pipeline, there is a wealth of promising tests, and it's never been before like this. We have tests which span imaging, which span molecular tests, point of care, alternate samples. It's such a it's so heartening to see that after so many years, we have these range or spectrum of tests which are now available. And I'll give you some specific examples and also tell you, how FIND is actually working on promoting these tests, also taking you, back into the history that how FIND has actually helped. So coming to the molecular tests, and there are several point-of-care molecular tests available, and I, kind of step back to 2010 when WHO for the first time endorsed Gene Expert, MTB-RFSA. And FIND has actually played a major role in advancing the Gene Expert test, which has been a game changer. And we did several studies, especially in resource-limited countries, which actually led to the implementation of this test. We also played a role in price negotiation at that point of time. We also did the multi-country trial on TrueNat in collaboration with ICMR, which provided evidence to the WHO to recommend TrueNat also as a test, as a frontline test for TB diagnosis. Now coming to the point-of-care molecular tests which are in the pipeline, and I'm naming a few tests, but this does not mean that FIND is kind of endorsing these tests. These are the tests which are going to be available soon, and some of the cases FIND is actually working with these manufacturers. So we have the U-Star Portnet, the Cosara, the Lumira, a PlusLife by Huvel. These are all what we call as miniaturized tests which can be used at the point of care level, closer to the community, can be done by a semi-trained technician or a health worker and can quickly give results which are reliable, replicable, and near accurate. There are also low complexity NATs which are available, like the SD Biosensor Standard M10, the Bioneer, the MyLab Compact DX, which is from India, the Genes to Me, the TrueNat Ultima, and other Indian tests. And we are working with some of these manufacturers for both validation and also providing them technical support for refining the test, so that they can be used at a larger scale at a low cost. The moderate complexity NATs, which are aware, these are high throughput tests. These are not point of care, but they can be placed at the district hospital or at a higher level. For example, PathoDetect is one such test which has recently been evaluated by ICMR and has been adopted by the India's national TB program as well. COVID actually started initiated the start of open PCR, right? And these labs have been established all over the country in India, and most of the countries now have these labs available. But because COVID has been down, most of these PCR labs are no longer being used. So the thought was that why don't we have these open PCR kits for TB, which can be tested at these PCR labs very quickly and can be used for mass screening as well, because PCR kits, one, they are low cost, two, very high throughput. One PCR round can actually do 96 tests, if not more. And recently, ICMR has evaluated a test by Whovell called as QuantiPlus for TB, and another one, QuantiPlus for rifampicin and INH resistance, is in the pipeline, which is being evaluated. There are other which are coming, which is Quantigen, SteriPack, or Teva. But remember, that as soon as the doors open, it's like a floodgate. A lot of companies will start coming in with their open PCR kits. And it becomes very difficult for anyone to say which is a good test and which is not so good. And for that, FIND is actually working with WHO to develop ISO standard for these open PCR kits, which will be used, to evaluate the newer PCR kits which are available. Now I come to another paradigm, which is sputum has been our mainstay for testing for TB. But now we all know, that patients may not have the typical symptoms of TB. Some of them actually do not have symptoms of TB, which we call as subclinical TB. And the last, the National Prevalence Survey, TB Prevalence Survey, which was done in India, showed that nearly 30 to 40% of the patients who were culture positive or gene expert positive for TB actually did not have any symptoms at all. So they will never seek health care, and you will never get a sputum sample for them. Plus, if you look at elderly, if you look at the pediatric population, if you look at those suffering from HIV or other immunocompromised diseases, getting a sputum sample from them is pretty difficult. So there are now, tests which are available which test alternate samples. Urine has been there. You must have heard of the urine lamp, the lipoarabinomannan test, which was actually the first one. The LAIR was evaluated by FIND, and now we are working on the second generation with Fujifilm. And there are several others like Lionex, Fluxus, Brighter Bio, which are available. There are also alternate samples like the tongue swabs or the oral swabs. A study done by FIND, in Eastern Cape in South Africa showed that if you use an oral swab compared to a sputum sample, you can actually increase the TB yield by over 7%, and it can be used for mass screening as well. Imaging technologies, Dr. Narendran presented, about imaging technologies and AI CAD. Again, the issue is that with AI being so prevalent now and every other developer, working on developing an AI-based tool, which tool is good, which is not so good, and keeping that in mind, FIND has developed a validation platform for AI-enabled chest X-ray softwares, which is available and which can be used to test the accuracy, reliability, and reproducibility of any AI CAD software. And it can all be done virtually. We are also working and exploring the possibility of doing something similar for the cough apps as well, which you've just heard from Dr. Narendran. Skin tests also, there are several of them which are in the pipeline. A couple of them have recently been endorsed by WHO, the SciTB test, and you must have all heard that, at $1.50, it can be used, at such a low cost, it can be used to diagnose TB infection. And, this can actually help in treatment and preventing TB disease. I would, like to conclude that besides the availability of these tests, what is important is called as the diagnostic network optimization. If you look at any resource-constrained country, it is sad to see that it is not a problem of less, it is a problem of more. We have a lot of tools and equipment available, but when we do a capacity utilization exercise, we find that most of this equipment is hardly 10, 20, 30% utilized, not even 100%. So the diagnostic optimization exercise, which has been developed by FIND, we actually take into account all these scenarios and then help the countries to optimize the use of technologies, how the newer technologies come in, where should they be placed, and how overall you can use these technologies for achieving the TB elimination goals. So this is the kind of work FIND is doing, and I think our main role also is around advocacy, market shaping, and price negotiation with the manufacturers as well.
Thank you. Sorry, I must extend my apologies to the panelists, and specifically the last two speakers, because there's some miscalculation, and we are supposed to finish at 12:15, so we have to rush through. Dr. Samir, 5 minutes to you. Tell us something about what the Gates Foundation has been doing.
Thank you, and thank you for staying on, everyone. It's not easy to keep you between the sessions and lunch. So I'll just quickly, I think two clear themes have emerged through this panel discussion. I think one is the urgency, and the second one is ownership. I think urgency because, anything that has to come from the discovery stage right up to policy alignment and delivery on the ground at scale takes time and effort. And I think with the urgency that countries like India and Indonesia are showing around TB elimination, it's critical to slingshot that timeline and make it as short as possible. I think the second piece is the ownership, and I think countries are really showing ownership in terms of looking at TB elimination and what can be done and setting their own agendas. We heard from the Indonesia TB lead program manager, Dr. Tiara, talking about how Indonesia is moving ahead in terms of figuring out what needs to be done. In India, it's being driven largely by the Central TB Division, Dr. Urvashi, who's DDG, and also by ICMR, DG ICMR, Dr. Rajiv Bahl. And in that sense, I wanted to also contextualize the role that the Gates Foundation is playing. I think the agenda is being set largely by countries in India, as I said, in terms of what needs to be done. And our role has been primarily to either fill in the various gaps that exist or also bring technical inputs as well as risk capital to focus on some of the areas that have not been addressed thus far. And this is all towards improving the sufficiency of decision making on what needs to be done moving forward. My colleague Sarabjit mentioned earlier about the challenges, and Dr. Soumya as well, on the challenges around low microbiological testing, especially the use of NATs, and the real need for improving presumptive TB examination rates. And that's where, while ICMR has actually really focused on getting a lot of these innovations validated, and CTD or Central TB Division is looking at getting them to deploy on the ground. I think some of the areas that we have been trying to work in close collaboration with ICMR have been around getting more innovators to come and focus on the priorities that the program needs. And one case in point that Dr. Narendran mentioned about was the TB Innovation Summit. And it's great to see a lot of interest from innovators to focus on TB-related areas. I think the other piece has also been on the advanced diagnostic workshop that NIRT is doing currently, but was earlier being done by McGill. And again, there the idea is, can we get a mix of healthcare practitioners, lab folks, and innovators to engage together on many of the newer areas of interest that Dr. Sarabjit mentioned about. I think the other piece that's been really interesting is, country collaborations. And a lot of conversations happened yesterday around the vaccine work, where, can we look at a Southeast Asia regional platform that already exists between WHO and ICMR. And there, we're excited and actually have been supporting an NIRT ICMR-led institute, NIRT ICMR-led focus on TB preventive treatment in 5 countries: Indonesia, Bhutan, Nepal, Sri Lanka, and India. And I think it's these kinds of platforms that can also help further, vaccine studies moving forward. I think one other example I just wanted to give was the whole challenge around pre-care seeking that Dr. Soumya mentioned. How do we detect more subclinical TB cases if we are really looking at TB elimination as an approach? And there have been studies in countries like Vietnam, Act 3, where they were able to do community-based screening consecutively over 2 or 3 years. Even work that's been done in post-war Europe or Japan that looked at using chest X-rays to screen populations and treat them over a period of time was really helpful in eliminating TB over a period of time. And there we have engaged on some really interesting work with ICMR, the TB program union in Telangana, where we are trying to explore if this is actually possible over the next 3 years. So these are just examples of I think, what we can do and try to do to reduce that that whole period of time from early discovery of whether it's diagnostics, drugs, or vaccine to actually getting them on the ground and scaled up. Thank you, Vineet, for the opportunity to speak today.
Thank you so much. And I'd like to thank all panelists. The chair is not here. We'd like to thank. And sorry for keeping you long. We had also thought that we'll have some community perspectives, but we have already exceeded time. So for now, thanks everyone for your participation. Thank you.
It's ready? Yeah. Oh, no. Number one is later. I will open in this. Okay. Okay. Later. Go. Okay. Yeah, sit. Okay, good afternoon, everyone. My name is Tang Quanzhan, a professor from National Taiwan University, Taipei, Taiwan. Our university is so a member of World Health Summit Academic Alliance. And I'm honored to have this opportunity to organize this panel discussions with Allah, right? It's my honor to welcome you to this vital panel discussion on health literatures in the AI era. You know, that especially in this place, Delhi, India, as we stand at the crossroads of technological transformations and public health advancement, the interactions of artificial intelligence and health literacy is more critical than ever. From rural telemedicine to AI-driven diagnostics, the tools we develop and how people understand and engage with them will shape the future of equitable healthcare. This conversation is especially important in the global south, where the promise of AI must be matched with culturally sensitive, accessible, and inclusive health communications. The digital divide must not become a health divide. I'm truly excited for the insights of our esteemed panelists we will share today, from policy innovation to community-driven approaches. And I look forward to a thoughtful and action-oriented discussions. So may I ask my panelists to come up to the stage. And first one is Dr. Duan. Dr. Duan is currently assistant professor of School of Nutrition and Health Science at Taipei Medical University, and he is the current president of Asian Health Literacy Association, established in Geneva, Switzerland. Okay, the second one is Fernando, yes. Right? Okay, the second one will be the Professor Garcia, right? He's a professor of health policy and administration, dean of the College of Public Health, University of Philippines, Manila, and currently the vice president of Asian Health Literacy Associations. Welcome. And the third one is Professors, let me see, Gowin, right? Professor Gowin is a Deputy Director General and Director of Central Health Education Bureaus from India. Okay. And the next one will be, let me see, Asha, right? Usha, Professor Usha Rainey. Dr. Usha Rainey is Associate Professor and Head of the Department of Healthcare and Hospital Management from the School of Public Health, Manipur Academy, yeah, in Manipur, India. Thank you. So the last one came from the forest, from Brazil. So Professor Galval, right? Professor Galval, please, is a professor at the University of Sao Paulo, Brazil, okay? So today, I will invite each of them give about 5 to 10 minutes presentations. They will stand here. And after that, we will follow by dialogue and discussion among the panelists and the audience. So with no further ado, I invite Professor Duan to start it.
So could you share the slide? Yeah. So thank you very much, everyone, especially for the organizers, World Health Summit's Academic Alliance, who invites our association, Asian Health Literacy Association, come to share about health literacy. And I believe that this is only sections about health literacies, and many of you expecting that what we are doing, and you may looking for some of the opportunities for the future cooperation. So Professor Chan mentioned that we can have a discussion section that encourage the question from the audience. So be prepared what you want to ask. We have more questions for you. So now I'm talking about the art of health literacy and AI. I just have only one or two slides, and then move to the speakers here. So you know that when we have digital transformations, how we can start with, and when we talk about health, it's not about AI for marketing, AI for business, AI for many other sectors, but AI for health is difficult. We need to have a very good data, with data collected from patients, collected from people. It's not that easy, so much bias. Every collector also have bias, right? And patient have some bias report. Collector have bias report. System have a bias, because every system have not the same platform. Application, you have 1,000 of application. It's not the same, right? How are you going to synchronize them? It's a big challenge for everyone. And to talk about art of health literacy and AI, how are we going to improve both health literacy and also AI, right? AI can help to improve health literacy. On the other hand, if you have a better health literacy, you know how to operate AI, right? There are thousands of the app now. Do you know how to operate all of that app? Probably not, right? And sometimes my colleagues just said that patients don't really know how to ask doctor. The doctor is a person. You don't really know how to ask. And now AI is the software. AI is the device. AI is some of the robot there. Do you know how to ask a robot? Right? So that is another challenge, right? If you don't know how to ask a person, you don't know how to ask a doctor or nurses, and now can you ask the AI? No, right? It's hard. We are healthcare provider. We are expert in the health setting, so we know how to ask. But patient, general public, there very challenge for them. So we need a lot of the platform transformation. It takes a lot of efforts from every one of us, not just only healthcare sectors, but also many other sectors, right, get involved. Okay, let me share another one. Do you know where people get the information? Where people get health literacy? We accumulate the health information, health knowledge in our life. Right? It's a lifelong accumulation process. Not just in one day you become a very outstanding pupil with high health literacy. No. And you see here that we have a different source of health literacy. Originally, we have the information from healthcare workers, right? And then we have a non-healthcare worker, which means friend, family, parents, or children, right? Children who study better than parents and go back to teach their parents and grandparents. So that is the information you get from non-healthcare workers. Now, there's another channel, it's a mass media. You see the speaker out loud in your village, right? And postcarding, all of that is a mass media. And now you're very active about Facebook, IG, and many other applications. Those are social media. You just scrolling up, and you see whatever they talk, they share there. Now, even more active, now you start to ask Google. It's the one we very commonly use. So it's a search engines. There's many platforms you can search on. Yahoo, you can search on Bing for those you use. Many platforms there, search engines. So when you search engines, you find a lot of the resource there. So you don't know which one is good, right? But now, ChatGPT come, Perplexities, many other software come up, and then you ask them, you ask the question, then they help you to synchronize on the sources, okay? And then you get the information. It's more comprehensive, complex idea come up, and then you get a better idea how to improve your health, okay? LLM is a large language model there, so we can have a server question related to that one. So AI come, make our life better. But I have addressed in the introduction that AI can make the profit or give some profit to us if we know how to use that. It also create a bigger gap for those people who don't know how to use that, especially our parent, our grandparent, right? They don't know really how to use that. Then it creates a bigger gap in the information access. So I will pause my share here, then I will go to the next speaker who can share their own detail. But I keep some of the information question here. Later we can think about how to reply to this. Can and should we trust AI for our literacy, right? Because you search before, you like, misinformation, disinformation, I don't really trust the information that I search and I found on the internet, okay? Next question is, how reliable are AIs for health literacy? Because the health literacy have to be very formal, very academic information, not the fake information or misinformation there, right? Now, next one is, when AI may not be appropriate for health literacy, when, in which situation, okay? Now, the last one is, will AI is really trustful enough for health literacy? Okay, so those questions will guide us in the discussion later on. So welcome back for those from lunch areas. Now, so the question we can keep, and now we move to important one. If you have smartphone, please take it out. Please take it out. Scan the QR code, and then you can access to our association. We have a 12 years old association. We have 11 years to have conference in different countries, and we are established in Geneva, just like Professor Chan introduced. So please join us. If your institution haven't, then join us, and we will welcome you to our next conference in Taichung, Taiwan, in November. Yeah. So thank you very much. So the next speakers, I think we'll introduce our Vice President, Professor Fernando, go on stage to share his experience about AI and health literacy. So thank you very much.
I'll just use my laptop. Yeah, it's okay. Yeah, I think. I'm a little bit nervous because my wife is here. This is my first time that my wife will be attending a conference. Okay, can I project? Okay, yeah. So again, good afternoon, everyone. So I'm Dr. Fernando Garcia. I'm a professor and the current Dean of the College of Public Health, University of the Philippines, Manila. For those who have not visited Manila or Philippines, let me know so that I can also tour you in my university. I'm also the Vice President of the Association of the ALA, Asian Health Literacy Association. So this first slide, it actually, the health setting movement actually came out sometime in 1980s, no, through the WHO strategy. And it tells us that health is actually created and lived by people like you, me, within a setting of their everyday life where they can actually learn, they can actually play, they can actually love. In fact, health setting could be the place or the social context in which people engage in daily activities, in which the environment no, the organization, the personal factors interact to affect the health and well-being. When we talk of health settings, it could be in a place, in a workplace, in an environment like schools, and that is what I'm going to share with you today. So health literacy in the AI era. No? So in this era of artificial intelligence, health literacy actually refers to the ability to access, to understand, and to use the AI-driven information to make informed decision better in a healthcare environment. I will not go one by one on this one, but this is some of the AI and mapping walk initiatives. So AI can be used not to determine whether it is safe to go to a place, what's the shortest possible route, etc. So these are just lists of some of those powers or functionalities of the artificial intelligence. So what I'm going to share really to you now is one of the research that we're working together with the Tokyo Medical Dental University, a university in Japan. It's actually a health school environment supporting healthy, informed choices of food and beverage. So those are the objectives. First, for us to assess the school food environment and the current state of the food literacy of those school grade 7 students. The second one, to evaluate the effectiveness of the resource mapping walk, because there will be a resource mapping walk, and I'll give you an idea of what is that in a while. And actually, the third one is to develop a strategy on how to scale up those health food choice mapping walk. So this is part of the research team. So we're working with the TMDU before, but it's now Institute of Science and Technology. That's on the other side, on your right side. That's actually the University of the Philippines, Manila. And we're working with other government institutions, no, in the country. So this one, it's actually the type of food available in and around a school. I know this is also, you're familiar with this one, that we are actually limited with unhealthy types of food, such as what? Fast food, deep fried snacks, soft drinks, and processed foods. This is the reality in the country, in most, especially in some rural areas. I'm showing to you some of the pictures. You have the sari-sari or the convenience stores selling sometimes unhealthy foods, school supplies, and typical found around the school. Back to school tarpaulins where you have those fast food chains, and it's advertising what kind of food will the student will going to eat. And some of them are actually street foods that are available, being sold just outside the schools. So part of the preparation that we did is we actually discuss, we identify relevant stakeholders, and we have a courtesy call with the local government, mayor or the chief, and their health teams to discuss the project. So part of the situational analysis really is conducting focus group discussion, key informant interview, on the students, the teachers, and the principals, the head of the schools, to investigate what's the current state of nutrition in that school. So we actually come up, after that discussion, we developed this tool or the manual wherein we reflected the results of the discussion, the design intervention, and we started creating tools necessary for implementing a mapping walk and a workshop. So we need to get the buy-ins and co-create the interventions with the teachers, with the parents, and with the students. So we pilot test the tool or the instrument. So it was done in one of the pilot schools back in early this year. And their insights, the students' insights from that activity were actually integrated in the actual implementation. So this is a two-arm activity. It's a randomized controlled trial. So we have the pilot test there. We identified one city in the Metro Manila city, the intervention group, the school, the control group. And I'll tell you in a while what's the process for the intervention in the control group. So this one for the intervention, so we have the preparation, the baseline, the workshop, no, brief topic, mapping walk, small group discussion, debriefing, and the follow-up. And compare this one to the control group wherein we did not conduct those intervention strategies. So the flow of the mapping walk, so we have the grouping rules. So the students are actually being divided into groups of 7, and each group have been assigned a navigator. The navigator, the mapper who will be holding the phone with the Google Map on it, no? And some 1 to 2 recorders. So while the rest of the groups, they will observe, no, what are the types of food, what are the prices of food that are present around the school. So the division of the area, so the radius, it's 100 meter. So they need to go, no, around that area, no? And a map of the zone has been provided to them. They need to identify what are the kind of foods that are being sold, who are the ambulant vendors that are within the school. So workshop 1, before the mapping walk, we do a briefing, no, of the topic. We explain what's the mapping walk all about. Those are you see the 20 minutes, 15 minutes that's being done for those activities. Then we do the mapping walk in the streets. No, we give them the cell phone with using the maps, no, Google Maps on it. Yeah, we have the briefing, some of the pictures here, mapping walk, no, students doing their activity, no. Just after the mapping walk, they need to do some reflections, no, and move in the next zone. These are some of the small group activities wherein the teacher and the facilitators, no, in a small group discussions to reflect the mapping walk. So this one, they have identified, no, what are the food labels, no, what are the food items that they have observed outside, and they classified them according to the nutrient that is being in that food. So the next step for the project, actually we're not done yet because this is a 3-year activity. So we need to evaluate the effect of the intervention, evaluate the implementation process, evaluate, no, the planetary health or the climate change component of that if there are, and validate, no, the electronic food premises maps. Then we disseminate the results, hopefully in the next World Health Summit again, and scale up those strategies. So the challenge in a resource-constrained setting is the limited technology, the infrastructure. The Philippines is a third world country, and we have some limited technologies, especially in remote areas. Digital and health literacy gaps, especially if you go far-flung the metro cities, then you will not have even internet connection in those areas. So you need to include the language and cultural barriers. You need to adapt to that one. And you need to work, you need to get the trust of those people who will be working with. Implementation strategy, very important. Community-based co-design, the training for the students as well as to the teachers, the partnership with the private, and the role of the academe. Conclusions and way forward. So AI can actually transform health literacy and access, but a big but, no? But only when this has been designed, these are designed equitably and inclusively. Success actually depends on the contextualization. You need to work with the community, local empowerment, and continuous feedback. And the last one, of course, the future lies in actually blending, not just the traditional, but blending the traditional and the modern tools, that's AI. So I think that's the end of my presentation. I see Doctor, yeah. I hope I made the 5 to 10 minutes presentation. Thank you, everyone, and looking forward to your questions.
Thank you. So, Professor Gori, you're the next.
Okay. So good afternoon and namaskar to one and all. I know a post-lunch session is very taxing. So I hope to thank you, Dr. Garcia, for introducing the concept of health promotion. I'm going to address my presentation in 3 parts. First and foremost, as the Director of Central Health Education Bureau, I would like to tell a little bit, because I'm sure none of you out here would be aware that there is an institution called Central Health Education Bureau, which is an institution of Government of India. And we deal with the concept of health promotion, health education, and health literacy. So apart from that, my presentation, I would like to address what are the avenues or initiatives of the Government of India. I'm duty bound, I'm salaried by Government of India. So I have to let this August gathering know that what are the initiatives of Government of India where there's a load of opportunity for addressing AI, considering that we have a huge population of 1.2 billion to address and deliver healthcare. And last but not the least, I would also like to address as to where India stands as far as AI in healthcare goes ahead. So, can I start now? Okay, yahin se karna? Okay, thank you so much. And I will try to ensure that Dr. Chang doesn't have to look at me and tell me that I'm overseeing. So, for those of you who are not aware, the Central Health Education Bureau is a attached office of the Directorate General Health Services, Ministry of Health and Family Welfare, set up way back in 1956 on the recommendations of the Bohr Committee, Central Council of Health, and the Planning Commission of India. And our mandate is, if I may put into 4 words, health promotion, capacity building, awareness generation, and behavioral research in all aspects of health. So beautifully enunciated regarding one of the concepts of health promotion, that is the healthy settings approach, which was addressed by Professor Garcia. The health promotion concept, a very nice definition given by Ottawa Charter way back in the 80s, enabling people to take care of their own health through their actions. And health literacy goes a long way in that it is our responsibility not just to talk about curative, rehabilitative, and all sorts of secondary and tertiary level prevention, but also talk about primary and primordial prevention that is enabling people to have access to all sorts of information so that they can take proper choices and lead a healthy life. So these are the 5 pillars or the action areas or thrust areas. Whenever you see all the data, you will find these 5 pillars, and we like to work on these 5 pillars because without developing personal skills is of no use if you do not have a supportive environment and a community action to assist you to take those skills forward. And if everything comes together and our medical services are not reoriented to it, again we falter. Last but not the least, you can have beautiful policies, but then if the collective awareness is not there, then there is no use of such policies. The health promotion approaches in Central Health Education Bureau are all these, right from trainings, workshops, development of prototype material, implementation of health promotion programs, whether it is with conjunction of the national health programs or standalone health promotion programs. We have a lot of community engagement. Presently, we are engaging with the senior citizens welfare forums in Delhi itself to improve their awareness and to connect them to the National Center for Aging, which has been established by the Government of India. We also have research, behavioral research going on in multiple fields of road safety in schools, in the field of assistive technology and all. So these are just a few of things. I'm just going to rush you through so that when you see pictures, you get an idea. So I hope you'll remember that we're working in the field of menopause is something new, integrating with the Ayush Ministry for all sorts of things. And this is our new baby, that is the training and awareness for assistive technologies, orientation training programs for more than 4,000 to 5,000 nurses and allied health students across the country, development of prototype material. This is all that has been developed in the last 1.5 years. So because of paucity, I will not further talk about all this. This is something which has been released just right now for noise-induced hearing loss, along with the National Program for Prevention and Control of Deafness, and with the National Program for Prevention and Control of Trauma and Burn Injuries. We've just celebrated the World Head Injury Day. community engagement with the Senior Citizens Welfare Forum in Delhi itself. And for the settings-based approach in the schools, we have the Pratap, that is the prevention of risk-taking attitude and behavior among school students, and for gender sensitization and for prevention of sexual harassment amongst all the institutions. We've trained more than 500 to 600 people from the Ministry of Health, the drugs, CDSCO, and our FSSAI, that is the Food Standards Authority. So we also have addressed health literacy through multiple mega platforms like the trade fair, which accesses close to 1 lakh people, and a health pavilion is there in which the Ministry of Health addresses lots of health-related issues and awareness generation activities. So that's in 24. We've had associations with universities like the Guru Gobind Singh Indraprasth University Health Mela. So all these kinds of things. The research is, just to give you, you've had mixed method, you've got for lifestyle diseases in specific communities, for oral health promotion among school students, and lastly, our assistive technology and cyber health promotion. So that was about CHEB. Now, for those of you who are aware, and for our international colleagues, Ministry of Health and Family Welfare has got a complete life course approach, and we have multiple national health programs which are funded and have beautiful objectives, activities, and they do have a very robust component of health education and health promotion inbuilt into it, which is delivered either through the health services or by various institutions, and CHEB is also a part of it. So if you notice, you have the reproductive, maternal, and neonatal health. I've tried to just list out the programs. There are multiple other schemes and small activities also. I've tried to just collate the national level huge programs which are, they've been there for a number of years, and we all, at least all of us who are from here, know that they are there. So I'm not going to list them out, but you have n number of programs for the reproductive, maternal, and neonatal health. For child health, apart from the health ministry, you do have things which are in conjunctions with the other ministries. So you have the ICDS, which is with the Ministry of WCD, that is the Women and Child Development. You have the midday meal schemes and the special nutrition programs specifically for iron and folate and all. And you have the RMNCHA. For adolescent health, you have the Kishore Swasthya Karikram, Bal Swasthya, and a specific thing with the education sector called the School Health and Wellness Program. For nutrition, you have all these. Communicable diseases and non-communicable diseases addressed through various different national health programs, each one of them having a component of health education and health promotion inbuilt into it. Maybe focus not being there exclusively for it, because the diagnostics, management part, delivery of services, having more budget and focus, but definitely it is inbuilt into the operational guidelines. It is inbuilt into all the activities that are there. So the preventive promotive component is inbuilt into all these national health programs. Similarly, the geriatric component inbuilt through various programs and policies. So I really wanted to get you through the life course part of from womb to tomb. There are healthcare opportunities where you have data, where you have research, where you have opportunities, where AI can definitely be utilized for better delivery and efficient delivery of health information. So as far as leveraging AI for health promotion goes, I'll be taking you through the pillars of health promotion that I had stated earlier. We have one of the most important components going on across not only India, but globally also, that is precision medicine. Now, precision medicine specifically is being utilized for curative purposes, for rehabilitative purposes. But I'm sure all of us nowadays are seeing a lot of platforms where it is being utilized for preventive promotive services also. Smartwatches, all of us are wearing. Everybody wants to know how many steps you've done on a daily basis. your calorie counters. So health and healthy lifestyle being integrated on a daily basis, at least in the urban settings. But you do see nowadays, even in tier 2, tier cities, lots of people actually joining the bandwagon for healthy food, healthy lifestyle, and healthy exercise options, even in the workplaces. Similarly, behavioral monitoring. It's not just a fact that I just want to watch my weight. I have apps, I have programs, I have models being generated which can actually monitor the kind of behavior that you're doing, give you even prompts to state that, no, you don't need to do this, so that you can achieve your goals. So reminders, adherence support, behavioral monitoring, and precision medicine leading to personalized health recommendations are the opportunities where AI can be leveraged specifically for developing personal skills. Because all of us are aware that whatever amount of knowledge, attitude, and information that we may give, till the time it is not multiple practiced, it is not going to have a behavior change component that we want. Secondly, for creating a supportive environment, improved communication, virtual support groups, and mental health support. These are 3 areas in which a lot of AI has been inbuilt, and it is all being done nowadays. For strengthening community actions, we have the opportunity of automating tasks and analyzing data, loads of big data and small data available with researchers, and personalizing health messages and interventions. And for reorienting health services, it's being used in multiple places where we are training healthcare professionals to effectively address emerging and re-emerging diseases. We've seen it very clearly even in COVID era also. And as far as healthy public policies are concerned, loads of policies are available, and for AI and data, we have a national level policy which is also being delivered, so that the early predictions can help us in addressing any future public health emergencies of importance. So all these opportunities, we have examples we've taken which are implementable through our existing systems. I'm not going to go into the details of this due to a paucity of time, but these are small things which can be used for predicting poor maternal health outcomes for high-risk mothers, as well as for congenital involvement in case of children. For children and adolescents, we've had malnutrition being addressed, intelligent learning interventions, environments to be created in schools where it can be utilized. Road safety is one area where we are getting this, and we are also trying to utilize it for actually labeling the schools as safe school zones and those kinds of things. Similarly, for adults, you have loads of nutrition fitness apps, virtual assistants. Stress and wellness is something which is an industry nowadays utilizing AI. One of the things where we are planning to do is menopause. Navigating menopause is one cohort of women who would want all sorts of information and actual help or assistance in going through this phase, but do not have it even at one particular thing. So the awareness generation, the physical health, mental health, and emotional well-being, we will be trying in the future to get into this space and deliver something which is AI-based. So for older adults, fall detection systems and a smart home care technology with Internet of Things is already being examined and utilized by a lot of home care and assisted living centers in India also. So these, if you see, I'm sorry for the small this thing, all this is just in the last 2-3 years. These are all AI-driven healthcare innovations in India, but mostly in the R&D stage. So if even now as researchers, all of us want to see whether they have actually gone into implementation, there is no platform where it can be seen. So I'm sure across the country there will be lots of examples where AI is driving the healthcare industry for preventive, promotive purposes, but we are not able to collate it, or we don't have any place where we can actually access it and showcase it, that this is what is the benefit and this is what is the pitfall of utilizing AI in healthcare. So my last slide ethical considerations, or you may consider it as challenges. It's already been addressed by both the earlier speakers also. Privacy, data security, informed consent, unbiased use, liability and accountability, and more importantly, explanation and interpretability is something which we are really struggling with. You put some health education material in Google and you try and get the Hindi version of it, and you'll be appalled at the kind of Hindi version that you'll get out of it. It makes some other sense, absolutely. So that is something which I want you to understand. And I leave you with this last thing, that a balanced collaboration between an AI-driven automation and human intelligence will definitely promote and support healthy behaviors. And we need it because we are a very densely populated country. But simultaneously, if we do not empower the individuals to make informed decisions to use AI, it'll be impossible. So it's up to us that we use AI tools judiciously, responsibly, and ethically, so that we may not have a tyrant or a master in AI, but more of a helper in AI. Thank you very much.
My presentation. Okay. It's not shared. Sorry. Technological problem, technical problem often we face, and here we are in a session of where we are going to talk about AI era. So you can imagine what AI can do. So it's a true example. So my talk is going to begin, and we are facing this. Duplicate. Yes. Thank you. Yeah. Yeah. Thank you. It's okay. Yeah. Thank you. So, good afternoon. I'm Dr. Usha. I'm heading the Department of Healthcare and Hospital Management, as well as I'm the coordinator for Manipal Health Literacy Unit. Previously, I was also the Assistant Secretary General for Asian Health Literacy Association, and we were the country office head for Asian Health Literacy Association. This Manipal Health Literacy Unit was started way back in 2014, where India was not talking much about health literacy, and thanks to Professor Helmut Brand, who brought this concept with us and conceptualized this Manipal Health Literacy Unit in Manipal. Thank you. When we talk about health literacy, a lot of time the question comes, what is health literacy? Even the same question even I wanted to ask many a times to myself. But you know what helped me is AI, to make it understand in a better way. There are many skill sets which are attached to it. We want to have access to information, but my dear, there is an information overload. We have ministries who are producing lots of information. We have a lot of NGOs producing a lot of information, researchers producing a lot of information, but I'm a human being. I need one answer. Where should I go? AI might answer. AI might give you that access to information. Second is reading, comprehension. I'm not understanding the jargons used. I'm not understanding what this doctor is talking to me about. I can speak Hindi, I can speak any local language, but I'm not understanding what is appendicitis. I'm not understanding what is inflammation. Oh, it is confusing. But AI can help you. There are a lot of numbers. 1 per lakh, 1 per thousand. What does it mean? Whether my patient will survive or not, whether my family member will survive or not, AI might help you. There is a lot of comparison. One doctor is telling, go for this treatment. The other one is telling, go for another one. Which one to choose for? What does the evidence says? Oh, there are plenty of evidence. Can I take help of AI? Because whenever I go to multiple doctors, everybody is confusing me. Can I take? And then you might get some help in taking informed decision. AI might help. And the most important is bridging the gap of communication. We have wonderful doctors across the globe. But when it comes to having a discussion in the local dialect, in a local linguistic problem that we face, how to overcome, here we are training AI in various linguistic approach that, that can train the system. And whenever the doctor has to communicate to a person who is not literate and who prefers speaking the local language, we can help them. We can communicate with them better. So there's always a struggle to understand health information, and low health literacy always leads to poor health outcome and system burden. And building a health literate society can help us to reduce some burden, especially the financial burden to any country and rest of the world. But do we need a lot of finances to invest? No, we need a different approach. What is the approach? Approach is you all are sitting here. Why don't we hold each other's hand? Why don't we join together? Why don't we collaborate together? Why don't we distribute our role? Why don't we talk to each other? And when we do, we will develop a solution where AI model can be developed through all of us, because all of us are expert in either one or the other domain. One person cannot help the AI to develop. And somebody has developed AI, somebody has put the information behind the scene. But if we all start putting the information behind the scene, that can help us to solve future problems. There are 22 scheduled languages, more than 22 scheduled languages, multiple dialect, varying literacy level. But the plus point is there is a growing smartphone penetration and digital infrastructure. There is a fertile growth of AI-driven inclusive health education. There are a number of tools and technologies which is coming up, which can bridge the gap. Now, if a patient has to go and ask any doctor, they can ask AI first, ChatGPT, I'm having a pain. Can you tell me what all question I can ask my doctor? Because if you are hesitant, what if I ask a wrong question? So at least AI can help you to ask the right question to the doctor. It can also help you to deliver personalized health messaging based on your local language, behavior, and context. Majorly, when we were analyzing the health literacy tool around the globe, we found more than 300 health literacy survey tools which are available. These are non-comparable, but at least it can help us to bridge the gap. It can contextualize. And we can have a real-time engagement through chatbot, voice tool, and visual learning. So here is the graphical representation. Earlier, we used to have everything through either written material, or somebody will come to your doorstep, or you go to a hospital or a clinic and then you ask, or you have a videos. But here you have a smartphone in your hand, where even now, if I ask you to open your ChatGPT and ask any of the health condition that you want some information, at least you will get some, which is a little bit satisfactory to you. And you don't have to travel. You are saving a travel cost also. You don't have to wait in the OPD. You are saving your OPD time, waiting time. So there are a lot of gaps that AI can bridge in, and that also help you to develop your health literacy. Because more and more question, more and more information that you seek from the AI software, AI platform, the more and more health information is going into your brain, into your mind. And then you are developing your knowledge and information. You are developing information towards your own health. So there are few initiatives which we have done in Manipal Health Literacy Unit. We have done some screening the population in 5 different states in India. We are developing an AI-enabled platform, which is for researchers, which is going to very soon in another, but it will take 1 or 2 years. First phase is over, where it will lead to identify the gap in your health literacy, and then how you can fill the gap, what material or what information you need. There is another AI-enabled prediction which we have developing, which is going to help the intensivist on disease prediction, disease progression prediction, and also what messages has to be given to caregivers. There are certain digital books and videos that we have developed. So coming to Vision 2030, hopefully with joint collaboration with all of you, we will be having, most probably, we can do it actually. Most of the PHCs will be equipped with AI literacy kiosk, bridging the linguistic barrier. Health workers can use AI to support community health literacy because they themselves have to upgrade. Every day new health information is coming. New method of prevention is coming. National integration of AI for preventive health education. And that's all. Thank you.
Thank you. So lastly, we have Professor Gabo from Brazil.
Good afternoon. I am Cristiane Galvão from University of São Paulo. In the moment, I am also visiting professor of Manipal University. First of all, gratitude. I would like to thank Asian Health Literacy Association for this invitation, and also Manipal Academic of Higher Education for support me, for stay here, and also University of São Paulo, where I developed my research in the last 30 years. Well, this presentation aims to propose a conceptual reconfiguration of health literacy, and I explain why. Well, we can find many articles regarding health literacy in the world. Today we talk about many definitions about health literacy, but commonly, traditionally, we can see that health literacy is a process to obtain, access, process, understand, evaluate, apply, and use health information for patients' health decisions. And then, if you can how use the health information, you have a high level of health literacy. If you don't use health information or don't know why and where find this information, we have a low health literacy. Then people explain if I have a health literacy level high or low. But I don't know if this model is interesting. In the last 9 years, I and my team in Brazil answer many questions from population, vulnerable population. Every day we see in the social networks questions for patients. And after assisting 1 million of persons around the world, not only in Brazil, but in the United States, Canada, Europe, and also in India, we have a vision regarding this. Well, this traditional model seems good, was useful for many years, but in our vision, this model does not explain the complex process of patient decision making. Why? Because health information is only one of dimensions for patients' health decisions. When people look for us, look for help, first of all, they looking for care, attention, heart, proximity, subjectivity, not only for objective health information. And then we can see people looking for empathy, time, attention, listen, comfort, relief, care, affection. Human connection. Words, not health information, but words, heart and soul. And here I put this red for attention regarding words. Our scientists, many times we have many health information in the websites, governmental websites, projects with health information, but many times people need only a word like yes or no. And many times they don't want health information. Many times they need human connection. And I am a professor in the last 30 years, and I can find many systematic review about many conditions around the world. But human connection is more important for me. If my husband, my daughter, my son, my family says to me, don't do it, maybe I will consider my family and not the systematic review. Why? Human connection. Our decision is based in human connection. And then it's a very important issue in the AI era, because like human connection is important, we can provide society with a powerful care more important for their lives. Considering this, I'm here today provoking you to present a new concept, the bond-based health literacy. What is the concept? Bond-based health literacy considers not only health information, but also the human connection, the proximity, the heart, the soul. I try to develop a concept. A bond-based health literacy is the relational interpretative capacity to construct meaning, trust, and care through verbal interaction between human beings. It's a communicative process shaped by layers, cognitive, affective, and contextual, in which health-related information is shared. Bond-based health literacy recognizes that decision-making in health takes place in the geological spaces. In my mind, I have a phrase. First of all, we need to accept the patient. We need to take care of the patient. In the second moment, patients accept the information. And many times, we say, patients, go ahead and look for health information. And in the fact, patients don't need this. Patients need connection. In this moment, we have a great opportunity in our lives, like as health professionals, to use AI to help us to provide a better care for people. We can use AI for, like Professor Rushan mentioned today, a linguistic mediator between individuals and systems. Is a very issue problem, because many times health professionals inform the patients, but patients don't understand what doctors say. They go to social network and ask for others. Every day we see this in our project. then use artificial intelligence is a good thing for us. Another possibility, use AI for empathy, like an empathy tool with human supervision. If patients put information inside the AI can map some characteristics of patients for health professionals. As an extension of human listen, and also of a memory of care, we need to provide a personalized care using AI. Almost, doctor talk about the risks. Yes, AI don't understand the suffering, don't understand the nuances. Many times in our project, we can see that the AI provide incorrect information, then is a risk. But if you use AI with a human supervision, we can have a good result. Thank you very much, and thank you for this human connection. I invite you to write me, and I have a draft for this talk today for share with you. Thank you very much.
Okay. Thank you, all the distinguished panelists. Under my pressure, they're squeezing their talk to allow more space for discussions. So as you can see from the Philippines and India and Brazil's experience and perspective, the challenge of AI to public health, to health promotion is ongoing. It's very challenging. And a lot of issues has been raised through these presentations. And just add a little bit, a lot of this presentation think about AI can be co-pilot by human means to improve things. And Taiwan is a place manufactures the most of chips for AI. And the requirements to improve the chip efficiency is on monthly basis. So it would be very soon, AI not only co-pilot by human, it's become autonomous, okay? So some of these materials the presenter says that we humankind has generated a lot of health information, and we have to put in and all the language, but we have to sleep, right? Our health worker has to sleep, and machine can continue. So in the future, machine generate knowledge by themselves through the large language program. All of this will surpass humans' knowledge and informations, and they are all fit into the AI models. So we have to learn how to distinguish machine generate knowledge and human knowledge very soon. And in the clinical settings, in the past, a patient came to the clinic and he or himself or his relative, mostly sons and daughters, can Google to see several options, right? When we are in a community, we want to do health promotion, and they have already have some information they can check from internet. So in the classroom 2 years ago, we have asked students, have you Googled today? Now we have to say, have you checked today? So this AI has another direction to the givers. We want to give up information, and we want to instruct correct health information to make people healthy. But now, it's bilateral now. So all this actually is happening now everywhere. And as I mentioned, will this become digital divide become health divide? The reason that this is it takes a lot of money, energy to have a chat. So the poor's area will be very difficult to do that. So can we have an efficient health literature as the association has promoted, right? That the end users can be very easy to use. That's the kind of things. So I want to ask the chairmen and the associations has any plan to engage with this AI industry. You know, they are very, very, very active in clinical settings. Can you have this for population health and others? Have you thought about that?
Yeah, thank you very much for analyzing some of the aspects and also promoting Taiwan chip industry, which is very important now, and people accuse about that a lot. Now, talk about our association, Asian Health Literacy Associations, which I'm now serve as the president. We have some one project with Israel's bilateral project with Israel. We talk about the digital health literacy and also the digital access from the elderly people in Taiwan and also Israel. We published one and going to publish some more. That nowadays in our hospitals, especially in our hospital system, our university, we have 6 hospitals belong to universities, and we already apply AI in diagnosis and also the treatment and follow up the patients. So then AI is around us, and patients, especially for elderly, they have big challenges. They know how to book it, book the doctors, they have to make the appointment, and whether when you see their name there on the system, but actually they didn't do that. Their children help them to do that, right? So in that case, how we can empower and leverage their autonomy. This is a big challenge. Of course, we have to deal with that. But one thing we can do is that we train the young people now. So next 10 years, next 20 years, we can become old, then we can access that. Okay, so we cannot change the system immediately tomorrow or overnight. No, we have to change now, and we expect that the elder people in next 30 years is adequate, you know, well trained for AI, right? So I'll become old one day, then I say, yeah, I'm confident that I can access all of that AI driven sources and also the facilities that related. I can use robot, I can ask robot to help me to do something in-house, and they can communicate with me. So one of the things that AI now can do, they can speak out the emotion. Just like do you love me? And say, yes, I love you. With the voice change, the tone change. So we can do that. But talk about AI, what we can do now is to make to push, you know, own hospital and our university, our member, that they share their work, okay, and try to initiate some of the idea that we can integrate, apply AI into our practice, daily practice, no matter is you are teaching or you are taking care of patient or you are doing the diagnosis or treatment patient, try to integrate health literacy into daily practice. So that's the thing we can do. There's another one is that we encourage them, doctor and nurses, hospital, to create a friendly material that people can access. Right? That is one of the industry you can do the startup for that. You can create a very friendly, easy information material, video, like a guideline. For example, you want to take the appendix surgery next week. Do you have any idea? Almost no idea, right? Because how you to prepare emotionally, physically, and before one day, what you should prepare, no material talk about that. You only listen to doctor, right? And search Google, and now you search ChatGPT. What should I prepare for that surgery, right? And if the material can driven by no matter it's AI or human made, that should be okay. But make sure that you can check the quality of that material, then you can give to the patient. Yeah, so some of the idea there, but we can work together. Hopefully one day our generation getting old and we can have better literacy. Yeah.
Yeah, so we are, after this, we are open. I think that the audience has a lot of questions to every one of you. So I open this one. We have 15 minutes left. You can ask anyone of this. Can you identify yourself?
Good afternoon, panel, and good afternoon, all the attendees. I'm Lavkesh Arora from South Africa, born and brought up in India, so I'm still an Indian citizen. So, my question to Professor Dong. So we speak about all those different channels from where the information is getting generated, which is unsolicited in most of the times and not medically correct or not, we don't know, or it's not evidence-based. And over a period of time, population have built the habit of in terms of consuming that content. And the pace of getting that content, we know that velocity. And now at the other hand, when we're looking at improving population health literacy or awareness around a particular disease, any thoughts around like what velocity we have to go and how we have to go so that we bring that shift from unsolicited to medically correct and evidence-based information? So that's one question. And connected to this one, the second is like, has there been any attempt in terms of understanding the current baseline literacy level of the population? Or if I have to say like population health literacy index or a health awareness index, or maybe like your general health index or a wellness index or a preventative behavior index. So those aspects, like, has there been any attempts around that? And if not, any thoughts around like how that can be achieved at all? Yeah.
Yeah, thank you very much for two questions. So let's say people have they have different channels of information, right? And one of our study found that we already published, and we found that if people access the official channels, which means you have edu.dot, right? Or they have like a university website, a hospital website, and the government website. Though information is official and reliable. So even though you go to TikTok, you go to IG, you go to Facebook, you saw some information, go to double check if there's any source from the government, from the university, from the hospital, then that is the official one, right? And the second question is about
any attempt in terms of understanding the baseline?
Sorry. So the baseline information here, we also need to put in the model, and we adjust it for that baseline information and see if there's some factors really affect to their health literacy and then their health. So we consider that in our models. So we definitely have to consider that. But you raise very important issues related to many confounding factors, actually. Yeah.
Sure, Professor. If you allow, may I ask a follow-up question on the response for the first one?
Yeah, quick. Yeah, we can ask any other questions? Yeah, that's one.
Yeah. So regarding that content that, so you mentioned about the government websites and all. So I think the question was more around as like people are habitual and addicted to that content. How do we bring that shift? That's an important aspect so that they only scroll the government website, not the other content.
Yeah. Can I collect another question from the back? Yeah, can you pass on this? Yeah, sure.
Yeah, good afternoon, dignitaries. My name is Dr. Sagar from Public Healthcare Council NGO. Sir, the need of the hour, health literacy. We all know that 70% people are dying with non-communicable diseases and 20% approximately by communicable diseases. This is just due to diet, lifestyle, stress and immunity, which 4 of them have to be dealt with self-health care. So self-health care is nothing but health literacy. So we all, I'm asking all the dignitaries that we are being raised in a culture from thousands of years, we are practicing yoga. We know the health starts from kitchen, not from the hospital. So we know the grandma remedies, so many things. So I would urge our representatives to collaborate with Ayush and even with Global Center for Traditional Medicine, which is being hosted by WHO, so that even 7-year-old kid, I even came to know that Chinese travelers who traveled India, they have written in the history that even 7 years kid were trained in health literacy. So this is very, very important aspect. So I want the generation, the upcoming generation who is about to face a lot of crisis in health now. So even in the school education, we have a lot of unnecessary subjects. So at least every year we need to have some subject related to health literacy. And even obviously reactive model is being in the country, in the world. So we have to transform it to a proactive healthcare. Thank you.
Okay. So we will ask each of you to have final comments. So can I go from Garcia?
Just to respond to Sir's comment. Well, in the Philippines, what we do actually is the government. So they are actually becoming more active in coming or posting in the social media some of those legitimate information about health. So that's actually to balance the information being received by the population. So those are some of the activities being done in the country. And just to respond also to Sir's invitation, actually, we would love to, the university actually benchmark good practices with other institutions, other universities. And with that, we would love to also contact or communicate with you so that we could also look at what are the best practices that you're doing in your institution that would also help the country. Thank you, sir.
Respond to the comments, or do I respond to the comments? Or
yeah,
okay.
Or you can comment on
So, 2 things. One, like you had stated, good point. We don't have a baseline. It's all just, I think, very small cap studies being done by students on various issues regarding disease models. And the moment you talk about preventive and promotive, even now, all the discussion, everything is around curative and management of patients. So we're not talking about healthy professionals. So one question which was asked to me by a PhD student was, do we wait, ma'am, for somebody to actually get sick so that we teach them healthy lifestyle? Or is it something which is to be addressed since birth? So that is something which all of us have to understand. My take on it is, if I want to take XYZ influencers or somebody who's a prominent hero or heroine, or for that matter, role models, a cricketer or Amitabh Bachchan. Today, I think all of us would have forgotten how many things health-related Amitabh Bachchan is endorsing. So I think it's about time we identified our role models. Secondly, we decided on the modalities or ways of communicating the health aspects. Whatever you may call it, health education, health literacy, health policy, whatever, XYZ, these are beautiful English words. At the end of the day, all that matters is what is going from me to you and whether it is registering here so that I am going to incorporate it into my daily routine. The most misused word nowadays, I wouldn't even call it misused, it's the most abused word nowadays, is healthy lifestyle, which means everything and nothing. I ask all of you out here, what does healthy lifestyle mean? Healthy food choices. What works for me will not work for any of you. 30 minutes of exercise, what I sit on the computer for 8 hours a day. What works for me may not work for all the students who are running around. So just let's not give information like practice healthy lifestyle. So I think that answers your question. And we have to make it interesting. It's very boring. The way it is given is so boring. If I want children to adopt something, I just can't make just cartoons or for that matter anything. I have to get into their head so that they are bound to leave the other game or anything that is exciting and want to get this information. And that is one area where nobody is thinking about. It's like the way they say it from Johari window, we consider that you don't know, we know, and we want to teach you. That is the concept of health education or health literacy right now. And unfortunately for all of us, we all consider ourselves experts. So I think we need to start from that area, that first try and understand what is required and then present it in such a manner that the other person is definitely bound to pick it up. So that is something which those are the 2 points that I feel should be there.
Dr. Usha?
Thank you, ma'am, for that comment. All of us feel we are experts, although we don't. So it is a health literacy, actually, it's a behavioral change. It's a behavioral shift that we all have to have. Once we have the behavioral shift, we will get the access to information. We will understand, we will start comparing, and most important, we will start practicing how to be healthy, the choices, like sir said, we have a lot of ancestral practices, good practices, which we could have followed, but we are not following. And right now, sorry, the entire world is moving towards nuclear family. So where the nuclear families are there, we don't have our senior citizens with us who can guide us and mentor us, but their knowledge can be saved in the AI, which can help us to understand what is available on various sources so that we can make a choice-based and evidence-based decision for ourselves. Thank you.
Well, it was a great pleasure to stay here today and learn with you. My final word is we need to accept that patient is a person, not an object. And a person have objectivity and subjectivity, emotions, and then it's not adequate in my perspective judge if a person is literate or not. A person is a person. The problem is in the scientists and health professionals that don't assume your task to best inform patient and population. Thank you very much.
Okay, I cannot make conclusions, but I want to say something. That's the last one. That's Professor Gabo talk about bound, right? Based. I think it's very good. And but think about this. 20 years ago, you are not bound by normal mobile phone. Now everybody in your pocket. 40 years ago, computers, right? And put in your office, then a laptop, and you carry everywhere. So people are also bound to machines. So the bond should be not just people, should be AI-related machine. It's a reality. So if we can have futures panel discussions. One of them would be AI's assisted robots or something with us, and we can have this kind of conversation. This is the word to come. That's the word to come. So I have to be very thankful for all the experts here bringing to us their research, their perspective, and their visions for a better and healthy world to come. So, and also thanks for all the audience to be here. And if you have further questions, can come up to discuss with our panelists. With this, I want to give the chairman of the last word, and not too long.
Very short. Thank you very much. We have wonderful section here, and I want to close our section with one question. So you can go home and think about that. For AI, which domain of health literacy AI showed the effect on all of the domain of AI, on domain of health literacy? You know how many domain of health literacy? We have many domain, many dimensions of health literacy, and AI can help us to improve which domain. That is the action that if you're interested in health literacy, then start to search it now. Thank you very much, everyone. Yeah. podium. पोडियम को यहाँ नहीं कर सकते.
Can the speakers come? बोर्ड भी आ जाएगा ना पीछे. ये भी तो आ सकता था.
Okay, I think we should start. We are already 5 minutes late. I want to welcome all the members of the audience and particularly the speakers. This is a session on basically drug use and the future in Asia. I am the chair, but I have been given 10 minutes to introduce the topic and introduce the speakers who are very eminent. When we are talking about this issue today, we have to remember, though it is criminalized internationally through international drug laws and because of ideological reasons, traditionally in Asia and Latin America, drugs were actually used very commonly. This is to remember. For example, how many of you take drugs? I was thinking about alcohol actually, but everybody thought I was talking about. I made this point to the judges at the National Judicial Academy and they fell through their chair. So the prejudice we have. In fact, cannabis is good for you because it has medicinal value. But because of criminalization, because of ideological and religious reasons, it's banned. Possession, use, etc. is banned. But historically in this area and in Latin America, both cannabis, heroin, opium, etc. were used very commonly for recreational purposes and for medicinal purposes. And today I know my partner actually uses cannabis oil for pain. It's more effective than any of the other pain-killing medicines. Because for practically 50 years there was this war on drugs, we forgot it was very difficult to do research on these issues. I remember I was studying biochemistry at Surrey, and we were doing research on the breakdown, the etiology of cannabis. And you had to take special permission from the government to do it. You couldn't do it. That is one issue. But what has happened in the meantime? The country which launched the war on drugs, the Nixon's prescription for getting rid of drug use. Like sex work, you will never be able to get rid of drug use. Please remember that. Anybody who talks about zero tolerance is completely mistaken. So we have to rethink our strategy. But there are drugs which are more harmful than, say, cannabis. Alcohol is actually the most harmful drug today in the world. But people don't realize that. And the commission, I have a presentation, but as a chair, I don't think I should take the prerogative of putting a presentation and deprive my fellow panelists. The commission in the early part of the last century, which actually said that taking a bit of cannabis and heroin is as less harmful as alcohol. These are documented cases. But because of the war on drugs, coupled with the international conventions. Now the international conventions actually do not prescribe what is being done in countries. They say definitely that use, possession has to be criminalized. But criminalized doesn't mean you have to send everybody in jail. Please remember that. There are alternatives to jail. For example, rehabilitation, treatment, etc. And a person who is dependent on drugs is not a criminal. A person who uses drugs is not a criminal because of their behavior, but they are treated as criminals. And all over the world, you have a situation where 50% of the persons incarcerated in jails are persons who are simpliciter using drugs, or they are small-time carriers. And they are actually in prison. In Punjab, for instance, 50% of the prisoners in Punjab, in jails, are people who are basically carriers or just use it for recreational purposes. And there's now a new prescription, zero tolerance from drugs. I can tell you, it will never succeed. Because it's part of the behavior of a person to take recreational elements, whether it's alcohol, tobacco, etc. Alcohol is legal, which is more dangerous. Tobacco actually has a procedure internationally to just give a warning. It's much, much more dangerous than, say, cannabis. So there's a dissonance between the various regimes that exist. Fortunately, because of HIV and the response to it, for the first time we realized that you cannot have a top-heavy approach, that academics or doctors will solve the problem. It is the persons who are affected by a particular ailment. I don't use the word disease because that's pejorative. They must be involved in the response to a particular epidemic. I've just written an article which is published in the leaflet 2 weeks ago about the comparison between the response in HIV and to the COVID pandemic. And difference is stark. HIV was rights-based. That's why it's also rational, scientific, based on scientific evidence. That's why we are close to actually finishing it off. Only because of COVID, things actually slackened off. But COVID was completely ad hoc, not rights-based. All based on who can afford the vaccine, etc., etc. I don't want to go into it. But most importantly, the community was involved. They were the fulcrum, the backbone of the response. And I'm sorry to say, I must tell the organizers that this conference will not achieve the purpose it set out to achieve. And I have to be candid to my friends. The organizers are my friends. Please involve the communities when you're having these jamborees. There's no point in having meetings between two academics. And in HIV, though Adiba and I are academics, and others are, Atul is all over, except my friend on the far left, who's actually an activist and has done wonderful work in the drug users community. Academics don't solve problems. In fact, we have realized that it was the people affected with HIV who were giving you answers to this. Even in sex work, that was the same issue. But HIV also told us something which was very important, that you have to, even for drug use, you have to have a rights-based health approach. And the rights-based health approach means that you actually introduce harm reduction. Take an example for drug users. I'm a drug user, you are the authority or the civil society. You'll come and say, we don't judge you on your drug use, you're injecting drug user. We are giving you a clean needle, give us your old needle. Why? Because we want to reduce transmission. Same things, sex workers. We were the only country in Asia earlier on where we actually educated, empowered sex workers for negotiating condom use with their clients. Is it easy? No. But we had a will, because at that time I was the lawyer in one of the matters, and the prescription that the government came up with was, no, you must actually now ban sex work. I said, it's already banned anyway, what are you talking about? Like, it's like saying, for rape, have death penalty. For second rape, have 2 death penalties. It's going beyond madness, because no rational responses to this. But we said, no, you can stop it. You have to take the community with you. Educate, empower, don't judge, and educate them and empower them for negotiating condom use. That's what we did. And actually, that was the success story. It was actually first started in Shonagachi by Dr. Jana, who's no more with us. But fortunately, though I have a lot of differences with the Gates Foundation for other reasons, which I won't speak of, to wit, COVID, but they actually upscaled the whole thing. And because of that, India was one of the few countries where it was a bottom-up approach. And even after the government said, okay, the sex workers even today will not have sex with the client without condoms. That's a very, very big thing, because you have actually changed the behavior of people who are affected. So harm reduction is the key in this area. And that, in fact, in drug users became a key issue. We could actually negotiate needle syringe exchange programs with drug users, and they became our confidants. But the real problem in drug use, like in all other issues like sex work, is criminalization. Because you criminalize behavior, you actually make a person who's actually just acting out of his or her desires, or a transgender person's desires, to have a recreational exercise in using a drug. In the US, it's very well shown that white people use cocaine and they're getting away with it because of the different method of using it. But black people, because they use it differently, they are criminalized. But why should you do it? But that's the problem, because you think another person's behavior is bad, so you criminalize. And when you criminalize, you drive things underground. You can't access. It was fortunate that through HIV we could access, but otherwise, very, very difficult. So the real problem is actually to decriminalize. You know, the people who started the war on drugs, Mr. Nixon, they've given up. And like homosexuality, 377 in India, what the British thought and what the Americans think, we think it's right. That's the problem. We have actually imbibed their wrong thoughts. It's better to get rid of them and start with a clean slate. And we know the answers. So countries have legalized, Portugal, US, Thailand here in Asia, and there are issues. Fortunately, there have been lots of progresses in countries in Asia. Nepal, my friend Adipa is there on death penalty. She's done wonderful work in Malaysia. And other places, things are moving on. But the crucial issues of criminalization are still at bay. We have to rethink. We have to actually set our minds free of the stigma that we have. Why do you wage a war on drugs? Because that's evil. Imagine the concept of evil. A person using drugs is an evil person. It's a load of baloney. Please understand that. So we have to rethink. And I'm just introducing, I'm not actually going to speak much. I've nearly exhausted my 10 minutes. So we have a wonderful panel. I'll introduce them one by one, but not take long, because later on we'll have some time for questions. I need not introduce Adiba at all, who's the first speaker. But she has done wonderful work in Malaysia. She was in charge of the HIV work, first of all. And she's done all sorts of work within HIV. Drug use is only one of them. And she happens to be, rightly, one of the commissioners, along with me, in the Global Commission on Drug Policy. She's got vast experience. And now she's the very complicated term, but she's the head of the Monash University in Malaysia. So, Adiba, we want to hear you. Thank you.
Good afternoon, and thank you, Anand, and to the organizers for inviting me to share my thoughts and what we in Malaysia have done to address the problem of drug use in Malaysia. As Anand hinted, I actually started off in this journey, if I can call it that, to help with decriminalization of drug use in Malaysia from an HIV angle. I'm an HIV physician. And when I first started my practice in Malaysia after training in Australia, it was in the late 1990s when there was a rapid escalation of HIV incidents amongst people who inject drugs. We were reporting on the upwards of, at the time, 6,000 new cases per year of people newly diagnosed with HIV in Malaysia for a population of about 28 million people. And that was largely because of the absence of opioid substitution therapy, opioid agonist therapies, absence of needle syringe program. And it became very clear that, you know, this could not go on. And having seen or having practiced in Australia earlier, where I actually didn't see a single one, maybe I saw one person in the 7 or 8 years that I practiced in Australia throughout my training in HIV, who acquired HIV as a result of drug use. I thought, you know, this is something we needed to do in Malaysia. Naively thinking that it was going to be an easy thing to do. Well, if any of you have been to Malaysia, you know that we take very strong views on drug use and trafficking, and you'll be reminded that it still remains a death sentence, although not a mandatory death sentence, as you land in Malaysia. So the opposition was stiff. The opposition came from all corners to introduce harm reduction, but this was this was around 2005. It so happened that at the time there was a review of the MDGs, the precursor to the SDGs, and the one thing that Malaysia didn't meet in the indicators was to reverse the HIV epidemic. So we were allowed to implement or pilot the needle syringe and opioid agonist therapy. And I think the lessons that we've learned from there and the important lessons, I think, for many countries and for Malaysia in where we are now at with trying to decriminalize drug use in Malaysia, I think there are a few. One is targeting your engagement and your activism and advocacy to important stakeholders, and in this case, the police, the anti-narcotics agency, the health department, and providing them with evidence, and it's important to grow local evidence, because one thing I heard very commonly in those early days, and even now in trying to take the management of drug use or drug policy to the next level is, the West can do all these things, but will it really work in a setting like Asia? So growing that evidence locally, and I know pilots can sometimes remain as pilots forever, but it's also important to gain the trust of governments, of communities, is to have well-designed pilots, but also embed within it monitoring and evaluation programs that can then be used again as evidence. And I feel that was what was very helpful in Malaysia in trying to introduce this extremely controversial, at the time, program of harm reduction. We're taking those lessons in terms of doing the same thing now that we want to advance discussions around decriminalization of drug use. So engaging the right stakeholders, having scientific evidence, and of course, working with communities. So at the time that we were introducing the needle syringe program and opioid agonist therapy, I was also president of the Malaysian AIDS Council, an umbrella organization of community-based organizations and NGOs, and they were colleagues who were former or current drug users were instrumental in terms of not just designing the needle syringe programs, but also in being hired as outreach workers. Now that I must admit had a bit of double-edged sword, because particularly because it remained criminalized, that when police raids happen, that it could put our outreach workers at risk. So working very, very closely with Ministry of Health and the police department kind of reduce the risk related to arrest and incarceration of outreach workers. It was something that was pretty hairy at times. I would get calls and say, there's been a police raid of ports where we would go and give the clean needles, and sometimes the outreach workers would get swept into these raids. So, but over the years, even in the presence of these still harsh laws, training police agencies and officers became a crucial part of the success, and having an MOUs between Ministry of Health, the Malaysian AIDS Council, and the police force. Through the years, as we were able to show the positive results from the reduction in HIV incidence, but also the other piece of work that we did was look at return on investment and cost effectiveness of these programs. They have now been incorporated as national programs by the Malaysian government that pays for these programs. It's integrated within primary cares for both the opioid substitution therapy delivered by primary care physicians, and needle syringe programs not quite integrated into primary cares, but co-located and delivered by outreach workers and present and former drug users within the primary care clinics. So I don't like to kind of blow my own trumpet, but I think it has been a successful program, and learning from those lessons, we feel that we have engaged and worked very closely with government agencies and police force, etc. So the next step is really to look at the different laws that are in Malaysia that's causing about 66% of our prisoners being people who use and inject drugs, with all the complications that come with it.
Thank you, Adiba. That was very useful. Thank you very much. Well deserved. I mean, this is very important because Adiba has actually mentioned the HIV context, also how it's very important to have not only the government, but the people affected working in unison. So national unity or the community and government unity are very, very important. So thank you for that, and we'll have question answers. Please stay for that. Next, we have a very interesting speaker because she actually is from the UNODC, which is the implementing agency of the drug conventions. So she's in the hot seat, as it were. But I must tell you, the UNODC has been implementing, and a lot of us had a lot of problematic issues, if I may put it. But over the years, and particularly in the last few years, the UNODC has actually changed its orientation, and things are they're looking better actually. From our point of view, UNODC. So I don't want you to be in the hot seat, but you can try to be in the hot seat and answer questions later. But we'll welcome to your remarks now. Thank you. And there's Seema Joshi Arya from the UNODC.
Thank you so much, Mr. Anand. And at the outset, I would also like to thank the organizers for inviting UNODC to be part of this useful discussion, which is also very important. So I'm Seema Joshi, and I work as a criminal justice expert with UNODC. So I'll be speaking from the point of view mainly in terms of, the punitive drug policy and how UNODC has also been working over, as has already been mentioned by Mr. Anand, that over the years, UNODC has changed its approach from moving from the custodian of the international drug conventions to more towards partnering and actively working with communities, with member states, with health professionals, with social workers, on not just only on supply reduction, which was the main forte of UNODC, but also towards harm reduction as well as demand reduction. That's what we have been doing. And in terms of changing our approach, the approach we have taken now is, over the past 2 decades, is putting the people first and more health-oriented approach, people-centered approach, and within the evolving human rights framework which is there. This is in line with the UN's, the UN's statement, the policy on drugs, also in line with the Sustainable Development Goals and other health-related issues. So in terms of, if I may just say, UNODC here in Delhi, I would just give in one line that it's a regional office which covers the South Asia region and which covers 6 countries, India, Bangladesh, Bhutan, Nepal, and Maldives. So particularly within the region, we have been working a lot with not only with law enforcement agencies, but also with health agencies as well as social workers. And in terms of our work, how we navigate, because as we have seen, as has already been talked by the previous speakers with my co-panelists, that even today, most of the countries, not only within this region, but of course globally, have punitive policies on drugs, particularly on drugs. They criminalize drug use, people who use drugs. There is a stigma, there's a discrimination. And what we have been doing is that we are actually trying to work with member states mainly on in terms of 3 aspects. One is basically providing them with technical assistance and policy dialogues. Second, we work on the capacity building and the trainings of not just of the law enforcement authorities, but as well as the frontline social workers and communities. And third, we work on the regional cooperation, because being a UN agency, we stand out. We are in that role, and so wherein we can have lot of other member states to come together at one table and convene dialogues. For example, I don't know how many of you are aware about the Commission on Narcotics Drugs, CND, which happens every year at Vienna, where all these discussions take place. So that is one aspect. I'm going to give you a few examples of UNODC's work so that just to better understand what we have been doing within the region. When I joined UNODC way back in 2017, I was mainly I joined this particular organization to implement one very unique initiative, which was about the looking at the regional drugs project. This was basically India and 3 other countries, Bhutan, Bangladesh, and Nepal. And one of the most unique aspect of this particular initiative was to create safe spaces for the law enforcement agencies, for the community, the people who use drugs, as well as social workers and health, to come at one table and discuss about the issue of drug use, particularly about the criminalization of drug use. And in this particular initiative, we actually successfully were able to convene these country-level workshops, and most of the country governments, particularly from the law enforcement agencies, they were really appreciative of this particular initiative, wherein each one of the stakeholders was able to get that safe kind of space wherein they could understand each other's challenges and could discuss this important sensitive issue of drug use, and to come out with some sensitive solutions also to this. So I think this is one of the most important role of UN agencies, to provide safe space for all the stakeholders to come and be at one table and discuss these issues. And in particularly in Thailand, if I would say that we have also been instrumental. We had, instrumental with the Department of Narcotics Control, the Narcotics Control Board there. We convened the interministerial meeting wherein we had different stakeholders being at the table, and we were instrumental in, reducing the sentencing, also moving from mandatory treatment towards the voluntary treatment. Similarly, even in Vietnam, in most of the Southeast Asian countries, we have been advocating this particular approach to the country governments. However, it's not that easy considering the complex political landscape we have, and not just the political landscape, complex political landscape. Of course, each country talks about their own security related issues. There are other global geopolitics things which happen. But still, what we have been doing over the years is that we have been advocating about this health-oriented approach mainly with the key government holders. For example, when we talk about the decriminalization, so in terms of our work, we are not particularly, as say, been using this terminology of decriminalization, because we know that few of the government might not be very open to this particular idea. However, what we have been advocating is alternatives to incarceration, particularly for the people into drug use who are into non-violent offenses. We have been promoting that. We have promoted the non-custodial measures in Bangladesh, in Sri Lanka, Maldives. With the, particularly we worked with the prosecutors, we have worked with the judiciary, promoting the non-custodial measures. We have also worked in most of the countries, advocating for diversion, like what Mr. Anand was speaking in this particular initiative, which I had mentioned just now. We tried to promote just one example of, NDPS Act of the India, which is there, Section 64, which talks about that diversion of the person for rehabilitation and treatment. So most of the law enforcement officers and even the community people are not aware of it. So through this initiative, we try to promote such kind of provisions which are already there. So rather than speaking about decriminalization, we have been using some soft approaches with government. And as UNODC is also a co-sponsor with UNAIDS in terms of the implementation of joint program on AIDS. So we have been also working particularly on harm reduction. In this regard, if I may just quote one more initiative, for example, in India, recently we had one of the very important consultation with prison officers in state of UP, wherein we had almost around 80 to 85 prison officers being there part of that particular consultation. And we had a lot of other experts, and there were issues which were discussed mainly about the prison health in the context of communicable diseases, HIV, TB, Hep C, and also in the context of people who use drugs, who are incarcerated. And not only that, we also spoke about, there was a particular session which was dedicated on the issues of women who use drugs but who are incarcerated, and of course the transgender people who have been incarcerated. So, and we also came up with a unique prison toolkit wherein we had the interactive games to sensitize the law enforcement officers about drugs and HIV, and also the inmates. So this is how we have been working with the government, and also with the community workers. We have trained a lot of CSOs, particularly on coming up with the, having this OAT services and on stimulant drugs. And other trainings and capacity building exercises. We have also been involved into a little bit of regional cooperation, the exchange of best practices. That's what we have been doing. We had people from the drug, officers from Maldives and Sri Lanka visiting India and going to National Drug Dependence Treatment Center to understand how India is doing, in terms of drug treatment, and also to Tihar. And I would also just like to highlight that we have UNODC has been the organization which has been supportive of, which supported the first OST center in Tihar way back, and it's still been continuing. So these are the few things which we have been working with government, with the member states to promote on all the aspects of drugs, not just supply reduction, but also demand and harm reduction. I think my time is over and I'll have to wrap.
Thank you, Seema. That was very useful. It's clear that the UNODC in Delhi, at least, started to shift its gear and indicated that it gives a safe space to all stakeholders, health-oriented approach, non-incarceration alternatives. These are very, very important, and I'm glad UNODC is taking lead. Next, we have a person who's affected, Alok Manan. I've known him for a very long time, and he's very active. Unfortunately, he's a solitary figure from the community. I wish there were many more, but at least he will be a voice that we must listen to. Thank you.
Namaskar. I won't talk about much about, mostly I'll talk about the drug policy, what is existing in India, and what are the flaws in it. Because harm reduction, generally I don't talk about it because we have a very successful program in India supported by Government of India, and which is harm reduction. Successfully running all over India. That's one thing. I talk about the drug policy, basically punitive to, treatment friendly. So first I'll talk about what existing drug policy we have. Madam has talked about, about the NDPS Act and its amendment. Then we have mental health. There is a central policy. Then the state level it comes to that also, again the mental health policy. Some states it covers by the social welfare department also. That varies differences. But generally what they talk about is the infrastructure of the treatment. Nothing else. It's not related to, what kind of a space, what kind of the human resource and other things. That's what they talk about, the mental health I'm talking about. And the center also has a mental health thing. Then there comes the NDPS Act, which is a central policy. And mostly I'll focus on that only. This came in 1985. Then later the amendments. So it's 40 years old now. It's not in childhood, not in early childhood, not in teenage. 40 साल का बुढ़ा हो गया है ना? But how many people knows about the NDPS Act actually and how it is implemented? Nobody knows. There are many things which nobody knows. I'll give an example which is known to everyone. A kin of a celebrity was arrested some time back, was chatting on a WhatsApp, and he was arrested. And who can afford the top advocates of the world in seconds? And he was behind the bars for quite some time. And if sir was talking about the Punjab, if you see in UP or Northeast, where the people you are using are caught, and you think of, the family, is, they don't talk, they want to avoid them. Most of the drug users disown the family, disown them. So they don't have the support of the family also. And if he is arrested, so who is going to support them? The kin of the celebrity has all the resources, but that poor guy, what resources he has? Arrested in Punjab or remote area of UP or Rajasthan or somewhere else. No law enforcement agency knows what the NDPS Act is, what it is talk about. Madam said his amendment talks about the treatment and rehabilitation center. Who knows about it? They misinterpret it, they interpret it, and again they misinterpret it. The thing is that there is a amendment says, the people is caught with this much of quantity, will consider as a consumer user, and if he has more than this quantity, will be look at as peddler. If the law is saying this, it differentiating the category. And then again, the so-called intellects, they interpret it and then they misinterpret it, the gray area of it. It's not supportive. Unless, until any policy, any law is supportive of what? Support of you all, perception of you all towards a drug user, perception of the society, perception of the treatment provider, perception of the advocate, perception of the judge. It doesn't change. No policy is going to work. No policy is going to work. No policy is going to work. Because, as in the beginning of the session, sir was talking about alcohol and cannabis. Okay? If in your family, a teenager, you came to know, was consuming alcohol, having a beer, was a different scenario, different perception. And if you come to know he was smoking a joint, there will be chaos in the family. That's our perception. I'm not encouraging drug use. I'm talking about generally how people think about the drug use. A person is found, teenage, I also started at a very early age. There was no awareness and treatment also available that time. I'm talking about 82, 83. Maybe, I mean, I was in class 7, 8, then I started in a very early age. That also from, I'm not from Delhi or Bombay, I'm from UP, Lucknow. So, I mean, there I started drugs. So, I mean, it will be a chaos in the family. There was no treatment available that time. I mean, chalo, alcohol, beer, pira is okay, tolerated, accepted. But they came to know, I mean, he was smoking a joint with the grass or weed or whatever, there will be chaos in the family. That's the perception of the society is towards the drug use. Unless this doesn't change, whatever policy you make, their intellects are there to interpret it, to misinterpret it, at the Thana level, at the block level, at the court level. So, I mean, you cannot change it. I'm wearing a t-shirt which I wanted to show a message. It carries a message. I just wanted to show it. It carries a message. I mean, I'll show you.
I hope the stripping is only up to the waist.
I mean, this is the perception. This perception should be for a drug user, to all. This is the t-shirt. That's what we want, nothing else. If your perception, of the family perception, of the advocate's perception, of the judge's perception, of the law enforcement perception doesn't change, nothing is going to change whatever policy you make. It is punitive or treatment friendly or whatever way. Nothing is going to change unless until our perception doesn't change towards the drug users. That's it. Thank you so much.
Thank you, Alok. I must tell you, recently only, about 2 weeks back, I was doing a case in the Supreme Court, and we had a very good case on law. And I told the judges that on each point, I have 5 points, each point the person has to be acquitted on the single point. So the judge said, what is the case about? I said, it's drug possession. Oh, Mr. Grover, please. So I said, I'm sorry to say, there is evident bias in your lordships, which never, a lawyer will never say it, but I had to say it. Then he got, I said, I'm sorry, but this is not only of judges, it's true of society. And that's the point that Alok is making. And we have to disabuse judges and also lawyers and the community. So, in fact, I was asked in the National Judicial Academy meeting, I was doing a training on Narcotics Act, and the organizer, she told me, Anand, be provocative. And I did the same thing, like I asked you, how many of you take drugs? And there were these judges sitting. They fell out of their chair. But you have to do this to provoke people. Otherwise, people easily accept things unless they think it is important to question. But we'll have a chance to discuss that. Next, we have Atul Ambekar, who is actually a doyen in this field, in the medical field. I don't think he needs any introduction. He's done excellent work in the medical field relating to drugs. Atul. After he speaks, we'll have time for discussion.
So thank you very much, Chair. Good afternoon, organizers. Thank you for giving me this opportunity. I'll echo, since I am a psychiatrist, I perform and work in the area of treatment of addiction, so I know a thing or two about human behaviors. And I'll echo with some of the thoughts expressed initially by our chair. One is that to do something to change your mental state is a natural human behavior. We human beings have been doing something to alter our mental state since time immemorial. Dancing, music, sports, recreational, and use of some chemical substances which can alter our mental state. So it's a natural thing to do something to change your behaviors, and then it remains an issue of debate to what extent indulging in a particular kind of pleasurable behavior is going to be harmful for you. So naturally it follows that the measures a society takes to govern, to regulate such behaviors which are pleasurable yet harmful should be proportionate to the degree of harms that can cause. Unfortunately, that has not occurred as far as psychoactive substances are concerned. So the modern history of the control of psychoactive substances, the drug laws and policies is rooted really in racism and colonialism. All those psychoactive substances which got banned, prohibited as narcotics, were the plant-based products which we, the people of global south, of developing countries, we have been producing and consuming. Cannabis, opium, cocoa bush in Latin America. Instead, so these substances were banned, prohibited, and the Scotch whiskies, the red wines, and the Marlboros of the world, they were not actually just allowed, they were actually celebrated and endorsed. And that's what we see today happening. In fact, a few decades ago, if not centuries ago, in many parts of the global south, products like bhang, cannabis products, they enjoyed the same reputation which alcohol today enjoys in many parts of the world. A recreational substance to be used occasionally, and if someone is doing it excessively, that's something which is frowned upon. But that's how things got changed because of this colonial and racist attitudes. If chance, it's available online, and let's read the report of that time of WHO in 1950s and 60s about recommendation about what to do with cannabis. And the text there says, about cannabis, it's harmful. Not just brown and black people and Mohammedans, even Europeans have started using it. Horror of horrors, right? So that's how they sort of vilified and demonized cannabis. But now things are changing. There is more research. As our chair was also telling us, there is now better understanding about some of these drugs, what can do to a human body. We now have clear evidence that alcohol is much more harmful to health than many of other so-called banned drugs. So that's how the governments actually have to changing their opinion also. Our chair rightly and jokingly said that she is on the hot seat being from UN system. But then, to be honest, I know that UN system, UNODC, UNAIDS, WHO, they play a very important role in shaping national governments' attitudes, laws, and policies. But ultimately, the buck stops with our national governments. The buck stops with whatever the government wants to do, if a government has decided something in the interest of their citizens, there is pretty much not much which UN system can do. Few years ago, the government of Canada, it decided that its citizens have the right to use cannabis recreationally, just like they have the right to use alcohol. And that's how they allowed complete legalization of cannabis in their country. And there is showing the thumb, if not the middle finger, to the international drug conventions. And there isn't much the international global community could do about it. So it all depends upon the national governments, basically. And if we lament the fact that we do not have the laws and right kind of laws and policies about illicit drugs, then it's our governments which really we need to ask some difficult questions from. And in this context, I will add to Anand's perception and right point that there is no community members here as stakeholders. I would also add to it that I wish we had some of the stakeholders for the government who are responsible for making our laws and policies. As far as government goes, we often, people outside the government, we often make this conception or perception of government being a large, homogeneous, monolithic kind of entity. Even within government, there are different sectors, there are different ministries, departments who hold different opinions about drug laws and policies. For instance, under the India's own NDPS Act, two ministries of, in fact, Government of India have gone on record officially to say that people who use drugs, they do not deserve to be treated as criminals. They deserve our compassion, our empathy, and treatment and support and whatnot. So this is a matter of records. Even our Honorable Home Minister on the floor of Parliament as well as in other public forums has publicly declared that he supports that people who use drugs, they should not be in jail, they should deserve treatment and not punishment. But again, these are words and they need to be put into action by bringing some kind of amendment in the law. So That's something which remains an agenda for us, the health sector. I'll very quickly, I'm just summing it up, Anand, that about the issue of harm reduction, So it's fortunately in India at least, the principle, the policy, the concept of harm reduction receives very explicit endorsement by the government. The government of India's NDPS policy explicitly endorses harm reduction approach. Unfortunately, and this is the sort of irony, that overall in the world, including in India, the concept of harm reduction got acceptance in the wake of HIV epidemic among people who inject drugs. Unfortunately, that is what the shaping of the policymakers' opinion, that harm reduction is only about preventing HIV. So if there is no HIV, why do we require harm reduction? That's how people commit the mistake of. There are many other important harms by using drugs besides HIV, such as overdose deaths in US. And that's why we continue to have a requirement of embracing and basing our public health programs on the basis of a balanced combination of treatment as well as harm reduction approaches. So I'll conclude here, and I hope we have some time for further discussion. Thank you.
Thank you, Atul. That was very useful. We will have now time for question, answers, and interventions from the floor. But let me just, as a lawyer, tell you a couple of things which are very, very important in the context of the Indian law. Now, the Indian law has unfortunately implemented the drug conventions fully, to the extent that we have actually not followed our constitutional principles, which is a matter of challenge. For example, there's a reverse burden of proof. If you are in possession of a drug, it's presumed you are guilty once you have proved possession. That's one. Secondly, until we challenge the provision in the law, section 67, unlike the normal law, I don't know if you know, but under the normal law, if I'm arrested by the police, okay, I'm taken to the police station, I give a statement, yes, I've committed a murder. That is not admissible in evidence, unless under section 27 of the Evidence Act, I say, yes, I've committed a murder, I've used this weapon, and it's lying there. And I direct the police to that weapon, and only to the extent of the weapon is there, that is admissible. Otherwise, statement is not admissible. But under section 67, the narcotics officer just had to get confession extracted. It's very easy to get a confession extracted in police stations. You just give a danda and everybody, 99% of the people will confess to whatever they say. They actually write it, you sign it. And that was the sole basis of convictions until we challenged it in the Supreme Court, and Justice Rohington Nariman gave a brilliant judgment in a case called Tufan Singh. So nothing doing. Narcotics officers are police. Therefore, these statements are not admissible. And now they're having a huge amount of difficulty in convicting persons. Secondly, because I teach at the National Judicial Academy also, one of the times we had a discussion on forensic examination. As a lawyer, I used to always ask the prosecution when they brought the forensic expert, I said, did you calibrate your instrument? Did you do this? Did you do that? I said, why aren't you releasing those data that is required for a fair trial? He said, if we give that data, all of them will be acquitted. The problem is that there's no fair trial. And the police are actually very corrupt. They use the act to extract money all over. There's no doubt about it. And I'm making this as a public statement. Let them file a defamation suit. They don't dare, because you know Aryan's case. It's very famous. So with this, let's have questions first. And then if you want to make an intervention which is slightly longer than half a minute or whatever, please do. So please raise your hands and introduce yourself. I'll just indicate. We are now at 1 hour, so we have actually a fair amount of time. So you can, what we will do is, if we can, subject to your approval and the panel, we'll have 3 questions. And if you want them to be directed at a particular panel speaker or anybody, please indicate. So first, raise your hands. You are there. 1, 2, okay. This gentleman, oh, there are 3. So I'll go one by one. 1, 2, 3. Question?
Yes, sir.
Please do. And indicate your name, please.
Yeah, I'm Saravana Murthy from PATH. So actually,
Saravana Murthy.
Saravana Murthy.
Murthy, okay.
Yeah, thank you. Sir. So from yesterday I was listening, like this is my third.
No, you'll have to hold your mic.
Sorry. From yesterday I was listening. Primarily, my focus was on how this evidence is being converted to a policy and how this policy is then going to an actionable points. So that was my focus from listening from yesterday in various sessions. So what I observed, like there are emotions required when a policy, evidence need to be converted to a policy, and a knowledge required, and engagement of stakeholders that all required. Like where we stated about government, he said, and then community people, and political leaders, and then resources required, and then a lot of evidence, and there are, in the morning case, they were saying use case scenarios. So these are some of the factors I could able to observe. Knowing all these things, like we know all these things, these are all the thing, various factors, there might be many other factors, but still we could not able to, at least in India, I'm not sure about other countries, but in India we could not able to succeed to decriminalize usage of drugs. Why is it so? That's my question.
No, is your question then, is evidence-based the main factor, or why should it not?
No, there are multiple factors which I listed.
So anybody wants to answer that, because this is a major issue in the drug issue. So we'll have a quick round. People can express their views. Adiba first. No, everybody can answer. And Alok, let us start. Okay, we'll start from your side. Alok, start.
I mean, so I was talking about bhang. So, I mean, it's very funny. It's legal in Noida.
It's legally all over India.
Not in Delhi, sir.
It is. Legal.
Sorry. Sir,
it is there because Mahashivratri, we need to have it. We haven't forgotten our culture.
So, I mean, it's officially available. It's marketed in the government shops in Noida, but it's not in Delhi. So I was scared of using it in Delhi. If I use it in Delhi, so I could be punished. I mean, what the difference is, I don't know. I mean, that's what I wanted to say.
Yeah, okay. No, but you have to answer his question. Why? Anyway, whatever you want to say. Atul?
I'll venture an opinion here on why do I think that decriminalization is difficult to do. And for this, I will take inspiration from our friend Alok said here, that we need to change the public attitude towards this. This is, in fact, the common psyche of people, that any undesirable behavior, if it has to be prevented, it has to bring severe punishment, right? Ask people about anything which they do not like, and their first knee-jerk response is, shoot him at sight, latka do phansi pe, right? Those kind of things. So people want these extreme kind of steps, and that's the and that's where our policymakers, our lawmakers also possibly are guided by. So a gradual change in public opinion will be very important for this, coupled with availability of scientific evidence that such laws and policies are not just non-effective, they are actually more harmful. So it's not just that criminalizing drug use is not effective in deterring drug use. It's actually causing more harms and damages. That kind of evidence needs to emerge, and particularly our lawmakers, the parliamentarians, who are representative of us, they need to then change. And that change will have to be gradual, and will have to be at a mass societal level. So the statement which our Honorable Home Minister made on the floor of Parliament, that actually is a very good example of advocacy plank of how it can further influence the policymakers' opinion. But I can already see these winds of change. So I remain optimistic. Thank you.
Yes, go one by one. Oh, you don't have a mic.
It's okay. So in India, what we have seen over the years is that, first of all, India is such a big and huge country, and with so much of diverse population, you know. Of course, what has been mentioned, that the perception of the people needs to be changed. So even the lawmakers, the judiciary, the prosecutors, who are they? They are part of society. So whenever they are there, they also think sometimes from that point of view also. And of course, they are bound. If the judges are sitting there, they are also bound by the law which is there. But so the perception is one of the things which needs to be changed, but there are other factors also which play a very important role when any country, not just India, wants to make a very important decision at the, amending the law or changing the policy. For example, decriminalization. They need to be, there are many issues. Politically also, they need to think about it, whether they need to decriminalize or not. That is one of the most important factors. Other geopolitical factors, the societal pressure. And of course, in our country, we have different government agencies which are dealing with drugs in terms of different mandates. I mean, they 3 or 4 of them are dealing with drugs, but one is dealing with the demand reduction, one is dealing with supply reduction. And the person who's dealing with supply reduction might have some different kind of views in terms of decriminalization of drug use. So there are many, many complex factors which play a role in that. But what is, I think, is very, very important and which is very positive, which we are seeing these days, I am sure my co-panelists also will agree here with me, that slowly and gradually there has been a change in the perception of the policymakers also, in the perception of the prosecutors, the judiciary and the policymakers. But this will happen slowly and gradually. We cannot expect this to happen just today. For example, like Dr. Atul has mentioned, that even the Home Minister in the public forum has been saying that, it is an ailment and we should treat them with compassion. However, still they have not changed the policy or the law. So it will take a little bit of time, but definitely we have to keep advocating for it. As I mentioned about promoting the non-custodial measures for the people who use drugs and different kind of alternatives for treatment, rehabilitation. When we talk about rehabilitation, there is a need to sensitize the society as well, that these people are not criminals, but they are the people who need our compassion. We should not be discriminating them. Thank you.
I've actually been thinking a lot about this. Why is it so hard to make these changes? Number one, I think even in non-controversial areas, implementing evidence into policies is really difficult. I mean, it's on average, I think it's been said, it takes about 70 years to implement and scale up an effective health response. I mean, take a look at PrEP, for example, in HIV. The landmark studies were out 20 years ago, and how many countries have adopted and scaled up PrEP? A little bit controversial in some countries like mine, but by and large, much, much less controversial than drug policy reform. Still takes a long time. So that's number one. There's a lot of inbuilt inertia in advancing evidence into policy. Number two, it's a complex problem. It's not just a health problem because it's been in the hands of law enforcement for many, many years. In fact, I think we health professionals in many ways have abrogated our duties and kind of left it to law enforcement to manage and handle people who use drugs for decades. It's only now that there's an awakening with people like Atul and others championing this. And so even within the health profession itself, there's a lot of mindset change that needs to be done to support the movement. And so there are many, many more actors that need to be convinced than, say, implementing NCD's policy. Even NCDs, we're so far behind, right? And that's pretty uncontroversial. But here we have law enforcement, we have non-health actors that need convincing. Number three, I think it's so hard to change ideology. So hard, and this is probably one of the critical factors. Once minds are made up that people who use drugs are horrible people, people who use drugs don't deserve to be treated like a human being, it is difficult to change that mindset. Just look at the MAGA movement, right? Just look at the anti-vax. You have well-informed, educated people who refuse vaccine. Why? And no matter what evidence you give them, you may not be able to change, their perception, like what Atul is saying. So I think these are some of the reasons. Number 4, what Shima was saying in terms of the evidence itself, the evidence that, it's not entirely a brain, sort of problem, but how many people out there know that smoking cannabis does a different effect to the brain compared to taking heroin, compared to fentanyl, compared to LSDs? Again, it's the health profession haven't kind of done a good job of explaining the changes to the brain from the different types of drugs that we use. So they all get lumped into bad drug users, and when we try and advocate that, you need the opioid agonist treatment where there is treatment, it kind of, the law enforcement and even in health professionals, like, what are you talking about? So I think we ourselves haven't done a great job of explaining the impact of drug use, different types of drugs, including alcohol, to the brain. And we also haven't done a great job of explaining, and I think this is really terrible, that we haven't done a great job of explaining to the public the sort of the drivers of drug use, the poverty, the breakdown in family, divorce, the environment, the social determinants of health, the social determinants of drug use. I think, it then again gets lumped into only bad people use drugs, right? But that connection, that what drives people to use drugs, also we've not done a good job of telling the public. So I think there's all these different angles to it that we've not dealt with, and expect, decades of the war on drugs, zero tolerance and all that for the public to take a 360-degree turn is, as Shima said, going to take time. But we don't have time because there are millions of people in prison. There, that's causing a lot of harm.
Thank you. I am not going to allow individual questions to be answered. So what we will do is, I'm not going to answer this question. I'll do it at the end. So we have 1, 2, and 3, or 4. I'll take all 4 questions. We have only 15 minutes. So I'll ask one of you to answer, because otherwise we'll never finish. And please indicate your name.
Hi, I'm Dr. Shirish Rao. I work as a casualty medical officer in a secondary care hospital in Mumbai, as well as I am a researcher at Association for Socially Applicable Research. I didn't have any questions till you mentioned the point of the police giving the evidence that this guy has just consumed drugs. So this is something that I encounter on daily basis, with police coming up with a group of people who from most of my patients are slum patients. So they just go for a raid, collect a group of patients, and they are like, sir, ye NDPS ke case hai, inka bana ke de do. And I realized that these people only have 2 lines of defense in their end. One is the medical verification of it, and second is a lawyer who might support it. Considering that they come from a socio-economic background, that they are having a law support is impossible. Considering what access they have and the awareness they have. The first line is that proving that they have consumed drugs or not. And we, I as a casualty medical officer, have been working for 7 months, and no one has given me any training or guidance to how to actually encounter this patient. My seniors who have been working for 20 years are just NDPS ka case aayega, and if the max you have to do is ask ki have you consumed. There was one case, the dilemma that I have faced till now is, usually people just confess, okay, I have consumed, none. In one case it was ki, the group is saying that we have not consumed. They have just come here and they have just collected us for their arrest ka quota. and they are fooling us. And I am like, ये लोग मना कर रहे हैं, I cannot do this. So police just ऐसा बाहर लेके गया and 10 मिनट बाद डंडा मार के वापस लेके आते हैं, and they are like, he agreed. So like the धमकी that they give is like, हम और बड़ा केस करेंगे तुम पे. Like even we are unaware of the laws that happened. Like the police, like when I ask the people like what is going to happen to them, they are like, according to law, this is like mostly like as far as my understanding, it's an imprisonable offense. Okay, but what they tell to these people who get arrested is like, थोड़े दो दिन थाने में रखेंगे फिर पैसा देके छोड़ देंगे. So how does this system work at like the ground level is what I wanted to understand. And second is similar to like all of medical legal cases that we do. Like we have a support system for rape survivors, survivors for domestic violence. We have a system called as Dilasa where we send these patients for counseling. So ये जो झुंड of NDPS keeps coming, can we have like a on-ground support system for them who just keep coming for medical examination and then like चलो वापस and then एक हफ्ते बाद वापस arrest करके लेके आएंगे?
Okay, basically the question is that people are being arrested to fulfill quotas for the police, which shows that the whole thing is a sham. But now doctors are put in a dilemma and they have no training. Unlike, you're right, actually I was very much involved in rape survivors medical training with the Bombay groups. There is no such thing for cases dealing with NDPS. So anybody want to answer? What should I can. No, this is a very, very important question, but I won't allow me to answer second question first, because otherwise we won't have a. But you keep in touch with me. I'll try to, because there are a lot of doctors who have asked this question. I think we should do something about it.
So yeah, I'll keep this short in the interest of time. I'm Abhijit Nadkarni. I'm Professor of Global Health Research at the London School of Hygiene and Tropical Medicine.
London School of Hygiene.
Yeah, and Tropical Medicine, yeah. So it's a wonderful representation of different perspectives on this panel, you know, lived experience expert, medical, global policy, and legal. But what's interesting is in all of the things all of you have said, the focus has been at one end of the spectrum, which is treatment, rehabilitation, harm reduction, or kind of legal remedies, etc. I'd be interested in hearing from some or all of you, depending on the time that we have, on your perspectives on prevention, the other end of the spectrum, from the different positionalities that you sit at, the places where you work from. And that's what would be of interest for me, because otherwise...
What do you mean? Explain. What do you mean prevention of what?
Well, prevention of the initiation and continuation of substance use, because we are focusing only at one end of the spectrum, whereas the other end of the spectrum remains underrepresented in the discussion that we have had today.
So in other words, how people should not take drugs?
Well, how not take drugs or not initiate or delay the initiation or reduce the impact of it when you start.
But isn't it a loaded question that, just as a question I'm asking, that it's bad for you?
No, okay. Obviously not. I mean,
I'm playing the devil's advocate. 1, 2, and 3. Okay, after 3, because, but very quickly somebody will take one question. I'll take the first one. Somebody will take the second question. Prevention. You will do it, Atul. No, not now. Third question.
Hello.
Yeah, please give your name and...
Yeah. Hi, my name is Sanya. I run a digital mental health therapeutic company. We're currently piloting a intervention to address the underlying triggers and the craving around substance and drug use. And what I wanted to kind of ask was, the point you touched on is, if we're starting to move towards a health-led approach, how can we also make sure we don't just replicate the current limitations of the healthcare model, which is very crisis management focused? So how do we make sure that this is very much looking at the social, economic, and sort of psychosocial element, the determinants around drug use, and where drug use does cause harm, rather than being this kind of punitive, it's bad for you. Of course, what we want to prevent is harm for users. So how can we take that approach even within the health-led approach? Thank you.
Okay, I'll answer the first question. Adiba, can you answer the final question? And Atul will answer the second question. Okay, there is no protocol like there is for domestic violence or rape survivors, how the doctor should meet it out. Now, you are being asked by the police, test them that they have actually taken a drug. So possession is a criminal offense. pursuant to the International Convention in the NDBS, so is use. So if the urine or the blood indicates its use, it's very rarely actually used for prosecuting. So doctors have to be trained. First of all, there's a major issue. Can you test a person? Okay? And doctors have to be trained. If the person says, I don't want to be tested, what happens? So these are very important legal issues. Right now, in fact, only on Thursday, the Supreme Court has decided to take up a case because the law for consensual sex has changed. It used to be 16 earlier, it's now 18. So what is happening is naturally young people are having sex with other young people with consent, in the sense it's not consent in law because consent is a concept in law, but they are willing. I, as a 16-year-old, want to have sex with another 16-year-old. It's illegal in India now. Now there are a huge number of people going to jail because of that, all over the country. And the judges are fed up. They say, what is this nonsense? They're just having sex, for heaven's sake. Why are they going to prison? Because of the law. So the Supreme Court has started to take up this case. So what about consent and all that? So this is also an issue in criminal law. Can you test an accused? Now there's a major issue on that which has to be addressed. But I think your issue of training doctors is more important. So what I'll do is, because of this and other doctors have asked, please give me your particulars and we will actually start doing something on that. The second question was this gentleman who wants to know what are the other part, sort of preventative measures. What can you do?
So thank you very much, Dr. Jeet, for asking that question. Indeed, for all health conditions, the three pillars of primary, secondary and tertiary prevention are important. What we discussed today was largely tertiary prevention in terms of minimizing the harms associated with drug use, be it of policy of decriminalization or other kind of harm reduction. So prevention remains a very important part of dealing with the public health issues of substance use as well. And there is a very large civil society sector working on the issue of prevention of illicit drug use. What unfortunately sort of remains unsaid or said between the lines is we are about preventing illicit drug onset while we are silent on what happens on alcohol and tobacco. So that's very, very harmful in fact. So, and that's the reason why the international standards for drug use prevention, which have been compiled by WHO and UNODC together, they are clearly showing the best evidence base for those kind of intervention strategies which are about preventing multiple kinds of harmful occurrences in life, including various externalizing behaviors, other kind of socially deviant behaviors, school performance and education performance, etc., along with initiation of all psychoactive substance use and of course the illicit drug use. So prevention remains an important component. We deliberately, the panel today was focused upon what happens if prevention is not successful and people are taking drugs. How does society deal with them? Thank you.
Okay, yeah, you want to add? Sure, please do.
So as Atul has mentioned that UNODC has this international standards on drug prevention, but as I had mentioned during the opening that ODC has also not only been working towards the harm reduction and only towards supply reduction, but demand reduction, which is prevention. And in terms of prevention, we are doing a lot of work, particularly in relation to one of our most important, I would just like to give one example, is Family Skills Program, in which we involve the parents, the children, as well as the educators, all three stakeholders in preventing drug use. And this particular program is implemented in community as well as through schools. And it is not a theoretical program. It is basically an activity-based program where we strengthen the communication between the parents and between the child, so that if there is any kind of negative social outcome which is happening or the child is having any kind of issue, they are able to communicate with their parents. And also one of the most important part of this program is how to avoid peer pressure in terms of drug use. So this is one which is already, and also, I would also like to mention that in India, with Ministry of Social Justice and Empowerment, we are piloting this program in 2 states. One is Manipur and one is Assam. And this is also again a pilot, so there is a research study also on the outcome of this program. But globally it has been successful, but again country to country depending on the circumstances. So we will be doing the research on this also and presenting it to the government, and maybe then the government is going to scale it up to the entire nation. And apart from this, there are many other prevention programs. We do have life skills, social skills, as well as we have, CHAMPS, which is a newly added program in which from the time the child is born up to the time of 18 or 20, it's a series of interventions which are there. So there are many prevention programs which ODC has been implementing across the globe. Thank you.
Thank you. Radhima, last.
Thank you for the question. I just want to quickly say that it's important to note that not everyone who uses drug needs treatment, right? Only about 10% or so end up requiring treatment. Is that Atul? Is that right? I'm not an addiction specialist. So, and they're the ones that need, to see people like Atul and others. So the others that may not even come into contact with the health sector, but if they do, then I think, there are interventions depending on what they're taking. That's not completely medicalized, the types of skills that Chimat's just described as well, sort of resilience and all of that. So yes, it's not just about giving substitute. Well, first of all, the only drug that where there is effective substitution is heroin, right? So it is more than just a medical intervention. You're right.
Okay, I think we started late because we allowed entry late. We may be able to extend it by 5 minutes. Who else has questions? 1 and 2. That's it. Last. So quickly, and then only one person will answer. Then we'll sum up and please give your name and indicate your question.
Yes, I'm Urvita. Thank you for this excellent panel. My question is about another ecosystem that can really benefit from drug policy, which is schools and colleges. I've heard the response about initiation, but what are your thoughts about why we are failing in schools and colleges when it comes to addressing harmful substance use? The response is usually awareness, punishing kids, isolating them, excluding them. Why are we still doing that in India? And what are your thoughts about the way forward?
Okay. Yes, you have to give your name and ask the question.
Okay. Hi, I'm Samantha. I'm from National Taiwan University. I'm studying Masters in Global Health. And I'm particularly interested in psychedelics. And we talked a little bit about cannabis and how that's being now used medically and then transitioned into recreational usage. And there have been several studies that have come out about psychedelics and their positive impacts on mental health treatment. So I guess I'm curious to know about how these clinical studies showing positive impacts of drugs that were typically like Schedule 1 or like very severe drugs like magic mushrooms and MDMA, and how now, since they're being more accepted as for medical purposes, how that might change perceptions of policymakers, of the public, and other stakeholders. Thank you.
The second question, either Ariba or Atul. And the first question is a repetition of the earlier question. So, sure, you can do that. And that's it, then I'll just sum up. No, you want to answer this first question then? Yeah.
Yeah, so in terms of schools and education, I think you're right that we have not been able, particularly in the context of India, to prevent the use of these harmful substances. But again, it is also, as has been rightly put, that this will not work, the punitive thing. If we are talking about that punitive policy will not work when the person is into drug use. So even for the, for this prevention in schools with children also, the punitive thing will never work. And also just saying that, say no to drugs and all these things, they are not going to work. What is required is what is required is communication, basically, and how our education system, our educators, particularly the teachers who are there and the family people who are there, they communicate with the children and how the children also communicates to them. For example, I'll just give you a very small example. When we first piloted this family skills program in Bangladesh, so this particular program was piloted in 2 countries in Asia globally, which was Bangladesh and Indonesia. And I was involved in piloting it in Bangladesh. Once this program finished with the educators and with children and all, you know what we heard even today we are hearing from those educators that we are using the, you know, what we learned during this family skills program, how to communicate, how to deal with children, what kind of parenting needs to be used, and you know, all these things we are still using when we are teaching, even if we are not implementing this particular program, but in our day-to-day activities with our children, we are using few of these skills. So I think this is what is required. And in India also, slowly and gradually, it is also very important to include some kind of, you know, these kind of skill-based things to be included even in the curriculum also. For example, ethics, integrity, all these things are also important. We have one very good program which is called Rise Up for Peace, which is basically working with the children as well as with educators, the education system, and to include within the education system the ethics, the integrity, and all these issues, so that children keep away from these harmful practices. And of course, we also need to give children some kind of alternative to not use. For example, if it's not just drug addiction, but maybe I'm going way, like even the phone addiction. So if you want the child should not use it, you have to give the children some kind of alternative. Similarly, even for drug addiction, if it's a peer pressure, how the child should deal with it, that skill needs to be developed inside the child. Thank you.
Final. Yes, I'll be very quick here. Thank you for that question. Basically, what she asked about is psychedelics, which is a group of psychoactive substances and drugs which bring about some alteration in your mind state. They have been used for literally hundreds of years in many countries as a social cultural pattern of use. In the last century, they were being used therapeutically when the UN Drug Convention stopped their usage as well as further research into their medical use. Now some of them are again coming into vogue, more evidence is emerging of their therapeutic effects, and I see some kind of bright future for their use. What we need to caution ourselves about is overhyping and glamorizing the use of these. So our policies about use of these medications essentially need to be guided by the evidence base and not just the hype around them. Thank you.
Thank you very much. I just want to add a couple of things. I think the question that you asked, I think, you know, it's the question of managing drug use. You can't tell a child, don't do this, you know. And I remember very clearly when HIV was at its height, I used to go to schools and colleges, Bombay, Delhi, etc., everywhere, talking to mothers, parents, and children and school teachers about sex. They didn't want to know. But the moment you started talking to them without being judgmental, it completely changed the whole scenario. And that's very important. Unfortunately, our programs are judgmental. Drug use, bad, finished. Children don't want to know that because they already have a mind, you know. They are not people who don't know anything. They are on social media. They know a lot of things which we didn't know when we were kids. So they need to be talked in an adult fashion. And they need to be talked at one-to-one. What is drug use? This is this. And we talk to them objectively and not be judgmental. That's very, very important. So I think that. And second question, which is actually very important, is why there's no effort to decriminalize. I don't agree that the government can't do it. The people actually are not so much opposed to it. It's the propaganda which is going on. You know, you're arresting people, and the stigma which is created by that is what is leading people to think in a particular manner. If you start talking differently about drug use, in a not judgmental way, the people will accept it. And that's what happened in HIV. HIV was highly stigmatic until we started talking about it. So you need to change your approach. And if the government decides tomorrow, by the way, and let me tell you, this is a sort of inside secret, as it were, not secret from the government. The change on decriminalization is unfortunately not going to come from the ground below. The Corporates are now interested in marketing drugs because they've seen the profits in cannabis sales in the US. I've been approached as a lawyer to give legal advice on that. So that's it. But it is your involvement in deciding these issues and framing policies which is very important. With that thought, thank you very much, and a round of applause to a brilliant panel. Okay. Photoshop. Hey, don't go. He's asking me to wait. Thank you. Hi. I know, I'll talk. Excuse me, give me a card. I'll send it to you. Where are you put it? I work in Baba. I know, I'm in Bangalore only. I don't stay there now. I have a house there. I have an office there. So I'll give you my number. You contact me, so I'll start to work on this. It's very important. I mean, I want it done. And I've been issued with a lot of things. It is great that you have this question. I mean,
Okay. Good evening. Okay. Can you hear me now? Okay. I thought I was a little too loud, so I was trying to be a bit quiet. But thank you very much for being here. I think it is not too often that we start late. I know we are starting a little bit late. And one of the things that I realize is that tuberculosis is something where we promised to end TB in this country by 2025, and we are almost there in 2030 in several countries. We have made significant progress. So what I'm going to do today, I didn't even start by introducing myself. My name is Pradeep Kakatil. I work on healthcare, leading Health Innovation Exchange. We are a Geneva-based non-profit platform. We have an exciting array of leaders in the tuberculosis space and in the innovative financing space and innovators in this room. So what I would like to do is to, as someone who's been leading the TB movement and setting the agenda and really making that significant acceleration of the response, we really want to start by listening to India's response. And it's such a privilege to have Professor Urvashi, who's the Deputy Director General of the Indian National TB Program. Ma'am, I would love to invite you to be our first speaker to set the stage, because this is one country where we have had the Prime Minister taking the leadership, committing. We have the technical leadership. If you look at technology, this is the country that has so many technologies to offer. When you start looking at investments, this again has so many lessons. So instead of standing in the way, I would love to ask you, Professor Urvashi, to set us off, and then I'll come back to the rest of the session.
Thank you, the hosts. Thank you, Dr. Luchika, Dr. Sahu, for having me here. And of course, all the audience, August audience here. So, where do I start? Actually, the passion behind TB elimination, I think it soaks in from right at the top when the Prime Minister gave this call for TB elimination. And for all of us who've been working in the sphere of TB for several years, like I have worked in the sphere for 30 years and plus, and I see several of my predecessors. Dr. Sachdeva is here. Several of our colleagues who've been working in the TB space for years together. So I think what has been the strength of India's response has been bringing in science to lead the policy. And that is why where I started when I took over as DDG, and frankly I took the reins from my previous DDGs and the program officers who've done a phenomenal job and actually kept the disease under control. When we compare our country to several other countries, I think we are, we have several things we can boast of. I'll come to those several things in just a minute. So what I would like to start by saying is science has always guided policy for us. It is research that has always been there to tell us what is the right step, what is the wrong step, where we are going right, where we are going wrong. And the fact that the ministry worked very hard to have everybody on board. So as the direction was given by the initial call for elimination, was that it should be a Jan Bhagidari. Everybody should contribute to their best. And that's where our collective wisdom and collective strength shapes the country's TB elimination response. So when I talk about research would be basic research, validating new tools, designing new tools, and relying on Indian indigenous tools for, not dependence on anybody from outside. Let me also briefly allude to the domestic funding component, where again I must give the credit to the hard work of the health ministry and the whole team under the leadership of our current and previous health ministers, who were able to actually enhance our budget more than 5 times over the past 8 years. And the Global TB report acknowledges that more than 99% of our TB program is supported by the domestic budget. Of course, we have colleagues and friends all across the globe, Stop TB being one of them, support from all over USAID, BMGF, Stop TB, and other partners, if I'm forgetting a few, has always contributed to new research, new tools, expanding the program, reaching the unreached, so we always have acknowledged their support. The differences that we have brought in are very many. So one, if you look at the diagnostics, we have, in addition to Gene Expert, we were the first country to actually poise an indigenous technology to compete, or rather support the Gene Expert. We have this TrueNet technology, where I must bring to you the amount of work and investment the government did, ICMR did, to handhold the company. Mr. Sriram is right here, and I'm sure he'll acknowledge the kind of support he received from the government in the initial days when the test was being standardized, undergoing multicentric validations, and then it was poised for the program to adopt it. Dr. Sachdeva went ahead, adopted the TrueNet in 2018, and we, as of now, have a network of 9,000 NAT systems. No other country can boast of. We have these systems at the PHCs, at the CHCs, at the block level, all across. So much so when we do a DNO, we have surplus. Even in Delhi, we have more than 3,000 surplus NATs available. So it is about, making the country self-reliant. And today, TrueNet is in fact exporting to 82 countries. So that's where our Indian indigenous technology, supported by ICMR, has reached. Coming to the treatment part, so there is no dearth. In fact, there is ample scientific experts, scientific minds in the country who lead the response. So treatment, again, we have teams who do trials and who bring in, new research, new knowledge. In-country evidence actually, excuse me, in-country evidence actually brought in supporting evidence for rolling out BPAL-M, which was recommended by WHO, but in our country, we want to be sure that there is, our ethnic population has the same, outcome, success rates as is claimed elsewhere. And it's only after that we rolled out the BPAL-M for our MDR-TB patients, and GDF under Stop TB was a great support, where we could acquire the protominid, which was very expensive. Till such time we procured within the country. We had support from them. We had support from Global Fund to buy the BPAL medicines. And here again, our scientific minds, our experts guided us. It was a decision that nobody else globally has taken. We are giving BPAL-M to our MDR patients. We are giving moxifloxacin as the fourth drug, even to our fluoroquinolone resistant patients, because when these four drugs act synergistically, we have a very strong regimen which gives us recurrence-free cure, really. Now, that was one initiative which is actually has already started showing results. Now, our patients on BPAL-M are gaining weight within a month, within 6 weeks, within 2 months. We're rolling it across the whole country. So treatment having been strengthened, what was the third thing for us to do? And in fact, a very important thing in place already during Dr. Sachdeva's time, 2018, the nutrition initiative as direct benefit transfer in the form of Nikshay Poshan Yojana, again a vision of our Honorable Prime Minister, was initiated with 500 rupees support for all our patients on treatment, 500 per month, which was doubled to 1,000 rupees per month from 1st November 2024. In addition, we had the Nikshay Mitra initiative, where we support our patients with food baskets, where research from within the country, again, like I say, this is a research-rich country. More than 5-6 research projects were done. Rations actually took the lead and is globally, acknowledged and acclaimed. We were giving food baskets to the patients from November 24. We enhanced the food baskets to the patients' families also. What we design is all science-based. We have defined amount of calories, defined amount of proteins to supplement our patients with the with the right nutrition. These were few initiatives, and then we rolled out the campaign. Again, science was behind the strategy of the campaign. We expanded the campaign, or rather focused on a vulnerable population to screen for subclinical TB. Again, a global first, where we offered screening by X-ray, the only recommended technology by WHO, to offer a screening for a vulnerable population, not only those who were symptomatic, but also those who were asymptomatic. So, just to tell you the outcome of this campaign, it was the hard work of our peripheral level workers, our soldiers in the field, our ASHA workers, who were able to lay down line lists of vulnerables at the peripheral levels. All villages, all Ayushman Arogya Mandirs in 347 districts to begin with, but now this is getting expanded to the whole country. Line lists of vulnerable populations were laid. They were offered X-ray, handheld X-ray at where they were, in their households or in camps. Shivers were there. And to tell you the outcome of this, we were able to screen 12 crore vulnerable population, some with symptom screening, but some with X-rays. So this was the initial strength, where we are going to go stronger as time goes by. And let me also tell you, the naysayers were quite critical about the strategy, but we were able to find 2.85 lakh asymptomatic vulnerables were notified as TB disease. They were put on treatment, and the follow-up, of course, we'll come back to you with. But this is the first time any asymptomatic subclinical TB were screened, found, confirmed as TB, and treated. And of course, there are a few other firsts, things we can boast of, which are not there globally. The Nikshay portal, for example, is a digital portal that records all patient data digitally, so a peripheral level worker with a smartphone can actually enter patient details. And we, sitting at the Central TB Division, can actually monitor that. We can also monitor our drug supply chains using the Nikshay Aushadhi. We have actual counts of which state, which district has how many, drug courses available. So we can dispatch more. That is how we usually work. Every day morning, we look at the drug stocks available in the Darbhanga district of Bihar, whether they have adequate or we need to, push more. Within the state, it's up to the state to send across to the districts or PHI. In our Nikshay Aushadhi portal, the dispenser at the PHI level actually enters how many he has dispensed, and we can monitor it from here. So that is the kind of system. A lot of effort has gone into make, years of efforts. And with this strategy, the way we are going, with the new strategy especially, we have reduced the gap of the missing millions to about 1.2 lakh. And this year, we hope we'll be able to actually cross the estimates. We'll be able to report more than the 27.4 lakh that the estimates show us. With the concerted efforts of the program, my team at the Central TB Division, my team at the peripheries, states, the state TB officer and their teams, we have a wonderful network of consultants all across, our DTOs, our CHOs, our ASHA workers, and our champions. So we have patients who recover from TB who come and join us to follow up our patients, to handhold them, to adopt them. So that is where Nikshay Mitra initiative also, in addition to food baskets for the family and the patient, they adopt them for psychosocial support. So this is just a glimpse of what we're doing in the program, and if there are questions, I can take them. So thank you for the patient listening, and thank you, Stop TB, for kindly hosting me.
Thank you very much. I think there will be a lot of questions, and also I'm sure there'll be an opportunity for us to ask questions. Maybe just to give everybody a bit of the structure, we have 2 more keynotes, and then we are going to bring in a panel where we will have an opportunity to interact. Is that okay? Okay. How many of you work on TB? That's your day job? Okay. I'm sure Luchika is going to say that is not enough, right? You need to do a lot more. But that is Luchika. I think, Luchika, you've been very passionate about pushing the TB agenda. Professor Urvashi, it was fascinating to hear what is being done and the progress that has been made. I mean, it's like you've thought through every aspect of the prevention, detection, treatment, and support. Yeah, so There's so much, even just listening to you, it's fascinating. Luchika, maybe the question to you is, there's so much that depth of programming that is happening in India. I would love to hear from you. Do you see the cup as half full or half empty globally, not just? And then where do you see the need for us to push more? What needs to be innovated both in terms of technology, community response, everything that Professor Urvashi spoke about? And then I'll also come back to you on some of the other challenges that you're seeing from a global picture. You might want to come here, or if, yeah.
I can give me the mic maybe. So just very briefly, good afternoon, good morning. It's always so nice to be back in Delhi and with so many amazing and Professor Doctor here. We should call you all Professor Doctor, and we should all listen to you for all the things that you are leading here. And I want all of us to give a big round of applause, not only for what is happening, but she's the only woman leading the TB program in India, so we need to recognize that. And I'm so impressed. I didn't know, I have to be honest, that it's the first one leading so forcefully a program. Now, thank you all for being with us today, and thank you, Pradeep, for doing this. I want to also thank very much our colleagues from the Asian Development Bank. And I'm saying that because in these moments in which there are a lot of challenges, right, that are being around there, Asian Development Bank is emerging as a leader in maintaining important values and pushing them forward. Health, investing in climate and health, looking at One Health and the AMR are important things that are not usually, you feel a wind of pushing them out of the agenda. So now, what I want to say here is, in terms of, is the glass half full or half empty, as Pradeep was saying. I want all of us to be extremely, extremely convinced that the glass is half full, or even more than half full. And not just because we should be optimists, and always the good prevails, but actually it is a good moment, and I will tell you why it is a good moment. On one hand, I know that the fact that a lot of the funding coming from US is, disrupted, stopped, and terminated. But rather than get into a disaster feeling, this should be a good momentum for all of us to address change and do the things in a better way. It's the time in which countries and the Big South, with all the challenges that will be, to take the leadership, to own their problem, to own their response much more, and it will not be easy, and it will be difficult, and it will be a hell, but it's the way to go. And I'm saying that because not in all the world the answer is the same. And I'm saying that because here in India, actually, the leadership was doing that for a long time. And India was between the very few countries, very high burden, probably the only one at that time, of TB as other diseases, but also the one that actually went ahead and big problem, big push, okay? And it actually led, when we had this push by the Prime Minister Modi and the entire team, and continuously by the leadership of the Ministry of Health, things are changing, right? And things are changing in terms of innovations and pushing agenda and trying to find ways to achieve what was promised. And was an example not only in the country, but also for the region and for the world. And we, from Stop TB, because we worked so close not only with our colleagues from India, but with all the other countries, we know how much they were looking at what's happening in India. And it's not lip service, it's a reality. And that's why what's happening here, and the amount of innovations that are coming, and I know that we will have here our colleagues from India Health Fund, we will have MolBio and others. Being in the country, maybe you don't see it, but this is creating a big push outside as well, and it's a good opportunity for the private sector from India as well to go global. I know they have big market here, but I think going global, it matters as well. So it's half full because of that. because of the fact that this turbulence now should not make us worried, should make us invest in the right things in a different way. When I also say in the right things, we also need to ensure that we will never, all of us, including global institutions, we will never allow to be over-dependent on one donor only, and also on what we invest. Because we like it or not, the reality is that in many countries, the investments that came were not strengthening the country. We're creating a parallel system, very nice, very cute, whatever, but not the country system. So we have now, in a lot of parts of the world, we see very dramatic situation on procurement and supply, for example, because what was done was not strengthening the country's procurement and supply chains, but parallel ones for different diseases. And now that the money are not there, complete paralysis, complete paralysis. It's completely difficult to understand how in a country the drugs cannot be distributed to reach the people. I'm not saying schmoozing access, leave that aside, that's even another level. But even for the people that are already accessible, the drugs and diagnostics are rotting in some warehouses because the distribution, the trucks and the system was driven by some people paid salaries with American money. Drama. Half countries paralyzed, no diagnosis happening because the transportation of samples, TB or others, were done with a transportation system constructed with outside money. Zero, so that stopped. The sputum transportation system stopped. And nothing happens. What? Yeah. So very difficult time in a short time, but on a long run, I think it's possible to change a lot, and it will not be easy. And the thing that we have to look in a different way, and I'll stop here, is integrating much more and looking at things across. I know we speak about integration forever, for some of us, for the entire life. We also speak about health systems for our entire life, strengthening and constructed resilient health systems. Didn't we say that? Nada, forget about it, zero. So not zero, no, let's be honest. Close to zero, very little. So integration, what it means that, as I was saying in the other session, we should not have anymore, for example, looking at investing big money into diagnosis just for TB. And I know that we have our colleagues here from Molbio, I see our colleagues from CureAI as well here. Their tools, and I know it's happening, but I'm not using you just because you are here, should be used for other diseases as well. So you catch my friend Aman here, representing youth and a vulnerable community, you catch him because he's coughing a bit, you test him for everything possible that the machine can do. And you do an X-ray. And maybe you don't find that he has TB or an infectious disease, but he's smoking like crazy and his lungs are affected and something. So integrating diagnosis, it will be probably easier in the beginning because I think we have many multiplexing diagnoses and in TB as well. Integrating into approaches as well and using the fact that to reach different groups will be difficult, so the moment they have secured access for malaria, let's say, let's do TB as well, or if they are for HIV or for other things as well. But there is, when you speak about integration, is a big array as well on the treatment, and there is a huge area that if I start, I will never stop, which is the data and the use of data, and how we can use that in a much smarter way. But that's why I urge the, 60, 70 people that we are here in this room, there is no such a thing as a glass a glass that is empty. The glass is full if we are smart. And India is very smart. Colleagues from other parts of the world are smart as well, but more than that, smart is this. You know, we don't learn from successes that easy. We learn from pain. We have that say in my country. When you have a problem, when something hits you very bad, you learn much more than if everything goes well, you are done, da-da-da. We are faced with some challenging time. We need not only to learn, but to come together in a different way. There will be drama. There will be losses, there will be challenges, there will be things that will not happen. But we have to get out of this, not giving up our ambition and our targets, but by doing things in a much different way. So thank you. When I speak next, I speak about communities.
Okay. Thank you. Thanks, Luchika. You spoke about the times of pain. I think if you look at global health, this is probably one of the most painful times. How many have you been affected by the US fund cuts? The fund cuts, freezing, whatever we want to call it, by the US government. Okay. Okay, so several. Okay. Let me come back to this. I want you to hold this thought for a moment. But also, we need to start thinking about what Luchika said. Some of the most painful times are also the times when you innovate the most, right? Okay. Now, one of the persons who I know who's been really at the cutting edge of innovating financing and looking at really sustainable financing is Eduardo Panzan, who's the Director of Health at ADB. Dodo, I'm going to ask you to share about where do you see this whole, how do you make use of this pain to get ahead? And the work that you're doing at ADB, you've been here as really helping us to rethink financing. So,
sorry. No. Okay. I thought I was just listening. No? Okay. No, probably my best analogy of the TB program is that you are facing a crisis that you have finished your school. You know, you're not a little baby. That's why I avoided the UNICEF session, right? That's all about children. You're not, the TB program are not little kids. It's a very mature program. Lots of lessons, lots of resources, lots of innovations, right? And probably because you've always been, this is my best analogy, and I will not talk about any country. You're like my son, who I still give money to. Right? He's 24-year-old, so he's not here. Okay, you know, so he studied in the US, went home. So he's now chilling it in Manila because I keep on giving him money. Made him dependent on my credit card, you know. So sometimes I get a message, you know, your supplementary card was used for this and that. And I will call him, did you use this? Or shall I now cancel it because it's a scam or something? And I said, no, it's mine, it's mine. I said, $500? What did you do with that, you know? So in a sense, what's the incentive for him to change, right? He's a physics major, right? So what's the incentive for him to work when he can actually have, he's a well-loving Filipino father who will let him use the car with a driver and all, not pay for electricity, right? Charge eating steak in his credit card. That's my analogy, right? So maybe I just decided to cut the card. Probably I just called the bank. I think I will after this talk. I will tell them, please cancel the supplementary card.
Blame it on Luchika.
Blame it on Luchika. And tell them to start working. Will I be afraid? No, he has a physics degree, right? He studied in the US. He can find a job, right? There will always be a safety net because the government of India will always give a budget no matter what, right? So this is where the TB program is. This is not a 3-year-old child who is left on his own. And so I think what has happened globally, I always tell that it's not that I'm criticizing our friends, but in a sense, it's, you know, the program basically got spoiled by itself. And I think what's happened was something that would have happened anyhow. It's just a question of when. It's just a question of how fast it was. It was about to happen. I was actually pushing for it to happen before this happened, because my favorite line when I talk with, sorry, anybody from Global Fund here? No, so we're not on record, right? You are, okay. I will deny everything, okay? I'm just, I was just asked to talk there. I always have this line that, do you actually expect developed countries to develop a parallel system for the TB program? No. When you go to Europe, when you go to Japan, to Korea, their TB program is part of their usual primary care. They procure medicines as part of the way they procure medicines. It's integrated in their systems. So why do you want to have a parallel system? And they started to defend it, and they have a very nice defense. Unless we do this vertical program, then things will not happen. I keep on saying that, you know, after all these years, do you not trust these countries that you're helping, that they can deliver? by insisting on having separate vertical programs, you're essentially sending a message. We don't really, sorry, I want to use a curse word, trust you guys to procure it properly. We don't trust that your information system can capture the data. That's why we have to have a service. So that's why whenever I was in a meeting, they never liked me. Because I always say, no, I don't want to work with you guys. And frankly, those who know, I was considered an anti-TB, not because because I don't like these global funds, Gavi. And so, if this did not happen, me cutting the credit card of my son, I would have found a way to kick him out, kick them out of the house. It's happening too fast, admittedly. It's happening in a pace that we should have been prepared. But I always love to say we can never be prepared for anything, right? When the pandemic happened, it's not as if we told the pandemic, "Can you chill it for a while? I'm just gonna buy some PCR machines," right? My favorite analogy in pandemic is that I could never imagine a world where basically face mask was not being exported. Export controls for face masks. That happened for a while, right? Because it was so fast that countries were doing a lot of stupid things, right? But in a sense, it has happened. That's happened. So rather than mope, let's try to see what we have. We have portable X-rays. Oh my God, We have new medications that's good for 3 months. Why can't we make it the norm, right? We use digital tools now, so nobody here will tell me that they don't use digital tools, right? We use TikTok to communicate, right? So there's so many that's there now. And really what you just need to do is to stop thinking about the past and just let's start planning. Now we start saying, where will the money come from and all that, right? Why? When the pandemic happened, did we worry where the money came from, right? I always believe if you have a great story to tell, if you have a great plan to tell, money will come. Right? One of the words I hate also when people talk about health is words like fiscal space. What fiscal space are you talking about? Right? Why do you make a plan immediately thinking that you don't have money? Which unfortunately is how a lot of people think. You always plan based on constraints. Make the plan, then let's worry about the money, because money will come. TB is something that has probably 99% support from the public for eradicate. I could not imagine that there will be resistance from the public for our country to invest in TB, right? Too many of us have friends who was not able to travel because they have a spot in the lung, right? Too many of us know somebody who died of TB. So this is one of those things that is so, probably to make it more scientific, because there are researchers here, 97.63%. I'm just kidding. I always have fun with numbers. If you put a percentage, it becomes more scientific. Okay, this is 5 p.m. So in a sense, I think, and that's why within ADB, we think that we always believe in ADB, that country systems is the way to go, right? When we provide, the way we describe ourselves is that we are a bank for Asian countries, and we are here to help countries scale up what they believe in. You don't hear us coming into a country and impose and tell them, please do this or that. That's not how we do our job. We always ask the country what they want to do, and then if they need financing, we're a bank, so we'll give loans, then we will help you scale it up, roll it up. That's what we do. Although countries are not yet in the process of asking us for that financing, we believe that this will naturally come. If they don't want to borrow from us, it's okay as well. If the countries can mobilize their own money, it's okay as well. I probably would end by saying that since this whole, I just keep on saying, I think really, I actually got a message that my son bought something, so I'm reacting. We've been talking to some of the biggest countries in Asia where the biggest burden are. And I have to admit, I'm a newcomer in TB, right? I'm a health financing guy. TB, as I said, I'm just so happy that Indonesia has a TB elimination plan, right? India has a TB elimination plan. My home country, Philippines, talks about a TB elimination plan, right? Pakistan has, sorry, my apologies, has a TB elimination plan. I'm just saying this because the 4 countries with the highest burden in Asia, well, the 5th one, Bangladesh, also has a TB elimination plan. That means it's already there. You know, ambitious plan, right? It's a desire politically. So, again, I ask, why, you know, so I don't want to ask a question sometimes because I might end up criticizing people. But nonetheless, the point is, you are a 24-year-old college graduate, right? Capable of working, very skilled, very learned, right? Living in a world where there's actually jobs available in a country with 7% economic growth. So if you will mope in your house and play Fortnite because your father stopped giving you money, I don't know. Maybe it's time for you to start opening up a new business, and let's call it TB Eliminated and Destroyed. A nice video game, right? Let's be ambitious. We can beat TB.
I would be surprised if you don't.
No, you know, no, because first of all, the analogy that you did was amazing. Second, to thank you because you are an outsider of TB, so for all of us that were in the trenches for so long, your perspective is so important. But also to give us the hope that we need. I came from Washington where we brought the ministers of Philippines, Indonesia, and Nigeria of health. We took them to DC to really discuss health financing. And we all agreed to start with TB. And we all agreed, and they said, not me, that the investments that come from outside should be on what they want. And I added, should be things that if are stopped, should not paralyze you, but leave things behind. So every time there is somebody coming to offer something, the thing in the back should be, is this what I need for my country? And everybody agreed, and that's why we hope to bring them in Manila together in our board and this to have a joint push for the entire world in this kind of thinking, because we have some champions here, of course, with India on top, because you drag all the region after you in pushing this kind of agenda. So I just wanted to say that. Thank you so much.
Thank you very much. How many of you remember when you were 24? Yes. Okay. It's fascinating what you said, because at 24 is when you start taking risks and doing things which you would normally, I mean, at 50, I would really struggle to do, right? So you said the TB response, you're 24-year-old, and the beauty of the TB response has been the kinds of innovations that many of you in this room have been driving, okay? So I'm going to put some of the people who have been driving the innovations on the spot. How many of you think, how many of you work on innovations in TB? Okay, that's a larger number than I thought. So let me do one thing. Let's continue the conversation, looking at if you're a 24-year-old, and Dodo, I certainly hope your son doesn't think that the change happened because of Luchika's advice that pain is good. If it is, yeah. So we will have that conversation separately. But can I do one thing? Let me invite. Let me start with the panel. I'm going to bring some of the panelists now, and then I want to listen to the panel. I want to make it interactive in terms of questions. Let me start with Dr. Rijal. Dr. Rijal is the Director of Communicable Diseases at WHO CRO. And I know Vineet is also here, who has been driving a lot of the TB program. Madhav Joshi is with the India Health Fund, looking at financing. And again, the India Health Fund has been one of the pioneers in investing in innovations. Kai Yoshida-san, if I may invite you. You spoke, Dodo, about handheld X-rays, so I would love to hear more about that. So please join us, Yoshida-san. There was mention of Cure AI. So Shibu, if I can invite you to join us. Um, Malbeo, Sriram, you got a lot of mention from everyone, so I guess you're one of the Indian heroes, so please come. And then Dinesh, you've been, please, if I may invite you to join us here. Okay, so I'll keep you there. I'll bring you back in. Dr. Sahu, if I may invite you. Dr. Sahu is the Deputy Executive Director of Stop TB Program. Okay, now let me start with this one question. Again, we are 24 now, right? So we have quite a lot of success. We now need to do a lot more because when you're 24, you're starting your first job maybe. The kind of money that you're making is very different from what you're used to from a rich parent. So we need to really squeeze a lot more out of what is available. Okay, so let me start with Dr. Rijal. Dr. Rijal, this region has one of the highest burdens, and it is also where we are seeing so many innovations emerging. I would love to hear from you. What is your perspective on the region? What is working? Where do you see gaps? And what do you believe needs to be done to, if you were to ask all these innovators here, where are the gaps? What would you like to see?
Thank you very much. As you have mentioned, Southeast Asia region gets always the prominence when we start discussing TB because of the disproportionate burden with around quarter of the population. We have about 50% of the deaths and about 45% of the new cases. That's from the 2023 figures. So if we are to make a difference to achieve the NTB targets, Southeast Asia has to play a dominant role. That's first thing, we all realize that. Now, some of the things which I must say from a WHO perspective is we have been trying to engage with the countries to prioritize TB. As you know, in the last decade, CRO had kept TB as one of the flagship areas. And one of the things which we thought was very important was to continue to keep the TB agenda in the countries because there's so many compelling problems and if we don't do it. So just to give you an example, the countries have shown great political commitment, and this has been reflected by several high-level meetings which was organized in this region. In fact, 3 of them have been hosted along with the government of India, and one virtual meeting was hosted along with India. We had Indonesia and Nepal. So at least 2 of the high-burden countries have been showing a lot of high political commitment. Now, the last meeting just before the UN high-level meeting in 2023, the countries, ministers of these countries, they signed the Gandhinagar Declaration, and a month later, we had this UN high-level commitments, which we are all aware of. Now, I would just like to highlight that countries have been trying to move forward, and we have heard from Professor Urvashi how India has really galvanized the momentum. And one of the things which we have been doing in CRO is trying to get the other countries to also learn from the good practices. So this is one of the things which I think is critically important because every country would have the specific approaches, but there's a lot of learning and cross-learning that can be achieved. So I would just like to highlight to you with some of the areas, not necessarily only looking at diagnosis or treatment or even prevention. So Bangladesh in 2024 hosted a global multi-sectoral accountability framework. So I think this is one of the key platforms which would be extremely important if you want to have a holistic approach to ending TB. And because we need the stakeholders, but we not only need them, but we need them to be accountable for what they are going to perform and do. So this is one thing. Now, India, as mentioned, they also adopted a patient approach, the Pradhan Mantri TB Mukt Bharat Abhiyan, and also that was used for the nutritional support. Now, Indonesia, we have been hearing in the last several years, there has been a lot of developments. So it started off, I would say, with the presidential decree on TB aims to implement a comprehensive strategy to ending TB. And last year, during the TB Union meeting, we heard about the commitment the country has made to reduce the incidence by 50% in the next 5 years. And that has been matched with the resources that was be made available to the programs. Now, Maldives is another country in CRO. It has a very low incidence of TB, but their aim, and I think that's one of the things which could be illustrative, is to try to demonstrate how countries can reach the NTB targets. So they are looking at having TB-free atolls, which would eventually lead them to be a TB eliminated country in our region. Now, Myanmar is also another high burden country in the region to achieve, and it was the only country to achieve the 2020 milestones for decline in the incidence before the COVID pandemic disrupted. However, we have seen that the current geopolitical situation has had a huge impact. So if you are looking at TB, we also need to understand the geopolitical situations, the challenges that can be come up with that, including the access to treatments in spite of having the drugs within the country. So these are things which we need to look at, and this cannot be solved by one partner, and we need to engage with the local stakeholders who have a better insight as to how in these challenging times drugs can be made available to those people. Now, Nepal has taken a unique opportunity. You see, Nepal has had a political transformation in the last decade, and they have divided the countries into approximately 700 palikas, or it is called municipalities. So they are looking at it from a TB-free palika approach. So here again, the ownership lies at the very much at the lowest level of the administrative unit. And Thailand has made significant efforts for coverage TB through the UHC, which Thailand has been able to do. So this was just to illustrate with some examples. And the last one I would like to tell you is about Timor-Leste, which initiated a partners pledge to end TB, and this was led by the Prime Minister of the country. So I think we have seen in other disease areas, and in fact today was a great opportunity to learn from other diseases. What we have seen is when you have a high-level political commitment, it galvanizes all the forces together to be able to take this forward. So I think one of the key areas which all of us should work and collaborate is how we can continue this momentum. And I would like to really appreciate the insightful thoughts from Dodo and also Luchika's very motivation speech, which is really something which we all need to talk more about. Thank you so much.
Thank you very much. That's a brilliant overview of where the political commitment is, where the lay of the land is. For those of you working on TB in this room, okay, where do you see the biggest gap? What is the biggest gap at this point? Are there any gaps? You mentioned the political galvanization. That's fantastic. It is happening. Anything that you... Community engagement.
I think access is a gap. The rights is a gap. It's missing.
Access, rights.
We are not finding all TB. We are not treating all of them. We are not preventing all of them. The approach which India has made, it's a foundational shift, and thanks a lot to Dr. Urvashi. All the high burden countries need to follow that. We need to find, screen all. We have the technological tools made in the global south, deploy them, treat all of them, prevent TB. And it's not just TBT. Treatment is also prevention.
Fantastic. Thank you. Treatment adherence. Mental health integration.
Post-TB needs to become a part of the conversation.
Post-TB. Okay, that needs to, it's not the end, but it's continuous. Asymptomatic TB.
Other social determinants like malnutrition.
Malnutrition, other social determinants. Social stigmas.
Meaningful political engagement.
Which is also what Dr. Rijal mentioned in terms of that political engagement and leadership. Drug resistance. Larger themes of AMR. Vaccine didn't come up. I'm quite surprised. Okay? Okay. It's great to hear where we are. Now, what I want to do is to move to where we are in terms of the innovations that are already there. My question is, how many of the innovations are being done on scale? Have we scaled innovations? Dr. Sahu, I'm going to ask you this question. How do we, and I'm going to come to the innovators because that's a story that I want to hear. How do we scale innovations?
Thank you, Pradeep. I think that's a very important question. Given the political commitment that we see in many of the countries in this region, and also given the capacity of the countries, I think it should be possible. Now, where is the problem? I think it is the mindset that people often have of thinking small, doing pilots, doing small things, and worried about taking the risk and going to scale. I think that's a big shift in the mindset that should happen. That's number one. Number two, scale will need financing. So some of the new tools and innovations that are happening in TB actually is bringing down the cost, and we should see more of this happen for molecular testing, for X-ray with AI. But still, financing is required. And I think speakers in Ruchika quite well highlighted, the dependence on donor and the example of the 24-year-old son of Dr. Dodo. So I think we have to look at innovative ways of how can we get the financing to scale these technologies up. Let me take an example. One of the biggest gap, if you look at the prevention and the care for TB, is the diagnostic gap. We are not able to diagnose people. Globally, about 2 million plus people not diagnosed and treated. And those who are diagnosed are probably diagnosed too late after the transmission has happened, right? There are other things we can do for prevention, but if you look at this gap, Dr. Urvashi very nicely highlighted how they did symptom-independent screening. Not easy, huh? If people come with symptoms to you, it is a different thing, but symptom-independent in the community, not easy. If you have to do that, you will need financing. India, there is a great commitment to provide the financing from the national level. I think states and districts, they are also contributing. But think of this, in any country which is growing, a growing economy in this region, there is a formal sector employing people, right? A large proportion of economically productive age group people are under employment and their families. Can we do something which is not just dependent on the national TB program, but can there be employer-initiated screening every year? Not just for TB, we also spoke about integration. Can this be X-ray, which is done on an annual basis, all employees in the country? It's a policy intervention, right? Finances will come, either private sector employers or public sector. Then there is an unorganized sector. That we need to think about how do we get the financing from the government domestic budget, from development banks, and other donors and other things that should be in place in countries, including subnational level. So I think this area of financing has to be rethought and relooked at. It should not become a barrier. A budget in the national TB program, not enough for X-rays, molecular tests, should not be a bottleneck for achieving scale. I think this requires a different kind of thinking. And then the last one I would also say is we have to think about how do we do it in a way that it is not just a TB intervention, but it is seen as an early diagnosis, something to diagnose disease early, not just TB. For example, in Indonesia, they have now, the minister announced on your birthday, the citizens are advised that you can go to the Puskesmas or whatever health facilities and get yourself screened for 6 major diseases there. So that kind of a combination strategy of keeping people healthy. So the TB programs have always been looking at how do we diagnose sick people. But this is the reverse of that. How do you keep the population healthy? And by doing that, you will prevent a lot of transmission of TB, the activities that will go on for this. So I would suggest we think about a different mindset to take these tools to scale, because today we have great tools. We have X-ray, which can be done in the community, never thought of in the past. When we started this work from Stop TB Partnership in the TB Reach project, people said, this is science fiction, this will not happen. 10 years ago, I'm talking about 10 years ago. This is happening today. Now, how do we take it to scale? You will require a huge number of X-ray machines. You will require deployment at an unprecedented level, right? Molecular platforms are there today, battery operated, and they're becoming even smaller. How can we scale it up? Can we go for swab testing, which is coming next? So if you go for a symptom-independent testing, maybe you don't have sputum. But today we have technology very close to getting approved swab-based. So we do a self-swab. So these kind of technologies were not there in the past, but now they are. So we have to think about how these technologies don't just remain in the meeting rooms here and in nice projects, but actually reach people who need them the most. I will not go into the other parts because of lack of time, but treatment also, if you look at it, 18 months of drug-resistant TB treatment is now down to 6 months. 4 drugs or 5 drugs. 3 to 4 drugs also is possible. So thank you, Pradeep. Yeah.
Thank you. Thanks. Thank you, Dr. Sahu. I think the one area that you started with, even just 10 years ago, a lot of what we are talking about was a pipe dream, right? Nobody thought that we could do it. X-ray, handheld X-ray is a classic example. Yoshida-san, maybe let me ask you this question. You have a handheld X-ray that Fujifilm makes. What has been your success? What has been your challenge? What's the scale at which you're implementing? And what's the one thing that you think will help you to scale beyond where we are?
So thank you, Pradeep-san. So before, my name is Kai. I'm from the Fujifilm India, and then we have been associated with the TB partnership from 2021. So we are doing the annually. So now we have completed 3 years, and then so far, as a Fujifilm India, we have so many partners, and then we have reached around 4.4 million pan-India in 3 years. And then also we have done the X-ray scan for approximately 80,000 scans. And then we have discovered around 1,000 people as TB patients. So that's we have been working so far. And then just want to ask you how many of you, the people, have been to the local site, I mean the village camps? Yes, okay, thank you. So if you go one time, you will be realized those people, the people in the village, they are not really have the knowledge about what the TB is. And then when I went to that site, one village people asked me, why do you come? Why did you come? What is the TB? So everything starts from that. So that's very challenging part, especially in India. There are so many religions, so many people, so many different languages, so many barriers. And then every time they don't speak English, they don't understand English. So, how do you say? It's very challenging, to be honest, to communicate with them. And so that's one of the biggest challenge. And then also, one person I met in the Gujarat, and then somehow Gujarat, I thought this is the non-alcohol state. So one person came with a drunk. Those things actually happens. So every time we are facing so many challenges in the field. So, but after finishing those 3 years, we are very happy. I mean, how do you say? We feel very contributed, and then I see those people who survived from the TB. I see some people went to the hospital after screening, and then they got the recovered. And they survived. And then one person talked to me, and they, thank you, Fujifilm. Thanks to your support, to all the way to this village, I was able to survive. And then when I see that person's face, I was very happy, to be honest. So, and then, how do you say? So, back to the topic: how to escalate, how to boom for the increase the screening, and then towards the TB challenge, TB project is from the company point of view, as a private company point of view, we should have something that private company have the CSR activity for the TB project, such as for the company who has the, how to say, factory in the mountain areas or heavy industries where all the workers working, and then those people tend to get TBs. So, for example, as a CSR activity, the private sector should invest their money on that activity, and then from the government or from the government side, they should also offer some incentives. Otherwise, company sectors, they are not willing to spend the money.
You're sitting right next to the man who's from the private sector. If I can call you private sector, the India Health Fund. I agree with you in terms of that point, yeah. So here's my question. Maybe one, what you mentioned is the whole need for awareness, community level, and engagement with community, which you already mentioned. So I don't know if this is my fault, so I can't tell anyone else. Is there a gender discrimination when it comes to, not the panel, but when it comes to actual TB care? Yes, there is a huge. Okay, that's the other thing which we need to also think about, right? So let me move to Shibu, if I may. One of the challenges that we usually find is the lack of human resources, and you're solving one of those problems in being able to, okay, you have an X-ray that comes, and you're able to actually help address quick screening. Why and where are you in terms of scale? At this point, I'm really interested in scale. How do we make it not just in one country, but across countries? I also know Deep Tech is also here. Is there anyone else working in the same space? Okay, great. So maybe Shibu, if you can share your experiences.
Yeah, so as we are also talking about the financial terms, and also the cross-sectoral utilization of technologies, I do also want to touch what is the benefit of actually using a stall? Because we have seen that now technology has downsized significantly and become tinier, and the mobility part of it is actually proximal to the community and patient has been seen. Then the skill set is essentially for who is going to interpret this X-ray in the field. That is where the technology comes in. AI comes in and interpret. Government of India has done, Department of Health Research has asked us to get it evaluated in the health technology assessment, because I want to bring in here the dollar savings angle here. The as-is situation is somebody, let's imagine that there is no technology to read it. Someone has to actually download all these images and come to a facility. There'll be a backlog to be read by a radiologist. It will take when we started in Philippines, it was 2 months turnaround time, and which has been reduced to less than a minute. So similarly, at least in India, it will be 2 weeks. So that is where the technology assessment looked at, and it says that if you use an AI-enabled pathway for tuberculosis detection, there's $120 savings. So you think about this is one disease, right? Then you think about this X-ray. So this same X-ray done for tuberculosis in Vietnam, this look for lung nodules for cancers. 300,000 X-rays, they found 300 probable cancers, lung cancers, early detection. And 10 of them were actually early detection, stage 1 cancers. So we are multiplexing these technologies is the way to scale. So where do you get the finances, right? So you unlock, one disease has actually shown, TB has shown that many examples. For example, how do you leverage the technological advancements? And we have seen that it been utilized for one disease. Our technology has been now in COVID has been used by TB technology has been used for multiple COVID detection. Similarly, now we are talking about multiplexing. You start technologies has to be unlocked for multiple disease. Digital is the way for scale because that enables scale. Many countries are moving digital transformation. I'll just give an example of, you mentioned about Indonesia, and now Luchik also mentioned about Indonesia is now in a digital transformation plan. They have a plan. How do you enable the utilization of disease, one disease tool for multiple diseases is the way forward? And you bring in the dollar savings angle, like, because I understand Dodo mentioned about like how do you better utilize it. That's the best way to look at, not from a lens of one disease, look from a lens of multiple disease. For example, all our, including Deep Tech and us, we are all working towards a lung health solution, right? Okay, so it's an image interpretation tool which unlocks multiple diseases. It gives a report and unlocks multiple diseases. To name something, few of them is increased cardiovascular, this thing, CV risk, the CVD risk, the silicosis, the pneumonia, COPD. There is n number of opportunities to leverage existing investments for health system strengthening. So you start with that narrative for scale. So for example, like, and again, India is the best example of like, these are all, we have all of this thing. Talking about community engagement, we have TB Arogya Sati, we have One Impact tool globally. Talking about patient adherence tool, we have 99 dots. But at scale, scaling is a bottleneck. Because one of the major reasons for not scaling is that we are not defined how to procure AI and digital tools. That's many countries we are facing a challenge. So fortunately, we are all supported by Global Fund or donor-supported grant is happening in many countries. Now countries are thinking in the line of that. So that has to happen rapidly. Because defining how AI, because anything on software procurement in a public system is a critical challenge. It's not defined. They always ask for hardware along with that because they need to enter that into the stock register, get it audited. So I think countries need to work on that because otherwise this will not scale up rapidly. Rapid scale up is something which will define rapid elimination. So otherwise this won't work. Thank you.
Great. Thank you very much. I think procurement is a problem that needs to be solved, and that's probably something that also from a X-ray perspective or the work that you're doing that has. I also know that data is another issue. I know Dure is here. There are others. How many of you work on data in this room? Okay, Sonal, you do. Okay, great. Let me come back to you, and maybe let me go to Sriram. Sriram, in terms of, you're probably one of the you've been able to really start looking at scale. I know, Professor Urvashi, you mentioned about where we are able to look at the molecular screening that's available. What has helped you to grow in terms of this and the multiplexing which you're talking about? You've also been, I know, Luchika, you also spoke about this. What is your experience? Where are you going? What do you need to be able to get beyond where you are?
Yeah, primarily the objective when we started was to ensure that we'll create a technology which can actually, is that for me? We create a So create a technology which can actually go down to the grassroots, right? Because at the time when we were working on this technology, most of the molecular testing was centralized and very, very heavily centralized. So it never became a clinically relevant tool at all because the turnaround time to results used to be anywhere from 3 days to 1 week. And no doctor, physician would wait that long to start treating a patient. So it just became an irrelevant tool. And that's where we thought we could play a role by trying to work on decentralizing this and taking it down to absolutely to a community level, primary level kind of, that was the objective. So it was completely a grassroots up kind of a innovation, and we had to see the real problems at the ground to build the product. It took us about almost 14 years to completely come with a final solution. So it's a long, grinding story. It requires a lot of grit and a lot of conviction, and of course also money. So we had to really beg, borrow. The only thing we didn't do was steal. But we did everything we could to, because we knew the end was going to be very important and impactful, and that's how it happened. So scaling up is not that easy. Of course, we got a lot of support from the Indian government. Dr. Urvashi Singh has been a strong supporter from very, very early on times when she helped us with all the validations. ICMR came forward and did a very, very large study for us, completely paid by the government of India. Even the global validations are funded by the Gates Foundation. So this kind of support, I can, absolutely, very, very, very crucial. If these were not there, probably we would not be where we are today. So all these was very useful, and going forward, so that helped us to scale up. When we developed the platform, it was a multi-disease platform, but we started focusing on TB because that's where we saw an immediate need, and because every country was wanting to go into a TB elimination, so TB became the priority. But when COVID came, clearly the same platform could do COVID testing. So in India, for example, just before COVID, we had supplied about 1,500 machines to the TB program, and then we had a test for COVID, and ICMR came back and said, please move all the TB machines to COVID centers now. It's going to be COVID tests. So talking about pandemic preparedness, something like this really makes a big impact. So that's what we are trying to do. So we are now building it as a multi-disease platform. And today we have about 26 different pathogens you can detect on the same machine. So once they are put in the primary level or any other deployment, same machines can be used for multiple testing, and also makes it a pandemic preparedness kind of a tool that once we have the machines, you just have to make a new test and then everything is ready. So that's the kind of way we're looking at this whole thing. And as a company, we are committed to health for all and trying to make sure everybody has access. And that's our full-time commitment, that we keep developing technologies and looking at how we can keep making our platforms more and more user-friendly, deployable, and also affordable. So that's where we're going.
Fabulous. Thank you. And again, your own personal commitment and the risk that you have taken, I think that's something that we want to applaud you for. I know, Madhav, I'm going to come to you. There's a lot that we can do in terms of, we speak, I mean, the whole world talks about, especially with the financial crisis, we all talk about innovative financing. But the one thing which we need to be really talking about is financing innovation. Yeah? And you have been, as the India Health Fund, you've been starting to do that. How can we really start looking at new models of financing, and how can we really start investing behind, I mean, you had a 14-year journey. I know yours has been similar. I know Fujifilm, the investment in handheld X-ray, that would have been a very tough decision to make because it's a long road. And for all of us who are in innovation, it's not easy. We need these kind of resources. And how do we really invest in research and development of innovation? So I'm going to turn to you. One is the public-private partnership, new models of financing, and financing innovation. How can we learn from you?
Okay, no, thank you. So this is a story of waves. And it started back in 2017 when the SDGs were announced, and India announced much more ambitious goals for the elimination of TB in particular and infectious diseases. Now, Tata Trust needs no introduction in this room, but Tata Trust had a long history of supporting programs for infectious diseases, including TB. And the view that the Trust took was relying only on programs would not allow us to reach the elimination goals within the time frame that had been set. Now, science and technology-based innovation was identified as a disruptor, which could improve the ability of programs to get the discontinuity they needed. But the related hypothesis that the Trust had was that market failure had prevented the financing that was needed for the development of meaningful innovation. The science existed, but the funding was not there because there was just insufficient return for developers. And the gentlemen in this, on this panel are exceptions to that rule, to make the investments for the returns they expected, which was very different from what was happening with non-communicable diseases. And that's when Tata Trust took the call to set up India Health Fund as a catalytic fund. And it was meant to be catalytic in a few different ways. One, to be catalytic in scaling meaningful innovation, exactly what has been discussed in this room. The second area of catalysis was to catalyze partnerships and collaborations to support the scale, increase the pool of financing, and develop new funding mechanisms. And as the late Mr. Tata's philosophy was, it was really India for the world. So you leverage Indian science, innovation, and entrepreneurship to develop solutions that were relevant for all low and middle income countries, particularly resource poor settings. But there was a twist at the tail. When we started, there was actually nothing to scale because the pipeline was very thin. And as Sriram has said, there was a long journey to development. So we actually worked very closely with the program, the TB program, to identify need gaps where solutions were needed but not available. And the first wave was really to support the biggest priorities that the program had in terms of decentralizing molecular diagnostics and improving early stage screening. We provided grant funding to support developers, but we had an incredible partner in crime in the government of India. And I think full credit to the program for being very open to new solutions. Full credit to ICMR for also bringing in the funding that was needed for validation, which was of solutions which were being developed or de-risked with the funding that we were providing. And the program, I think we've heard Dr. Urvashi Singh and Dr. Sachdeva before that speak about the accelerated pace of adoption. So that was the first wave. The second wave was to address other need gaps, particularly the need for non-sputum-based solutions, minimally and non-invasive screening tools, and supply chain optimization. So that's where we put our energies and efforts into first developing a pipeline, funding the development. And this is where, from being the only funder, we started finding a few allies and partners. And full credit to the Stop TB Partnership for being one of our biggest allies, particularly through the TB Reach program, because they were then more than willing to take whatever was coming through our pipe and putting it into quick validation, not just in India, but around the world, to get the evidence that was needed for then the likes of ICMR and governments in other parts of the world to have the confidence that these were scalable. But this was still only grant funding. The third wave is what we are in right now. And again, I think credit to the TB program for being extremely evidence-based. We have identified challenges that are still not fully addressed in collaboration with the program and ICMR. We've got a call RFP that's open right now, which is really for unmet needs and emerging challenges in TB. Again, addressing some of the issues that Dr. Singh mentioned earlier, asymptomatic TB, subclinical TB, how do we have more effective, faster, lower cost, and more efficient tools that the program can use? So far, all of this funding has been done only by Tata Trusts. For the first time, for this RFP, we were able to get other domestic funders. And for every rupee that we committed, these domestic funders have committed 4. So we're hoping to not be the 24-year-old who has to keep going back to dad for more money. But this is the first time it's happened in the last 7 years. It's been a very lonely journey. And we really thank, I think, the partners in this room who have helped us. But it's not only grant funding now. And that's where I think I'm coming to your question on innovative financing. There is grant funding that's needed. But we're also now able to get concessional debt. And shout out to ADB for now setting up the Excited initiative, which is opening up larger pots of concessional debt for neglected and infectious diseases. So potentially the sources of funding are increasing, not just using grants, but using other innovative financing mechanisms. And with your permission, Indian industry is now playing a very active role in enabling the early stage startups to overcome the challenges that they have faced, and they're now paying it forward to make sure that high potential solutions get not just the financial support that they need for long-term scale, but also the technical, regulatory, and manufacturing support that they need so that they don't get constrained by many of the challenges that they have faced. So that's how we're trying to build an ecosystem, and definitely not be a 24-year-old looking to dad's supplementary credit card, but really building that collaboration. But I have to say, it's not been easy. There's a long way to go, and this can only be done with, I think, not just mission alignment, but mission intent.
Thank you very much. I think, unfortunately now, Dodo, your son is going to be really looking at a whole panel advising about credit cards. But the one who you spoke about excited, and Dinesh, I'm going to put you on the spot. I think there's so much that we have learned this evening in terms of the innovation, scaling, looking at financing, looking at the regional political leadership. Where do you see, Dinesh, in terms of pulling all this together? How do we move forward? And assuming that the credit card, the supplemental credit card is taken away.
I think when my boss says that he's going to take away the credit card of his son, I'm a little worried. The next could fall on the staff also, right? So I think we need to find a solution. So team, you know, when we talk about scale, we do only scale. We do nothing else. We don't do research. We do take innovations which are getting mature and take them to scale. Now I came in the front because I want to look at Dr. Urvashi in her eyes and ask her one question, ma'am. You know, you are one of the finest administrators I have come across. I don't know if you know me. I was Joint Secretary in the Ministry and I was the Deputy CEO of Ayushman Bharat. Ma'am, we promised to the PM 2025 we'll eliminate TB. Can we go back with you, Luchika, look at my eyes and say, can we go back to the table and say, hey, what is our plan to eliminate TB? What do you need? Ma'am, you have today the support of the whole political establishment. If you stand up and tell Dr. Mr. Nadda or the Prime Minister that, look, sir, I need this thing to finish TB and I'll do this in next 3 or 4 years. Because we can't keep on shifting the targets, right? And with your leadership, if this cannot be done, then I'm losing hope here. We have done well, but I'm a little provocative child of Dodo who wants to say that I'm not happy with this because India can do much better. You have one of the best softwares, the digital Nikshay, which I think the whole world needs to see how it has partnered private sector, how it provides nutritional support. There cannot be a better system than this. You have panchayats, you have local self-governments, you can decentralize. You have Ayushman Bharat to leverage this and get your X-rays on second hand, on a second arrangement, on a contracting arrangement, and use this community universal screening. We cannot now allow the naysayers to rule over us and say, hey, there are X-ray emissions are coming, we will not do universal screening. No, we need to do that. We need to do this for a public good. We need to do this to eliminate TB, and if India does it, world does it, because we have the 50% of mortality here. Now, ma'am, we are coming excited with the health systems approach. And I'm an Indian first, I'm an Indian Administrative Service Officer first, and then I come from ADB. My vision to you is, ma'am, and my request to you is, ma'am, how do we help you to do this? You tell us, ma'am, and even when I have worked with Nadda ji, I can go and tell him, "Zar ye karna hai humko." And Luchika, when she speaks, she doesn't let anybody else speak. So that's why I asked Dodo to speak in the inaugural so that Dodo can match her, because nobody else can match her here. So it's only Dodo who can match Luchika in giving a story and giving her back. But my pain point is, ma'am, we are ready with concessional financing. Here are your 3 of the best innovators sitting there. Here is a innovative financing guy who wants to give us some catalytic financing to work with you. Stop TB is sitting here. Tell us, what do we need more to finish TB now, to eliminate TB? This cannot be a business as usual. We are here to support you, ma'am. And I need you to come here with the mic and tell us.
So I join you on so if you ask me, we started with the vulnerable groups, considering that we'll be able to screen the 80%, which contribute to TB. But frankly, if you ask me, I would like to go and do mass screening. Screen everyone and find TB early. With the screening tool that is approved, that is 94% sensitive for screening, Confirmatory with our NATs, TrueNAT, we have the gene expert, we have some new ones coming. The strength will be there. And X-rays, we have the AI, we have Fujifilm, we have at least 8 more manufacturers offering us handled X-rays. And we tendered from the program, there's support from the partners, Global Fund, others who are contributing. So we will get there, sir, but not without your support and not without the support of the Mr. Nadda, our PM. The drive towards mass screening of a 150,000 crore population is not going to be something simple. But when we can vaccinate with COVID vaccine, this huge population, we can definitely screen them. So,
Ma'am, I don't want you to go away from here because I need something. I need a commitment from you. Can Luchika, Dodo, and sorry, not Madhu Joshi, from WHO, Rijal, because Samia is not here. Can we go back, come up with a plan, what we understand, and then give it to your scrutiny and come up with this, hey, for this screening, ending TB, and this medication, we did talk about, I was there in the session yesterday, we were talking about newer vaccines coming. Whenever they come, they get validated, we will start giving this, and we will support you in that policy advocacy for avoiding any hesitancy there. Can we come back to you with a plan and saying this is required, this is things are required, and then we work backwards, how do we get those resources?
Can I say something?
Yes, Luchika, come here. You can't stay from there, you have to come here.
We don't do the plan us. Honorable professor here, she has the plan.
Okay.
She knows exactly what should happen. I think, right?
Yeah.
And
she
where?
will need your support. She will
Yes,
need our
yes.
support.
She has the plan. She'll come to all of us to say, you were all of you here, and I need you now to step in. WHO with whatever WHO does the best, Stop TB with whatever we do the best, and the bank with whatever do the best. That's what I wanted to say, that I think that's the narrative we need to change. And I know that you meant that because you come from India and India is already there, is having the country to drive. Because then you own it. And I was very impressed you started with the screening and the vulnerable.
Yeah.
Because indeed to find everybody to have access to the screening and to diagnosis and to treatment will be a hell of a job, because will not be people like us, will be people that for whatever reason have a barrier to access services, and that will cost money and needs to be done in a different way. But I think, I have no doubt India has the plan. I think it will be us to help to go at scale, and that's exactly the challenge. And by the way, the only thing, and you said right, if I speak, I don't stop. Indeed,
No,
in TB,
I didn't say that.
In
You
TB,
speak so well that nobody else can speak. You
no,
so only
no,
Dodo
don't.
can match you.
You can say whatever, I am fine. I wanted to say that in TB, indeed, finding the people with TB is the biggest challenge.
Yes.
I think once we find everybody, diagnose, and we are able to treat. I mean, you know, we are able to enroll. We don't hear that much of waiting lists, but to find and diagnose, that's the challenge, especially with the things we said here. And the other thing we have here, 3, 4 amazing on the innovation. We need much more. So that will be important.
And the vaccine you initiated, let me complete. I believe if the M72 failed, or for us it's failed because the grapes are sour. We're not getting it in India soon and anytime soon. I believe we should look at what we have. So we initiated the BCG implementation study, which was again in the vulnerable population, where if I quote this paper from NEJM, which shows 45.4% protection, 2023. If we go to our vulnerable population and the BCG revaccination, it's an adult revaccination where we are boosting the BCG, which was given at the baseline. If we show protection, then we'll be the first ones to show that protection. So again, there were several naysayers who objected to the design and why are you doing it? There'll be no protection. But we hope to get some outcome. We also believe that if we use some BCG booster molecules, possibly we could have some, breakthrough. So mass screening and vaccine. If we have these two, we are there. So with partners, I think we can look forward to M72s coming our way. As of now, they're not. Any other vaccines? Yeah, we'll be able to implement them soon with the kind of experience we've generated over the past. We've immunized more than 1 crore, that's 10 million of our vulnerable population across the country. Again, consent and such hesitancy were issues, but then nevertheless it's a big achievement.
Absolutely, ma'am. Thank you so much. And I think the idea here is, ma'am, to work with you when you are here and support you in whatever best we can do. In one voice, we go to the political establishment to say that this is the map, this is where we can do, whether it's 2027, 28, 30, come up with a realistic plan. We know the landscape is evolving, technologies are coming, more technologies will come, especially on the vaccine, because there we are lagging. When Mr. Bahal said that it may come on time, my remark was it's already 2 decades late. Yeah. But let's get it now. Whatever vaccine WHO validates, I think we will be happy to support and immediately move on. And I think the people sitting in this room, and it's not about, you know, I come from the government and people say, "Acha, private se kyun baat kar liya aapne? Unka kyun machine le liya?" Let's sit down as a partner here, ma'am, and see what is the best way out. You know, Dodo will bail me out. We are technology agnostic. We don't talk about X, Y, Z. We talk about the product which is validated. We procure them on competitive basis so that there is never an issue of any favoritism. But let's sit down, plan this, support you, and let's see how far we can go in this journey. Ma'am, I will let you know that Philippines, where Dodo's country, so it's Dodo's country versus Dinesh's country. So Philippines is actually saying 24th November, let's announce something big when they want to do a board meeting in Manila. Indonesia is perhaps much ahead and they are actually going forward. They have already done one such big project with World Bank and they are looking forward to eliminate TB. I think India with its everything check marked, tick marked, should actually move more faster than what it is doing that. That's all I request. Thank you.
Do you have any doubts that India will be leading?
Absolutely.
I have none.
Yeah. Thank you.
No.
Okay, that's a great note to really that challenge and the commitment that we will. I mean, that's something. Maybe just 2 quick thoughts. One, it's wonderful to have this ability to challenge each other and to really move forward. Number 2, it cannot be just India and just Philippines. I think what we want, certainly every country in this region. So here's what I'm going to suggest. One, it'll be really good as a part of the partnership for everybody to come together to think about how do we bring this ecosystem approach where we are looking at technical, where we are looking at political, where we are looking at technology, innovation, community, and the whole financing, the private sector certainly. How can we do that? And look at what will it take to end tuberculosis in Asia. And that becomes a model not just for Asia, but for the world. And that is something which I know we'll have an opportunity at the World Health Assembly. Yes. And maybe to bring together a set of us coming together to work for that and then be able to actually build that economic case and the political case, because the rest will come, the finances will come. So thank you very much. It's been, I know that, I don't know how many of you are going to see Ricky Cage. Maybe I might be getting the name wrong. And for dinner. So that is what the bell was about. So have a wonderful evening. Thank you very much. There are so many people who really helped to pull this together, from Asta to Dr. Srinivas to Anand, who is not here, and everyone here. So really want to thank you. Thank you very much. Okay, so a group photo is part of the tradition. So if I may ask all the panelists and everybody here. Quick picture and then we can have a
bouncing.
Yep.
Not everyone should stand.
Okay, one quick picture and then we'll have an opportunity to interact. Sorry.